So that was Medicover Cancer Institute, ladies and gentlemen. Wow, that was truly amazing. And we just witnessed an iconic oncology healthcare at the heart of Madhapur high-tech city. Indeed, a state-of-the-art healthcare designed for enriching experience. Now, I will request Dr. Ravichandra Veligeti, Senior Consultant, Surgical Oncology, Medicover Cancer Institute, to kindly please come onto the stage and present the welcome address and to also share insights about today's program with all of us here today. Over to you, sir.
A very warm morning, everybody, and warm wishes from Medicover Cancer Institute. As you have witnessed, facility available. That's the state-of-the-art cancer institute in the heart of Hyderabad, catering to each and every modality of treatment that is available in cancer. And to further share our knowledge and enhance visibility, we have devised this conference particularly targeted at gynecologists, because this conference was born out of what we can say is multiple questions or multiple doubts what the gynecologist keeps asking us whenever they are referring a case, or whenever they encounter a case, they would call and ask us a few doubts about how to manage those cases. So keeping those topics in mind, we thought we'll clear all those doubts and give you a brief overview of definitive management of multiple cancers. So that's the idea behind the conference. So I welcome you all to this conference, and going forward, whatever topics we have chosen were chosen which are of practical importance and which will help you in guiding your patients for your treatment. So once again, I give a warm welcome to all of you to the Medicover Cancer Institute, and we'll start the conference with the first talk.
Thank you so much, Dr. Ravichandra. Thank you for the insightful remarks. And yes, that has truly energized all of us here today, and we are ready for the seminar, for the program. Now let's move on to our first session, which is session 1, endometrial cancer. Session 1 is divided into 2 sessions, general session followed by the oncology session. Now I'd like to invite our chairperson, Dr. Sharda, Senior Consultant Gynecologist, for this session. I request Dr. Sharda to please come onto the stage. I request Dr. Amit Jodwani, Senior Consultant, Radiation Oncology, Medicover Cancer Institute, to please join us in felicitating our chairperson, Dr. Sharda. Yes.
ఫోటో కావాలని వెళ్ళి తీసుకోవచ్చు, వీడియో నాకు కంటిన్యూ ఉంటుంది కాబట్టి కష్టం.
Promoting the green environment. Thank you so much, sir. I would now like to invite our next chairperson, Dr. Aruna, HOD, St. Teresa's Hospital, to please come onto the stage and take seat. I request Dr. Praveen, yes, Adusumali, Dr. Praveen Adusumali, are you here? Okay, sir, would you like to do that? Thank you so much, sir. Thank you, ma'am. You may please take your seat. We have our chairpersons ready, seated here on stage for the session. So let's move ahead with our first segment, which is the general session. To start with our first presentation, I'd like to invite Dr. Savita Rathod, consultant gynecologist, Medicover Women and Child Hospital, to please come onto the stage and give us insights on identifying red flags in a patient with premenopausal bleeding, a guide to work up. So I request Dr. Savita to please step forward.
Good morning, everyone. At the outset, I would like to thank the organizing committee for giving me this opportunity. And also, I would like to thank all of you for being here on this Sunday morning. The 40s in the women are often a time of hormonal turbulence, and the fluctuating sex hormone levels can cause various symptoms in women. The irregular menstrual cycle that a woman experiences is the focus of today's topic. So my topic today is identifying red flags in a patient with perimenopausal bleeding and a guide to workup. Hello everyone, I am Dr. Savita Rathod, working as consultant gynecologist and obstetrician at Medicover Women and Child Hospital. During my talk, I will take you through what is perimenopause, understanding perimenopausal bleeding, the red flag signs, the possible causes of abnormal bleeding, the clinical evaluation, and 1 or 2 case scenarios if time permits. So, what is perimenopause? Physiologically, perimenopause is the period in which the ovulatory function begins to wane and ovulation becomes unpredictable and less frequent. So it is defined as the transition period leading up to menopause and 12 months of amenorrhea after the last period, marking the end of a woman's reproductive life. And it can last 4 to 10 years, and it is characterized by various symptoms including irregular menstrual cycle, hot flushes, night sweats, mood changes, vaginal dryness, and so what is perimenopausal bleeding? The irregular menstrual cycle that women experiences during this transition period is known as perimenopausal bleeding, and it ranges from 40 to 50 years of age, and it is marked by changes in flow, frequency, and duration. Why is it important to identify perimenopausal bleeding? So it is important to identify and manage abnormal bleeding during menopause to prevent complications and addressing underlying conditions, more importantly endometrial hyperplasia and carcinoma. So what is a normal menstrual cycle? Normally the menstrual cycle is described according to the 4 specific components of frequency, regularity, duration and volume. And earlier, the frequency normal is between 24 to 38 days. Cycle regularity between the shortest and the longest is considered to be less than 7 to 9 days, and the duration of the bleeding is less than 8 days, and volume is determined by the person, and it is anything that affects the quality of life. So any variation from the parameters of a normal menstrual bleeding constitutes abnormal uterine bleeding. And this abnormal uterine bleeding could be abnormal menstrual bleeding, which constitutes the heavy menstrual blood with or without pelvic pain, or any pressure effects on the gastrourinary or the gastrointestinal tract. Or the non-menstrual bleeding, which compromises, which constitutes the intermenstrual, postcoital, or the postmenopausal bleeding. So, perimenopausal bleeding, it can be a normal part of a transition to menopause, but certain signs should prompt us further investigation, and as they might indicate more serious conditions. So the red flag signs include heavy bleeding, that is soaking through 1 or more pads or tampons every hour for several hours, prolonged bleeding, bleeding lasting for more than 7 days, frequent bleeding, cycles occurring often less than 21 days, intermenstrual bleeding, bleeding that is bleeding between the periods, postcoital bleeding, bleeding after the intercourse, and postmenopausal, any bleeding occurring after 12 months of amenorrhea, severe pain which is different from the usual menstrual cramps, signs and symptoms of anemia, any unusual discharge which could be abnormal or foul smelling. And so moving ahead, talking about heavy menstrual bleeding, the NICE defines heavy menstrual bleeding as any excessive menstrual blood loss that interferes with the physical, social, emotional and or material quality of life. Earlier, it was thought that any volume more than 80 ml or depending upon the pictorial blood assessment chart, we would determine the amount of blood loss, but that is no longer accepted by the FIGO, and it defines it as any blood loss which affects the quality of life. And the prevalence of AUB, it is a chronic, common, debilitating condition for women worldwide, and it is seen that in about 1 in 20 women aged between 30 to 49 years reach the OPD for their consultation. And it affects 40 to 25% of the women of reproductive age and is one of the most common reasons for gynecological consultation. So as you can see, the women in the age group of 45 to 49, almost about the women reaching OPD, about 5% of them seek opinion for heavy menstrual bleeding. And the causes of heavy menstrual bleeding, as you all know, FIGO has created a system to categorize this, and this is described by the acronym PALM. And there are 9 categories which represent the causes of the non-gestational AUB. So, considering the pregnancy is excluded, the following are the main causes of AUB. In general, the structural causes that is described by the acronym PALM indicates P stands for polyp, endometrial or cervical, A for adenomyosis, L for leiomyoma, M for malignancy, which also includes pre-malignant conditions. So this PALM, the structural causes of the AUB, these are the discrete entities which can be identified either by imaging or by histopathological diagnosis. Whereas the non-structural causes of AUB, which is defined by COIN, that is the coagulopathy, example 1 milligram thrombocytopenia, patient on warfarin, ovulatory dysfunction like PCOD, hypothyroidism, hyperprolactinemia, Cushing's, CAH, E for the endometrial disorders like endometritis, I for iatrogenic like exogenous sex steroid administration or any intrauterine device or traumatic uterine perforation, and not otherwise classified. This point, that is the non-structural causes, are not determined either by imaging or by histopathology. So we need to evaluate the patient with perimenopausal bleeding, and the evaluation would include the history, examinations, investigations and the diagnosis. Moving to the history, it should include history pertaining to define the nature of bleeding, which includes the patient's age, menstrual or non-menstrual, including postcoital, postmenopausal or intermenstrual bleeding, subjective assessment of the menstrual blood loss, whether it is affecting her quality of life, any alteration in the menstrual cycle, any associated pelvic pain or pressure effect, if the woman has taken cervical smears up to date, and any family history of gynecological pathology. It should also include symptoms that may indicate pathology, like for fibroid, it can present with pelvic pain, mass pressure effect, or any obstructive symptoms. Similarly, for adenomyosis or endometriosis, the women can have cyclical or non-cyclical pain, dyspareunia, dysmenorrhea, or infertility. And also, there are certain symptoms which indicate any coagulation disorder. And it is also important to identify the pathological effects, like effect of HMB causing anemia, or pelvic pain, or impaired quality of life. And also we need to know the treatment expectations from the women, as there could be concerns and needs for future fertility and contraceptive wishes, need for definitive treatment when offered treatment alternatives. So all these history need to be taken while examining the patient, and also coming to the coagulation history, the presence of all the three domains on a clinical questioning is highly predictive of hemostatic condition, and that could be contributory or causal to AUD. And this indicates the need to perform certain specific investigations to rule out any coagulopathy. So it should include heavy menstrual bleeding since menarche, any one of the following, that is the postpartum hemorrhage, surgical related bleeding or bleeding associated with dental work, 2 or more of the following symptoms: bruising 1 or 2 times a month, epistaxis 1 or 2 times a month, frequent drum bleeding, and family history of bleeding symptoms. If all the three domains are present in the history, then it is highly suggestive of a coagulation disorder. And it is reasonable to undertake a clinical examination in a patient where there is uncertainty or overdue cervical screening or underlying pelvic infection. Suspected structural pathology, that is the palm part of the palm point classification, wherein the women can present with intermenstrual, postpartum or postmenopausal bleeding, weight loss or weight gain. Suspected coagulopathy as symptoms described earlier, and suspected ovulatory dysfunction, wherein the women can have signs and symptoms like acne, hirsutism, and acanthosis nigricans. So the examination should include general examination, abdominal, and systemic examination. The general examination should begin from the vital signs including the blood pressure and the BMI. Look for the signs of pallor like skin or mucosal pallor. Signs of endocrine disorder like any thyroid enlargement or any tenderness. Also for any abnormal hair growth patterns, clitoromegaly, acne, which can indicate hyperandrogenism. Moon phases or abnormal fat distribution or striae, and signs of coagulopathies such as bruising and petechiae. Abdominal examination to palpate for any pelvic or abdominal masses. Pelvic examination, that is speculum or bimanual examination to look for any local pathologies. So the basic investigations include the full blood count, the cervical smear if the patient is not up to date, and pelvic ultrasound is considered for one of the first time investigations in a women with perimenopausal bleeding. And if there are any signs suggestive of infection, genital tract swab testing is essential. So moving ahead to the uterine and endometrial assessment. So uterine evaluation is important, and if there are history suggestive of high risk for hyperplasia or neoplasia, considering obesity, polycystic ovarian syndrome, unopposed estrogen, age over 45 years, nulliparity, late menopause, patient on tamoxifen, there's a family history of breast and colon or endometrial cancer, or other risk factors like diabetes and hypertension, then if such risk factors are present, then office endometrial biopsy can be offered as a first-line investigation. And if the specimen is adequate and it denotes atypical hyperplasia or carcinoma, then it should be managed as AUBM. However, if there is an increased risk of structural abnormality, or on office endometrial biopsy there is no adequate specimen, then we can go for a transvaginal ultrasound, and if the cavity appears normal, it could be presumed to be caused by an endometrial or an ovulatory dysfunction. However, if the cavity shows any lesion, then either a hysteroscopy or a saline infusion sonography can be performed. And if any target lesion is identified, it is classified as AUBL or polyp or adenomyosis. However, if the target lesion cannot be assessed, then MRI can be considered. So the transvaginal ultrasound, it is one of the modality of the investigation which helps us to determine what to be done next. And the thickness of the endometrial stripe, it can be measured very accurately by the transvaginal ultrasound. As a minimum screening test, endometrial biopsy is required if ET is more than 4 mm, that is if it is 5 mm and above in postmenopausal women, or 16 mm in premenopausal women. However, there is certain discrepancy with different guidelines, as ACOG defines it as 12 mm. So in the premenopausal women, depending on the history, the call can be taken. And also, it can be selectively performed in postmenopausal women if the ET is less than 4 mm, but there are other history or any sonological risk factors present. And saline hysteroscopy, combined with the endometrial biopsy, it improves the sensitivity and specificity compared with either test performed alone. And it can be considered as a first-line investigation in women with high risk of endometrial malignancy or symptoms suggestive of endometrial polyp. And the endometrial biopsy can be taken either under hysteroscopic vision or in blind manner, sampling all the surfaces of the uterine cavity. Saline infusion sonography, it provides better visualization of the uterine and the endometrial pathology, and it involves infusion of the sterile saline through a soft plastic catheter in conjunction with the transvaginal ultrasound. And endometrial pipple sampling is another mode of investigation wherein a fine-bored plastic instrument with a curette-like tip can be inserted inside the uterus and a sample from all the quadrants can be taken. And it can be performed with or without local anesthesia. So as you can see, the hysteroscopy and biopsy has a specificity of 99.2% and the positive predictive value of 100 and negative predictive value of 99.5. And so it should be considered wherever possible to go for hysteroscopy and biopsy. And there are certain supplementary investigations like MRI, saline infusion sonography, pelvic infection screening, or testing for von Willebrand disease if the history, if there is any history suggestive of any of these disorders. Moving on to intermenstrual bleeding. Intermenstrual bleeding is any bleeding that occurs outside of the women's menstrual period, and the incidence in perimenopausal women is about 24%. While that in the reproductive age is about 13 to 21%. And it is a symptom which and it can also include postcoital bleeding. Postcoital bleeding can although be a benign cause, but it can result in significant distress in women, and it is commonly known and accepted symptom of cervical cancer. So the causes of intermenstrual bleeding can be based on the anatomy. It can arise from the ovaries, wherein the women can have spotting at the time of ovulation. Uterine causes, it could be iatrogenic because of the hormonal devices, or it could be infective as in endometritis. Benign causes like polyp, adenomyosis, fibroids, or it could also represent malignancy. Coming down to cervical causes, it could be following any examination or a smear test, or any infection as cervicitis, or benign causes like ectropion or a polyp, or it could also indicate malignancy. Similarly, coming to vaginal, it could be a cause of infective or malignant vaginal cancers. So, in a woman with intermenstrual bleeding, initial assessment, medical history and examination are equally important. Examination should include speculum examination to rule out any vaginal and cervical lesions. Cervical smear is indicated in women depending on her history, and if it shows any pathology, colposcopy can be advised for these women. Swab for STI screening and imaging according to the history. And so, depending on the cause, we investigate these women. If there is any history suggestive of infection, swabs can be taken and appropriate antibiotics, antiviral, antifungals can be advised. If it is an iatrogenic bleeding or a breakthrough bleeding secondary to any examination or smear, we can either alter the dose or type of hormone administered or add tranexamic acid. And if there is any structural pathology, treat the cause in accordance to the guidance. And if it is because of the ovulation, then just reassurance would suffice. However, if there are any structural pathologies which indicate pre-malignancy or malignancy, then it should be adequately investigated and if required, referred to the oncologist. And postmenopausal bleeding. Postmenopausal bleeding, it accounts for approximately 5% of the office gynecological visits, and 4 to 11% of this bleeding occurs in approximately 4 to 11% of the postmenopausal women. And there are various causes of bleeding in postmenopausal women. Most commonly it is because of the endometrial atrophy or because of the endocervical or endometrial polyp. And so in a patient with postmenopausal bleeding, 96% of the women will have an endometrial thickness of more than 4 mm, and there is a risk of 1 to 2% if the thickness is less than 4 mm. So in a case of postmenopausal women, ultrasound testing is essential, and if the endometrial thickness is less than 4 mm, if the endometrium appears homogeneous and there are no risk factors for carcinoma, expectant management is advised, and if there is no recurrent bleeding, no further intervention is required. However, if the endometrial thickness is more than 4 mm with risk factors for endometrial carcinoma, or there is recurrent bleeding when the ET is less than 4, then we advise hysteroscopy and biopsy. And if it shows atrophy, then no further intervention is required. If there are any benign findings, treat the pathology, and if cancer is identified, refer to the oncology. I have just one case to discuss. So this is a 49-year-old woman who presented to the OPD with worsening period. Her cycle varies from 21 to 28 days in last 7 days. She is on HRT since 7 months. She has had 2 normal deliveries and her partner has had a vasectomy. So investigations included a full blood count which was suggestive of anemia, a normal PSH and normal cervical screening test. Ultrasound was done which showed ET of less than 7 mm. In a patient who's on HRT, it is essential to go for the history and the examination and determine which HRT regimen the patient is on and the duration of this. If the patient is on sequential HRT and she is experiencing heavy, prolonged or breakthrough bleeding in more than 2 cycles, and if the ET is more than 7 mm, then endometrial biopsy and hysteroscopy is essential. However, if the ET is less than 7 mm, then only observation can be carried on. If the patient is on combined continuous HRT and if the duration has been less than 6 months, then no further, if there are no other risk factors, reassurance would suffice. And however, if the woman is on continuous HRT for more than 6 months, then ultrasound is suggested. And if the ET is less than 4 mm, then it is an ectrophic endometrium, and if it is more than 4 mm, endometrial biopsy with hysteroscopy is advised. Just a word on what if a woman is on tamoxifen. So tamoxifen also stimulates the endometrium and it increases the risk of endometrial cancer, but transvaginal ultrasound in a woman who's on tamoxifen could be misleading, and it can cause subendometrial cyst which makes the endometrium appear thickened. So tamoxifen therapy therefore invariably causes a thickened endometrium and it should not be used as an investigation of choice. Hysteroscopy is recommended for a patient who's on tamoxifen.
Thank you so much, Dr. Savita Rathod. We are indeed running short of time. There are so many other speakers, dignitaries in the world waiting to give away their presentation. I request the chairpersons to please add their remarks.
Dr. Savita, you have spoken everything about AUP. That's so nice. You have covered all the topics of AUP. But I think the red flag symptoms which we wanted to know are that any obese women or anyone with endometrial bleeding, they come and say that first cycle we are having heavy bleeding. But still, if the endometrium is very thick on an ultrasound, we should not dismiss them as a normal thing and we have to evaluate. You told that very well. Thank you.
Thank you. Other red flags will be any foul smell in discharge. That you have to address. The biovector is also common. Okay, in atrophic endometriosis, what is the treatment of choice? You cannot just ignore if they present with a postmenopausal bleeding.
Postmenopausal bleeding if a woman has an ET less than 4 mm, and however, if there are certain risk factors of malignancy, then we would certainly evaluate and if the histopathology comes out to be negative, then we would just reassure. However, if the ET is thin but there is still endometrial fluid, we would keep her on follow-up. And if the ET is more than 4 mm, then biopsy, and if depending on the report goes the treatment and the referral.
Thank you so much, Dr. Savita Rathod. I request Dr. Shaka Rao to please felicitate Dr. Savita Rathod.
Thank you everyone.
With the memento. You can also take a photo opportunity. Both our chairpersons are doing the honors.
అశేఖర్ అతను చెప్పు అశేఖర్
Thank you so much.
వెనక చూసుకోమని చెప్పు.
Thank you so much. Yes, ladies and gentlemen, we have another session going on. We move on to our next presentation. I'd like to invite Dr. Lakshmi Manasa, Perkota, consultant, oncopathologist, Basavataram Indo-American Cancer Institute and Research Center, to throw light on behind the microscope, harnessing immunohistochemistry and molecular testing to revolutionize endometrial cancer diagnosis and treatment. Consultant in Medicover Hospital. All right. Thank you so much, ma'am, for correcting that.
Good morning everyone, I'm Dr. Manasa, I'm consultant pathologist. Today I will be briefly discussing regarding the role of IHC and molecular testing in endometrial cancer diagnosis and treatment. Though the title says cancer, I will be mainly discussing regarding endometrial carcinoma because of the time constraints. So this is the outline of my talk. I will briefly discuss about the histological classification of endometrial carcinoma, role of IHC, and briefly regarding molecular classification of TCGA, the additional biomarkers which have come up after TCGA classification, and how to use this, how to come to this molecular classification in clinical practice. So this is the WHO 2020 histological classification of endometrial carcinoma. It's classified as endometrioid type, which is type 1, and other carcinomas like serous, clear cell, mixed. All these come under type 2 carcinomas. The rare carcinomas are undifferentiated, dedifferentiated carcinomas, carcinosarcomas, squamous cell carcinoma, and the two recently described entities which have been added in WHO 2020 classification is the mesonephric type and the gastrointestinal mucinous type. So once we receive the specimen, our first job is to do a proper histological classification and grading. So the grading is mainly done only in endometrioid carcinoma. There are 3 grades depending on the solid component in the tumor. The other tumors are by default high-grade tumors. So it is important to classify and grade the tumor because these are the important determinants of prognosis and treatment. But studies have shown that the microscopic diagnosis of endometrial carcinoma is reproducible among the low-grade tumors, but there is considerable interobserver variability in a subset of high-grade carcinomas. This leads to imprecise estimation of the risk. Here comes the role of immunohistochemistry, which is a vital tool in differentiating various histologic types, and sometimes even we can predict the molecular subtype based on the immunohistochemistry, which is a simple test available throughout all the laboratories. So these are the markers which we use for histological typing. The PAG site is a marker which indicates Mullerian differentiation. It comes positive in almost all the tumors of female genital, carcinomas of female genital tract, the adenocarcinomas, except the undifferentiated carcinoma where the PAG site expression is lost, and in the mucinous type, gastrointestinal carcinomas, which loses the Mullerian differentiation and shows intestinal differentiation. And you all know the role of P53 in diagnosing serous carcinomas and the role of hormonal receptor in diagnosing the endometrioid carcinomas. So not only histological subtyping, it can be predicted. So if the tumor is P53 positive, most of them are serous carcinomas. MMR testing can be done by IHC, and MMR deficiency is only in endometrioid carcinoma. So if there is MMR deficiency, it is an endometrioid carcinoma. And then if the tumor is wild type, tumor do not show P53 mutation and do not show MMR deficiency, and if it is strongly hormonal receptor positive, it indicates it is a copy number low molecular subtype. I'll discuss in detail in further slides. So in 2013, the Cancer Genome Atlas have come up with this molecular classification where it has categorized the endometrial carcinomas into 4 subtypes: the pole mutated type, microsatellite instability type, copy number low type, and P53 mutated type. The pole mutated type has a very good favorable prognosis. P53 mutated type has very poor prognosis, and the microsatellite instability, copy number low type groups have intermediate prognosis. So the integration of morphology, immunohistochemistry, and the molecular subtyping provided more accurate prognostic information, and the molecular classification proved to be more reproducible than histopathological classification. Hence, it improved the current clinical management for the endometrial carcinoma patients. But there are some challenges that this classification is difficult to be applied in a routine clinical practice because the TCGA group, they have used high-end techniques like whole exome sequencing and microarray technologies which are not widely available. And we do not have much data about the rarer subtypes like the mesonephric type, the gastrointestinal mucinous type, which have been described recently. And also there is a problem called multiple classifiers. So 3 to 6% of tumor, they show multiple features, like tumors can show a combination of pole, which is a favorable prognostic type, and P53, which is an unfavorable prognostic type. Then what to do with this kind of tumor? So the recent studies have shown that the pole mutation supersedes MMR deficiency, and that supersedes P53 abnormality. That means if the tumor is having both pole, P53 and microsatellite instability, the tumor behaves like a pole mutated tumor rather than the MSI deficient, microsatellite unstable or P53 abnormal tumors. So to use this classification in routine clinical settings, some other groups have come up with a classification which using immunohistochemistry and targeted sequencing rather than whole exome sequencing. One such thing is the PROMISE algorithm, which can be done on formalin fixed paraffin embedded material with low cost, enabling easy translation into the clinic. So this uses IHC for P53, and for MMR deficiency also IHC is used. For whole exonucleus domain mutation, hotspot sequencing is used. So this almost similar classification is adopted by WHO, the European Society, and the NCCN, where the algorithm starts with pole sequencing. As I have said, pole sequencing supersedes, the pole mutation supersedes the other mutation. So first they have suggested to start with pole sequencing. If the mutation exists, pole mutation exists, it is a pole mutated tumor. If there is no pole mutation, the next step is to do the MMR IHC. If it is deficient, it is an MMR deficient tumor. If it is proficient, the next step is to do P53. If P53 is mutated, it is P53 abnormal tumor, and the remaining tumors are the non-specific molecular profile tumors. So they have encouraged molecular classification in all the endometrial carcinomas. However, the studies have shown that the impact of this molecular classification is principally on the intermediate to high risk, the patients which fall under intermediate to high risk group based on the conventional histopathological classification. So if we see the table, the stage 1 and the tumors, the thing which is underlined in red color. So the stage 1 tumors which are high grade as well as stage 2, they are coming under intermediate and high intermediate risk. But if we know that they are all mutated, now if we include the molecular classification, they are coming under the low risk. So mainly the impact is on the intermediate and high intermediate risk groups, and the small molecular classification did not add much prognostic value in the low risk group because anyhow it might not need accurate therapy. So for practical purposes, testing can be done on high risk patients depending on the conventional histopathological findings. So coming to each molecular subtype, the pole mutated type accounts for almost 10% of the endometrial carcinomas, and these have very high mutation frequency, more than 100 mutations per megabyte. Morphologically, they resemble endometrioid grade 3 tumors, or they can show ambiguous morphology. Like on morphology, we cannot identify it is an endometrioid, or it is a serous tumor, or a serous carcinoma, or a clear cell carcinoma. So they show ambiguous type of morphology, lot of tumor infiltrating lymphocytes. The prognosis is excellent, and the pole mutated tumors can be diagnosed only on DNA sequencing, either Sanger sequencing or by next generation sequencing, and these tumors show high tumor mutational burden. One thing we have to note is there are so many pole mutations described, but there are only 11 pathogenic pole mutations, and these are mainly occurring in the exon 9, 11, 13 and 14. Mutations other than these 11 mutations, the significance is not known. So while interpreting a molecular report, we have to keep in mind that other pole mutations other than these 11 do not have any significance. The next one is the MMR deficiency type, which accounts for 25 to 30% of endometrial carcinomas. They also show a large number of mutations and high tumor mutation burden. Morphologically, they appear like endometrioid grade 3 tumors. They show substantial LVSI, lot of tumor infiltrating lymphocytes, involvement of lower uterine segment. They show intermediate kind of prognosis, and the diagnostic test is by either by IHC or by microsatellite instability PCR. So the IHC is preferred test over PCR because it is cheaper, has less turnaround time, it is more accurate, and there is less chance of test failure compared to the microsatellite instability testing. So MMR by IHC is the preferred test, at least in endometrial carcinomas. So this is how I'm not able to use the pointer, but if we see the corner left image, that is a normal IHC expression. For there are 4 MMR proteins. So if we order for MMR IHC, we do 4 IHC markers, which is MLH1, MSH2, we do 4 proteins in the panel, MLH1, MSH6, MSH2 and TMS1. So these are dimer proteins. The two proteins, they exist as dimers. And this is how a normal, that is, this is normal expression. All the cells are showing the nuclei stained brown. So here the MMR genes are functioning. They are produced with the MMR proteins, which we are able to see on the IHC. Whereas if we see the bottom right side image, this is how we see when MMR deficiency is there. That is, the tumor cells are not showing the expression of MMR protein. In this case, it is TMS2. So we test for 4 markers, and this is the algorithm which we use. So there are four IHC markers. If there is loss of 3 markers, the 3 markers means any one marker can be lost. Anything apart from MLH1, if the other 3 markers, any one of them is lost, it is most likely because of a germinal mutation, and patient has to go for genetic counseling. Whereas in case of MLH1 loss is predominantly because of sporadic mutation. because of MLH1 hypermethylation. So MLH1 hypermethylation testing should be done. If there is MLH1 hypermethylation, it means it is sporadic event, and genetic testing is not needed. Whereas if it is negative for MLH1 hypermethylation, again patient has to go for genetic testing. We all know the implications of MMR testing in the management of endometrial cancer. It is diagnostic, used as screening to identify Lynch syndrome patients. It has prognostic significance. It has predictive utility for immune checkpoint inhibitor therapy, as well as there is no clear benefit of adding chemotherapy in this patient. So the third one is the P53 mutant type, which accounts for 15 to 20% of all the endometrial carcinomas. This usually shows serious kind of morphology on microscopy, but what we have to remember is 5% of grade 1 to 2 endometrioid carcinomas also fall under this category. So if we do not do molecular testing, there is a chance of mismanagement of these patients. So, and these show poor prognosis, and P53 mutation can be assessed by IHC. The IHC and molecular testing show very high level of concordance, so it can be easily done by using IHC. So P53 IHC, if you look at the pathology report, it should not be written like positive or negative, unlike any other IHC markers. So P53 is interpreted like whether it is mutant type of expression or it is wild type of expression. So the lower left box is the normal expression, that is there is patchy, variable positivity of the tumor or normal tissue nuclei of the cells. Whereas if it is mutant, there are three types of expressions. The upper right one is the overexpression type, that is all the cells show a very intense nuclear positivity. Whereas the upper left, it is the null type. It is like all other phenomenon, the cells do not show any positivity. The lower right one is the cytoplasmic expression. So these are the types of mutant expression, and P53 report should be like mutant expression or null expression, not positive or negative.
We are running out of time, Dr. Lakshmi.
Yeah, I can conclude. Yeah. So the last one is the no specific type, which is the diagnosis of exclusion, and this is a heterogeneous group. The prognosis variable. So the studies have been going on to assess further biomarkers beyond TCGA. So this is the list of biomarkers which have come up recently. The most important among them is the ERPR receptor. It is mainly significant among the non-specific molecular subgroup where positivity of estrogen it reduces the risk of recurrence. Other markers are beta-catenin, L1-CAM, HER2/neu. The scoring of HER2/neu is little different compared to the scoring of HER2/neu in breast tumors. These are other biomarkers so just one slide. This is how we can apply the molecular testing in a practical setting. So we can't send for DNA sequencing in all the cases. So we can select the cases for which DNA sequencing for cold testing can be done. So it is better to do MMR, P53, ER-IHC on all the cases. If there is any abnormality in MMR and P53, so these cases should be sent for cold testing because there is a chance of it being multiple classifiers. So if these two are negative and it is a low risk tumor, that is group 2, cold testing is not needed because anyhow they don't need adjuvant therapy. Then again in high and intermediate risk group, cold testing is needed. And in locally advanced and metastatic, again the cold testing is not needed because it will not change the management. So to summarize, morphological features are alone are imperfect for precision medicine, and in near future you may expect pathology reports showing an integrated histomorphological and molecular diagnosis, like already it is happening in the CNS tumors. Combining standard algorithm with additional ISC and molecular testing provides potential for a new range of therapeutic options, and if you see the bottom markers, only beta-catenin and fold. It is the sequencing techniques. All others can be done by IFC. So we can expect this sort of thing in near future. So right now it is not a validated algorithm. And I thank Medicover Hospital and the organizers for this opportunity, and I thank all the delegates for paying attention.
Thank you, Dr. Nancy.
Yeah, all this is required for new FICO 2023 classification. Apart from surgical, anatomical, we require the histological, molecular staging, so for the prognostic stratification. So in the low grade, if there is aggressive or non-aggressive with the P53 mutations, we upgrade the class. And the treatment will be adjuvant therapy. Right? Thank you.
We all should know this because Google has come and patients are coming back in
Dr. Lakshmi, request you please remain on stage. Dr. Lakshmi, please remain on stage. We have to present the moment. Yes, ma'am, you were saying. Please, ma'am.
Yeah, so they are asking in this stage, grade 2. So if they come back and show us grade 2, so it's intermediate risk. Madam, I know it is intermediate risk because Google has told them. So we also should know.
The new classification and the treatment, every gynecologist should also know, so that when they come with the report, we should not always rely on the oncologist, send them back to there. That is minimal justification we have to give to our treatment.
I request Dr. Aruna Garu, chairperson, to felicitate Dr. Lakshmi Manasa. Thank you so much, Dr. Lakshmi. Yes, ladies and gentlemen, we move forward to our session 1, endometrial cancer oncology session. Now, I'd like to invite on stage Dr. Ravi Chandra Veligedi, Senior Consultant Surgical Oncology, Medicover Cancer Institute, to please come on the stage and give his presentation on navigating surgical anatomy, understanding key landmarks and concepts in gynecological cancer surgery. Over to you, sir.
Why don't we have a brief introduction also?
లైవ్ చూపెట్టి సరిపోద్దా అని అడుగు లైవ్ రికార్డ్ అయితే
Yes, ladies and gentlemen, as you can see on the screens, Dr. Ravi Chandra, he is a qualified MBBS, MS, General Surgery, FMAS, MCH, Surgical Oncology, with the designation Consultant Surgical Oncologist and Robotic Surgeon with the experience of 20 plus years. And as we also have mentioned, the education details and the past experience also is being mentioned on the slide.
Sorry for the delay. I think I have some problem running the videos, so we have to reload that. And warm welcome to all of you. Before we go on to the next talk, I think Mansa has talked extensively on molecular testing for endometrial cancers, but what is its implication in the practice? I just would like to ask a few words from Dr. Sarita, medical oncologist, how does it impact our treatment? So without knowing the impact of treatment, all
GNRH or it can be letrozole as well. So this has shown that it prevents, it offers patient some amount of disease-free survival benefit. Then coming to HER2 positivity, again all patients who have a serious histology and those with diagnosis of carcinosarcoma. So in those patients we recommend IDC for HER2 positivity. Because in such cases, again, apart from chemotherapy, we will be also offering HER2-directed therapy like trastuzumab, pertuzumab combination. Then we have lapatinib plus trastuzumab combination. And recently we have trastuzumab deruxtecan, which is showing very significant improvements in the outcomes of the patients. So in metastatic setting, yes, the patient is positive for HER2. Instead of directly offering chemotherapy, we are treating patients with trastuzumab deruxtecan as well. So apart from stage 3, in stage 4 also, if the patient is positive for MSI, then we are offering patients immunotherapy with which patients derive significant benefit. Thank you.
Thank you, Dr. Sarita, for those remarks on blood testing and how it translates into what is called as a precision medicine in oncology. So, coming to my talk, I will be talking about the basic surgical anatomy and landmarks and the different types of hysterectomy and everything, so that you will have a brief idea when they are doing when they are doing different procedures which needs to be done where and how is the anatomy and how do we go about doing it with different kinds of radical hysterectomies in that. Into the first slide, actually, there's we have projected the laparoscopic video so that the anatomy is clear, not the open one, so that everybody can know, can see easily on laparoscopy and not on open. It's difficult to see all these landmarks. So what we are seeing here, once you open the abdomen, you will always see that the sigmoid colon is lying on the uterus. Here we have not used an elevator because in malignancy we don't use elevators because that is one poor prognostic factor because it disturbs the tumor a lot. So what do we do? Instead we use the assistant to retract the uterus. So what we are seeing here is once you, here you can see what you are seeing there. So this is a round ligament, the tube, and this is the IP ligament, infundibulous pelvic ligament. And this is the triangle where you will be doing your lymphadenectomy, pelvic lymphadenectomy. For either cervical or endometrial cancers, we always do pelvic lymphadenectomy. And this is the area which we will be dissecting. And here, at the base of this triangle is your iliac pelvis, the external iliac artery and vein. So this area is important for pelvic lymph node dissection. The next step would be what all the gynecologists are very worried about, that is the ureter. So before you see that's the IP ligament, and once you go into the pelvis, there you can see the blue one. Sorry. So once you lift the ligament and see posteriorly, where you can see the blue thing you are seeing is the extended vein, and crossing the iliac will be the ureter which will be going this way. So where we say the ureter can get damaged at multiple places, the same when it can be damaged while you are trying to ligate the IP ligament. But if you notice it, when you lift the uterus properly and ligate your throat, it will give a long length of IP ligament to ligate. So until unless if your traction is good, if you lift it up good, very unlikely you will be damaging the ureter over this age. Repeating again, this is the round ligament, the tube, and the ovary there, and this is the ovarian ligament which connects the ovary to the uterus. So these are the three ligaments which we need to divide when we are doing a hysterectomy. going anteriorly, you can see this is the anterior leaf of the broad ligament, and when you follow that one, you can see the yellow structure over here. So yellow structure where you see fat, this is the bladder. So always remember a simple point in this one, the fat belongs to the bladder anteriorly. Posteriorly when you go, the fat belongs to the rectum. So as long as you are not seeing any fat on the uterus, that means you are safe. So this is where go good. So you can see all the fat, and once you lift it up, you can see the UV port. You will get a nice UV port where you can dissect. So when we try to go close to the uterus like this, that is when we will not get this plane. So majority of the time what happens is when you are doing an EH, that is open hysterectomy, you start putting your clamps here, and as you go down, it is difficult to separate this UV port. So in a laparoscopic hysterectomy, the technique is a little different, and I will be showing you all that technique in a minute. And posteriorly, there you can see, this is the uterosacral ligament. Like I told you, this part belongs to the rectum, and given a proper traction, the rectum will fall away. You can see the uterosacral ligament. So when you are talking about uterosacral ligaments, so you can see the attachment is here, going around like this. So in a simple hysterectomy, we will be cutting the uterosacrals here, or sometimes we try to preserve the uterosacrals and go ahead. When we are doing a virgin hysterectomy or type 2 radical hysterectomy, you will be putting the uterosacrals at the anterior border of the rectum. So you can see this entire thing is the rectal wall. So this is where you put your uterosacrals. And type 3 hysterectomy, you go as posteriorly as possible and put your uterosacrals there. That is how your anatomy. So I am just moving forward. The next thing which we do, I have shown you where we open and do a pelvic lymph node dissection. This is the anatomy after pelvic lymph node dissection. What we are seeing here is, you can see this triangle, that is what has been dissected, opened up, and here you can see the blue structure is the external iliac vein, anterior to it is the external iliac artery, and this is the obturator nerve, and the internal iliac artery and the ureter. So that is the order of structures when you are coming from lateral to medial. That is external iliac artery, vein, the obturator nerve, internal iliac artery, then the ureter. This is the order when we come from lateral to medial. So, and the uterine artery, where does it arise? It is as you know, it is the first branch of the anterior division of the internal iliac artery. So, the uterine artery usually arises just after the bifurcation. So this is the bifurcation and the internal iliac, and there you can see that is the uterine artery. Now can you see that? So this is the internal iliac artery, and the first division is the uterine artery is coming and crossing over the ureter. And you can see this is the ureter going here, the white structure here. So when we are talking about the ureter, then we talk about the ureter tunnel, where the ureter passes under the, so that's what we call water under the bridge. This is the uterine artery and the water passing under it, and the ureter tunnel. When we do a hysterectomy and all those things, we would assume that it would come directly like this and go on to the uterus. It's not. So it comes higher and goes down, then crosses the ureter in a diagonal manner. It is not a horizontal one. So the ureter tunnel is not something which goes like this. It is a tunnel which goes like this. So that is what you need to keep in mind when you are trying to dissect that area. So this is one view of radical hysterectomy. So as you can see, we are ligating the uterine artery at the origin. So this is for a type 3 radical hysterectomy or the mean hysterectomy. What do we do in a type 2 and the ureteric tunnel? This is where we ligate in the type 2 hysterectomy. When you go for a type 1, I will show you where we do that. That is divided, and I think they are trying to lift it up. and I will show you how it crosses over the ureter. So all along, I think ureter is something which each and every gynecologist is very much worried about. Right? So, frankly speaking, with the proper traction and exposure, you'll always be able to see the ureter. So, don't hesitate. Make it a habit to see the ureter. So, once you see the ureter in the beginning of the surgery, don't try to. A lot of gynecologists are seen, they do a hysterectomy, simple hysterectomy is whatever you can say. After the hysterectomy, they just see the ureter once and be assured. So, but instead of seeing it at the end of the procedure, I suggest you always see it at the beginning of the procedure. You know where it is, you are more comfortable, you are assured, okay, you can proceed with the surgery very confidently. So, as you can see, this is the uterine artery. We are trying to slowly dissect the ureteric channel and lifted it to the opposite side. So this is where we are going to ligate it in a type 2 hysterectomy. You have seen the length of the ureter, so from here to here. So that is the amount of length of uterine artery you will add when you are doing different types of hysterectomy, because the lymphatics pass along the ureter, along the uterine artery and drain here. So when you are talking about the lymphatic drainage, where does it drain? This area is called as, this is the obturator fossa. So this is where usually the first site of lymphatic drainage for any cervical cancer or endometrial cancer. And then the next step from the obturator will be to the external area. And then goes on to the common area. So when we are talking about the common area, and sometimes it can go along the internal area and go onto the presacral area. So that is how the lymphatic drainage is. So all this anatomy will help you in deciding your types of treatment when you are doing different types of hysterectomy. You have to see these structures and proceed with your management. So when you are talking about cancer management, obviously it will be like the term radical hysterectomy was invented for treating cancer. So you have different types of hysterectomy. The first one was proposed by Fiber-Rutledge. This was way back in 1970. So 5 classes. So where you have an extrafacial hysterectomy, class 1 to class 5, modified radical, Berlin, classic radical, named. Then class 4, it is not named, but it will include you are taking out the you are separating the entire ureter and taking the vagina. So the vaginectomy will be part of that one, and type 5 will be the partial examination, that is excision of the part of ureter and the bladder. Same thing has been, more or less the same thing has been adopted by the URTC also, and this came in the 80s and 90s, so it is rather a modification of the Fiber-Rutledge classification. And further standardized for comparison purpose, there is a Morrow classification which will include multiple things, but effectively what it has divided it is divided the radical hysterectomy into C1 and C2 type, that is nerve sparing, and where you do not try to save the nerve. That is the difference between that. So, and obviously that extensive extended radical hysterectomy is also part of it. So the main difference would come in radical hysterectomy divided into C1 and C2 again, where you are nerve preserving or non-nerve preserving. This is a pictorial differentiation. This is a type 1 or simple hysterectomy extrafacial. The type 2, where you are taking the carotid ligament laterally and the uterosacral ligament, and then the type 3 hysterectomy, where you are going up to the pelvic wall and the uterosacrums as posteriorly as possible. Right? This is where your nerves will be coming. So that is what you need to be very careful about when you are doing the radical hysterectomy. We just put a video of extrafacial hysterectomy so that you know where how to go about. When you're doing the simple hysterectomy, the majority are done by gynecologists. So when I take a few minutes of this one, so when you see, you can see that you should not be going here close to the uterus when you're doing a laparoscopic radical hysterectomy at least. Because the uterine artery will be coursing along the course and you will be constantly ligating, coagulating and going. So should be a little away from it, 2 to 3 centimeters away from it. And you have seen we have ligated 3 structures: the round ligament, the tube and the ovarian ligament. And then the next step would be the broad ligament. The broad ligament, when you are trying to divide the broad ligament, always open up the anterior ligament posteriorly separately so that you will have a better visualization and you can have a better dissection of the bladder. So when you are talking about bladder dissection, what I was doing is going with a lateral approach. Majority of the gynecologists are used to the anterior approach where they directly try to open the bladder from the uterus. But in this era, we see a lot of patients coming after a cesarean hysterectomy, and obviously the bladder is going to be stuck at the cesarean scar. So when you see that one, this approach, if you try to start doing regularly, this will be of use, the lateral approach to the bladder. So what happens is, it is adherent at the scar, the bladder, but lower down it will be free. So what you can do is, you can come from the lateral aspect, lift the bladder, and then you can separate the bladder from the scar. So that way, the pain will come better. So if you try to start dissecting where the bladder scar is, you are more likely to injure the bladder, you are more likely to enter the bladder or injure it, and there is a lot of oozing around there, and you will be losing your planes again and again. So the lateral approach is an ideal one. So that would, I think, I suggest all the gynecologists should start practicing this lateral approach so that you have a safe hysterectomy. So I have divided the anterior tissue broad ligament and then separated the posterior tissue broad ligament. So that way, the only structure remaining after that will be the uterine.
Yes, just to take a moment here and welcome our chief guest amongst us, Dr. S. Shanta Kumari Garu is here. Ladies and gentlemen, thank you so much, ma'am. We also have with us, Dr. Sharad Reddy Garu. Thank you, sir. Thank you for joining us.
Lateral approach, dissecting the bladder and separating the bladder. So we did not ligate the uterine on the right side because we just want to ligate it only after the entire bladder dissection has been done. So when you are coming laterally, you have to do from both the sides and join them in the middle, and then you start pushing the bladder down. Here you can see the bladder is being pushed down. And then, this is the end of the cervix, you can see, and the uterocervical junction, and this is where we will be going to take the uterine vessels. And in all this dissection, you can see that you are not seeing ureter anywhere near your vessels or anywhere near the uterus. So once you have dissected the broad ligament properly, pushed it aside, then you are very safe in doing your dissection. So let it 2 to 3 times and then take it. Same thing repeat it on the opposite side. I'm not going into details of this. All that I can say is here, like to add on. So when you're taking here, this is a type 1 extracellular hysterectomy. I take a minute and close it. So this is the type 1 extracellular hysterectomy. Type 2 at the ureter, so this amount of uterine artery will come. Type 3 at the origin here, so that this amount of uterine artery will be coming when you are doing a type 3 radical hysterectomy. And once the entire dissection anteriorly is done, then we move on to the posterior aspect. I'll add a small point and then I think I'll So when we are trying to do an open hysterectomy, I've tested uretera, we are trying to do an open hysterectomy, we are worried about the rectum and we try to separate the peritoneum here at the uterocervical junction where it is densely stuck. I would suggest give a proper traction, go a little lower down, and this is where the peritoneum is loosely attached. It is not densely attached. As long as you see fat below it, you are safe. So you can see this separates easily. It does not lose. It will separate easily. Then we're cutting it the monopolar. You can use anything monopolar, or you can use a ligation, you can use a harmonic divided, and once that is done, always make sure that the entire cervix is there in your specimen. So always check this, and then once you are satisfied, then that means that your extradition hysterectomy is properly done. So entire cervix should be there. If any cervix is remaining, I think better go back and try to revise the vaginal margin. The specimen is removed vaginally, and then you can see there is no bleeding. Suturing, generally we prefer to do it intra-abdominally because we are used to the anatomy, and check the hemostasis at the end of the procedure. So that gives a brief about the extradition hysterectomy, the technique of it, and if you have any doubts or something, I will be happy to clear that.
Thank you so much, Dr. Ravi. Over to the chairperson. Any questions?
Yeah, could you briefly tell us which type of hysterectomy is done from what stage?
Yeah. So, type 1 or extradition hysterectomy, that is indicated for all cases of CA endometrium, and for the ovarian cancer also, what we do is the type 1 hysterectomy. The cervical cancer, that is where all the rest of the types of hysterectomy is coming. So, type 1 is indicated only in cases with stage 1A. Rest of it, 1B and onwards, will be going for a type 2 or type 3 radical hysterectomy. So, ideally speaking, we should be doing a type 3 radical hysterectomy for all 1B cases. Right? But the majority of the time, a lot of people will end up doing a type 2 or a modified type 2 kind of thing. Somewhere between the type 2 and type 3 is something a lot of surgeons would be doing majority of the time. And for type 4 hysterectomies or something are done only on a palliative cases, or I don't say palliative cases, the locally advanced tumor where you have given radiation, and at the end of the radiation there is a residual disease. That is where we are trying to go in and do a type 4 or type 5 hysterectomy. So because that is salvage hysterectomy, they are not done on a as a primary treatment for all these kind of cancers.
Pelvic lymph node dissection is totally separate surgery, hysterectomy.
Yeah. So pelvic lymph node dissection is not part of the radical hysterectomy. So when we are mentioning it, we will be doing a virgin hysterectomy plus pelvic lymph node dissection. So that is a separate procedure. It is not part of what this is description of a radical hysterectomy. Yeah, I think the Pankaj Sundar will be explaining everything about sentinel, so I didn't go into it. I'm concentrating more on the anatomy and the techniques of the simple hysterectomy.
Thank you, Dr. Ravi. I request Dr. Sarna, our chairperson, to please felicitate Dr. Ravi. Thank you so much. One last speaker and then we'll wind up the session. Yes, ladies and gentlemen, we move on to our last but not the least speaker right here. with us, we have Dr. Anurish Dharnikota, Consultant Surgical Oncology, Medicover Cancer Institute, to please come onto the stage and give his presentation on advanced tools, better outcomes, the role of precision surgery in endometrial cancer management. Over to you.
A very good morning to all the dignitaries and delegates. I'm Dr. Anurish Dharnikota. I'm the Consultant Surgical Oncologist at Medicover Cancer Institute. And today I'll be talking about the role of precision surgery in endometrial cancer management. We have already gone through the anatomy and types of hysterectomies. I'll be briefing about the precise surgical management which we follow for endometrial cancers. As we all know, surgery is the mainstay of treatment for endometrial cancers, and it consists of hysterectomy along with salpingo-oophorectomy and also a separate removal of lymph nodes, either a sentinel lymph node biopsy or a conventional lymph node dissection. If you look at the types of hysterectomies for endometrial cancers, there have been many randomized controlled trials which have compared the modified radical hysterectomy, that is type 2, and radical hysterectomy type 3 to the standard extrafacial hysterectomy for all stages of operable endometrial carcinoma, but none of the studies have showed any differences in local regional control, recurrences, disease-free survival, and overall survival. So the standard management for all stage 1 to stage 3 endometrial cancers pertaining to the extent of surgery would be a type 1 hysterectomy, or what we call as extrafacial hysterectomy. If you look at the picture, the extrafacial hysterectomy includes ligation of uterine arteries close to the uterus and will not be lateralizing or tunneling the ureter out of its bed. Coming to the salpingo-oophorectomy, it is routinely indicated in all postmenopausal females, and ovarian preservation is something which has to be considered for premenopausal patients who are less than 45 years with low-grade endometrial carcinoma, that is either a stage 1A with grade 1 or grade 2 tumors. In those cases also, it is routinely advocated to remove the fallopian tubes because it is the most common site of reoccurrence if you are leaving behind the fallopian tubes, whereas ovaries can be left behind in premenopausal women. Histological type, grade, myometrial invasion, and LGSI are the most important predictive factors in endometrial cancer and should be recorded in all patients if possible preoperatively rather than going for a direct surgery and sending the specimen for intraoperative frozen section, because it results in interference with the lymphovascular invasion, or freezing alters the staging of the endometrial cancer. So the key takeaway point would be to get a preoperative biopsy, either an endometrial fecal biopsy or a hysteroscopic biopsy, which are the preferred modalities, to assess the histological type and grade before going ahead with surgery, because it helps in planning the extent as well as the lymphadenectomy. And any intraperitoneal tumors village, including tumor rupture or routine morcellation which is done for benign tumors, should be avoided at any cost, and we do not use any uterine manipulators either through the vagina or laparoscopically, because it will alter the specimen and also might result in tumor spillage. And staging infrapolypominectomy is an additional procedure which is recommended for undifferentiated tumors, especially serous carcinomas and carcinosarcomas. And surgical lymph node staging should be performed in all patients with myometrial invasion. Because in day-to-day clinical practice, we rarely see endometrial cancers which are non-muscle invasive, that is confined to the endometrium. So most of the patients will require an adequate lymph node staging surgically. For evaluating the lymph nodes, traditionally we used to do a pelvic lymph node dissection, and if it is a high grade or a serous carcinoma, we used to go for a para-aortic nodal sampling, or at least sampling, if not a complete dissection of the infrarenal para-aortic lymph nodes. Now what we have come up with is the sentinel lymph node biopsy, which is the recent advance where it is preferred for all low risk and intermediate risk diseases in stage 1 and stage 2. It has become an alternative to sentinel lymph node dissection, where if you find a single sentinel lymph node also and it confirms to be negative of metastasis, it is considered as a node negative disease. And SNLB without dissection of other pelvic nodes is associated with significantly lower risk of post-operative mortality, especially the lower limb edema, which can be prevented in almost 60 to 70% of the endometrial cancer patients. So if you are planning to go ahead with the sentinel lymph node biopsy, previously the Medlin was the dye of choice. Now we have moved on to the advanced indocyanine green, which is given into the cervix. We usually give 2 ml of indocyanine green on each side at 3 o'clock and 9 o'clock, and then go ahead with the sentinel lymph node biopsy. As you can see, this is the surgery which was planned for robotic extrafacial hysterectomy and sentinel lymph node biopsy. We have injected intracervical ICG 4 ml. It takes 15 to 20 minutes for the ICG to come through the lymphatics into the pelvic lymph nodes. So we open the peritoneum and cut the round ligament laterally to access the pelvic lymph nodes. You can beautifully see the ICG uptake in the pelvic lymph node, the external iliac lymph node, which is being resected. It is surgeon's preference whether in robotic surgery or either using a monopolar hook or a monopolar scissors in the right hand. So removal of all the sentinel lymph nodes would be adequate, and we can effectively avoid traditional pelvic lymph node dissection in almost all stages, that is 1 and 2. Whereas in stage 3 we traditionally go for a comprehensive stage. You can see both the lymph nodes being dissected out from the right pelvic space. If by chance the ICG uptake is not there in any of the pelvic nodes, you can always re-inject the tracer. If you are still not able to get positive SLM, we go for a traditional sentinel lymph node pelvic nodal dissection. The same procedure is being repeated on the opposite side. We are opening the round ligament laterally and opening the anterior leaf of broad ligament. So this is one beautiful technology in intuitive Gavin-C robot, where you have an incorporated firefly technology, where near infrared camera is incorporated, and you can see a real-time ICG while operating. You can see the fluorescence behind the external iliac vessels, which are being dissected out of the hook. This being a stage 1A low-grade tumor, we went ahead with sentinel lymph node biopsy, which would be adequate for lymph nodal staging. For any other update, once it is not there, we routinely go ahead with the extrafacial hysterectomy. So when systemic lymphadenectomy is performed, usually a pelvic lymph node dissection is done and a para-aortic infrarenal lymph node dissection or a sampling is suggested. Based on the data from randomized trials, lymph node staging does not have a therapy. So the rationale behind confining to sentinel lymph node biopsy is based on the randomized trials which have shown that a traditional lymph node dissection does not add much to the therapeutic value of the cancer, whereas it is mainly to assess the extent of the disease and also to gain information whether it is a node positive disease or a node negative disease, which will guide us regarding the adjuvant treatment decisions. So if pelvic lymph node involvement is found intraoperatively, further systematic pelvic lymph node dissection can be omitted safely if you are going ahead with the sentinel lymph node biopsy. However, debulking can be done, and once the significant nodes are there, we can go ahead with para-aortic staging also.
So Dr. Ahmed will be given few extra minutes grace time for all the technical glitches that are happening.
Thank you. So coming to the choice of surgical approach in endometrial cancers, where previously the minimal invasive surgery was considered to be high risk in cancers, it is now proven to be safe, and there are multiple trials which have showed that minimal invasive surgery is safe in endometrial cancers and is now the preferred surgical approach even in high risk endometrial cancers. The two landmark trials, the LAB2 trial and LAS trial, compared the minimal invasive with open surgery and showed similar survival with an advantage of early recovery with minimal invasive, be it robotic or laparoscopic. So this is the surgery which we routinely do for endometrial carcinoma. As you can see, we start the surgery by incising the round ligament. We start our dissection with sentinel lymph node biopsy because once the dye is given, the ICG stays in the lymphatics for almost 1 hour. So we complete the sentinel lymph node biopsy first. We open the round ligament and then dissect the anterior leaf of broad ligament, which will give us access to the pelvic nodes. The first step in our dissection is to visualize the ureter, medialize it while doing the sentinel node biopsy or pelvic lymph node dissection in laparoscopy. You can see the ureter coursing along the posterior leaf of broad ligament. We won't be tunneling the ureter in type 1 hysterectomy. So we'll go ahead and remove the sentinel lymph node. You can see the ICG update. The same procedure is repeated on the opposite side, where we are incising the round ligament and opening up the anterior leaf of broad ligament. You can see a beautiful avascular plane is dissected to visualize the ureter. You can see that ureter is under vision now. It's being visualized. And then you can see the uptake in the pelvic lymph node, external iliac node, which is being dissected out. Once the dissection is done, we have already opened the anterior leaf of broad ligament, which is then continued anteriorly towards the introvesical fold to lift the bladder up from the cervix. As Ravichandra sir rightly said, we usually go from lateral to anterior. Once you open the anterior leaf of broad ligament, it becomes easy to get a plane between the bladder and the uterus. Then we dissect the uterine artery, as you can see. The uterine artery crossing and the ureter going below the uterine artery. So in radical hysterectomy, as sir has shown, we will be ligating or clipping the uterine artery laterally at the origin of uterine artery from the internal iliac. Whereas in modified radical, we will be ligating the uterine artery at the level of ureter. Whereas this being a simple type 1 hysterectomy, we clip the uterine artery and we are not worried about the parametrial extension, so we will be cutting the ureter uterine artery close to the uterus. And you can visualize a similar anatomy on the opposite side. The uterine artery being dissected, and you can see the ureteric tunnel below. Beautiful peristalsis of ureter below the uterine artery. The water under the bridge. So once we do that, we clip the uterine artery and divide it close to the uterus. So until this, we generally do not open the posterior leaf of broad ligament, or we are trained in a way not to cut the IT ligament initially, so that there won't be any malrotation of the uterus during surgery. So till the end of the surgery, the ovarian and IT ligaments will be intact. So once the posterior leaf of broad ligament is cut all the way down to the cervix, we move on to the posterior dissection, where we will be cutting the uterosacrals close to the uterus. And this is a premenopausal lady, so we have preserved the ovaries, and we had to do a salpingectomy in this case. So this is a extrafacial hysterectomy along with bilateral salpingectomy, where we have preserved the ovaries. Once that is done, we open the cervix. You can see there are no uterine manipulators, intravaginal manipulators, and the specimen, whenever feasible, is retrieved through intravaginally. Otherwise, we do not morcellate. We give a small mini laparoscopy incision or a small panel steel incision and endobag it to remove the specimen to avoid the spillage. So after that, we will be closing the wall laparoscopically, and once the hemostasis is checked, to conclude the surgery. So to conclude the talk, the advanced techniques like sentinel lymph node biopsies have revolutionized the management of endometrial cancers, where the morbidity has been brought down significantly, and there are very minimal complications when we adopt a sentinel lymph node biopsy in endometrial cancer. And whenever feasible, minimally invasive surgery should be the preferred approach, be it laparoscopic or robotic surgery, as it results in better visualization with the advent of 3D laparoscopies, 4K laparoscopies, and robotic surgery, which gives us a beautiful vision and zoom, and it results in less intraoperative blood loss, shorter hospital stay, and faster recovery. Thank you so much.
Thank you so much, Dr. Anvesh Garu. I request the chairperson to please propose.
Thank you. routinely it's lower limb edema, and if there are bulky nodes, if they are sacrificing the obturator nerves, there will be weakness, loss of sensations on the medial aspect of the leg. Apart from that, we routinely don't see much other complications which are. It's mainly because it's a common pathway where the lower limb lymphatics also drain through the external iliac node. So there will be a lower limb edema in almost studies might vary. It will be around 5 to 28% across the studies. So that we can effectively bring down to near zero if we are sticking on to sentinel limb.
And Dr. Abhi, should we remove ovaries for an endometrial cancer?
Yeah, that's what. This is a grade 1 stage 1A tumor. This is the only indication where if the tumor is 1A grade 1 and the patient is premenopausal, because this is a 39-year-old. We went ahead to preserve the ovaries.
Message is well taken.
Thank you so much. It was a nice.
CSC.
Dr. Anvesh, request to please remain on stage. I request Dr. Aruna, our chairperson, to please set the stage. Dr. Anvesh. Thank you so much. Thank you so much, dear chairperson. Can we clap for our chairperson for making sure that all the queries, questions are posted to our speakers. Ladies and gentlemen, our chief guests are here with the audience, and it's now time to welcome our chief guests. So with the thunderous round of applause, I request our chief guest for the day, Dr. S. Shanta Kumari, MBBS, MD, DNB, FRCOG, FRCPI, Ireland, FRCOG, UK, Senior Consultant Gynecologist and Obstetrician and Specialist in Laparoscopy Surgery, to please step forward onto the stage, ma'am. And I request Dr. Ravi Chandar to please do the honors in welcoming our chief guests by presenting a floral bouquet and a shawl. And also a token of appreciation, sir, to ma'am.
So, this is what we finished the presentation.
Thank you so much. And it's time now to call upon our guest of honor. Please put your hands, ladies and gentlemen, for Dr. Sharad Reddy Garu, MD/DM, FSCAI, FACC, FAHA, FASC, Senior Interventional Cardiologist, Director, CTO and Complex Coronary Interventions, Director, TAVI and Structural Heart Diseases, Director, Cath Lab, Director, Medicover Hospitals, Telangana. I request Dr. Anvesh Dhanikota to please do the honors in welcoming our guest of honor, Dr. Sharad Reddy Garu, with a floral bouquet. And a shawl presentation.
ఆశా గారు దూరం నుంచి తీసుకోండి.
And a token of appreciation. Thank you so much, dignitaries. Now that our chief guests are here, I would like to hand over the mic to our chief guest, Dr. S. Shantakumari Garu, to please address the gathering.
Good morning, friends. warm greetings from Figo, Foxy and the Optic Society of Hyderabad. It is a pleasure to be here on a Sunday and to see a hall full of people. So I think that itself shows that it's a very successful program, and I would like to place on record that thank you for the Oncology Department of the Medicover Hospital for organizing this wonderful academic conclave on the oncological aspects of gynecology. In fact, I have to say that when Ravi called me and asked me, are you going to be there on Sunday, I couldn't tell him lies because I had actually bunked one program I was in Hyderabad, and for practical purposes I was not supposed to be in India. But I couldn't tell lies to this good surgeon, because when I was in care hospital where I used to do a lot of oncology cases, lab endometriosis, but I used to be very, very particular that when I do the oncology cases, the surgical oncologist should come and do the lymphadenectomy part. So he was good enough to accept when one of my surgical oncologists was not there, and he came and helped me. So I have great regard for Ravi. He is a wonderful surgeon, and I think that is the reason why I think many of us are here. We have seen him operate few weeks back at Yashoda Hospital Congress also, which Sharda had organized, and everyone was appreciating his surgical skills. And I was just talking with Dr. Sharad, and very glad to know that this hospital is doing good, and they're going to start one more good institute in the Secunderabad area. So congratulations to you and your whole team. Oncology is so important, gynae-oncology especially, because I think we gynecologists are especially one set of doctors who have we have actually two arms. One arm is the obstetric part where we try to help, and we're not doctors, we are like part of the family, because we are all happy people, we are all happy people, because we deal with pregnancies, lives, or not happiness, unlike the oncologists and other people who are actually dealing with diseases. But there is another part of us which is the gynecology part of us. So originally it was the gynecologists who used to handle all the gynec malignancies. I happen to be the niece of one of the very famous gynae oncologists, Dr. Rajaram, who was very well known. He was actually trained by Vardhan Shorta Mitra and all. He was one of the very well known gynae oncologists of our country. And those were the days when every gynecologist used to do the gynec cases. And now we have evolved, we have developed this specific surgical stream where gynae oncologists there. We have got a lot of surgical gynae oncologists, and the gynecologists also are doing specialized gynae oncology. But basically, let me tell you friends, the onus is on us gynecologists to see that we take care of the mothers and women we serve. Gynae oncology is a good field, but unfortunately we find that the cancer cervix and endometrial cancer are on the rise. It's the responsibility of all of us to see that we are able to take care and give preventive care to our women. Please let no woman who enters your clinic go out without a postpartum examination, without a pap smear. Do pap smear, LBC, HPV, whatever, but do something. I think visualize the cervix. Preventive gynecology is so very important, and that is in the hands of us gynecologists. If we can't take care of the women, then I think that's something we should be very ashamed of. In fact, I am so happy that people could convince our Director General of WHO way back in 2017, when Tedros took over, FIGO organized a meet and said in that WHO meeting, told Tedros, yes, cancer is a major killer in the world. And he took it on himself and said, yes, we should work towards the cervical cancer eradication. And that is what is so very important. I was there in Geneva for the World Health Assembly last 3 weeks back, and the focus is on cervical cancer eradication. And I was in a meeting where it was in a small group meeting, and somebody was presenting the information. It was more an African origin doctors. They were all discussing on cervical cancer eradication in that part of the world. And when they put the slide, I felt so ashamed because after in Nigeria, India, we are having a huge burden of cervical cancer. Unfortunately, 75 glorious years post-independence, but still we have not been able to conquer this problem. So we all should take it as an war footing. Cervical cancer Mukt Bharat is a responsibility of each one of us. In fact, we have been working with the government, fighting from 2009 when C.N. Purandare was the president of FOXI. We have been advocating for HPV vaccination for girls, and we have seen the rise and fall of the vaccine. And fortunately now the government has realized, in 2022, towards the end of my presidential year, in fact, the ministry called me, Mansukh Mandavia and the Vijay Paul said, now Shanta, you call for a meeting, you call us for the meeting. And then Rajesh Bhushan, who was the Chief Secretary of Health, all of them came, and then we said, yes, now we need to see that we immunize all the girls, yes, boys also. And that was a meeting where the government agreed, because we were coming out with the indigenous vaccine also. The cost factor was always an issue with the country. And now, this year you have seen the financial bill where they have incorporated the HPV vaccine for all the girls. Hopefully now, yes, we want to look at the gender neutral vaccine, but that will take time because there are too many girls in the world, women in the world, and the vaccination, I think the output is still not enough. But the responsibility is on all of us to convince the mothers, the fathers, the family to see that they vaccinate their girls. And that is so very important. So I urge all of you to take the responsibility, because people come with the families to the obstetrician care, because gynecologist is the one-point contact. We are their friendly doctor must. So the responsibility is on us to counsel them. Take a minute, if you don't have time, put up posters in your OPD, tell them about the cervical cancer problem and vaccination. Don't let any woman go without a speculum examination and a pap smear. That is so very important. We have come with guidelines, we are just hearing both the surgeons, and I'm very glad to know that Dr. Medicover happens to be our gynecologist son. When I saw your surname, I thought this is looking very familiar. So we are glad you are there. But now the endometrial cancer, FIGO has come up with a new guideline. Now the treatment technology, techniques, everything, 7-8 years back when I used to operate, I really never grade 1, grade 2, grade 3. We used to do. But now I think it has evolved, and we have got this specialist. So take the opportunity, don't just push them off to the surgical oncologist. You also go and assist the cases. So that way we also get to have a feel of our cases. Don't worry. We won't let you all completely, at the same time we won't let you all take over our field completely. It should be a partnership for the best of women's health. And these sort of programs are very important, because we are trying to see how best we can inculcate. Because all the younger children, they want to do only infertility, fetal medicine. So who is going to deliver my mothers? Who is going to take care of my women? So I think the most important is all the younger generation of obstetrician gynecologists. The future is not for infertility or fetal medicine only. Future is for obstetricians, general gynecologists. So don't let that field become obsolete. Please do it with fervor, and that will help us reduce the burden of gynec cancer, which is really, really increasing. If you look at Hyderabad, I was just discussing with Dr. Look at the number of hospitals around this area. Huge number. So many oncology units. So many. I am from Yashoda Hospital. I find this oncology unit, and it is full. So the incidence of cancer is increasing. So whether it's environmental pollution, whether it's the food we take, whatever the pollutants, I think every one of us are responsible, right from the government to the public to everyone. We need to see how we are going to live our life. We have no right to ask for clean environment. Don't we have the right to ask for food which is free of contaminants? Young people, I think oncologists, all of you also should keep on talking about it. Give public statements that somewhere accountability should be there. Accountability, and we should ask the government for accountability. I was very glad, last 2 weeks back there were a lot of raids on these hotels and all, and they were talking about how the food is in such unhygienic conditions. I think the same power is needed from all of us to enlighten public and the government and accountability, because we definitely need to reduce the burden of cancer in our country also. Thank you all. I think I have bored you enough, but these are important messages. If I can make you all at least go back and see that you vaccinate all the young girls and you do pap smear screening And postmenopausal screening, so very important. Doctor's Day is coming. One more very important message I want to give. How many of you all, my dear friends, have got your annual checkup done? Please put up your hands. Honest, huh? Honest. How many of you all have got your mammograms done, pap smears done? Please go back, get it done. I have to be honest, even I was bad. In 2021, I just did a video to release about the cervical cancer awareness. Then I realized I didn't do. I went to the hospital, I told Dr. Please come. Now immediately do my pap. I think it's very important we take care of our health also. So unless you all are healthy, you can't take care of your patient's health. Take care of your health, your patient's health, and automatically I think hospitals also will be happy because they will be happy to have healthier doctors. So I actually urge all the hospital corporate on the Doctor's Day to see that you do your annual health checkup of all your consultants. This is what we have been actually here hospitals and Medicover and all the hospitals, make them accountable to take care of their own health. So don't be upset with me, but I felt this was an important message because we need to take you all and we all need to take care of those who are taking care of people's health. Thank you all and wish you all the best for the rest of the
Thank you so much. Dr. Shanta Kumari, ladies and gentlemen, talking to all of us, encouraging us and motivating us. And ma'am, you just told that all the doctors here should go for their tests, annual tests, pap smear tests. So on behalf of Medicover, we will be making sure that we give special offers to the doctors here so that you can get your test done. Isn't that a good, I think, occasion to clap for Medicover? I now request Dr. Sharat Reddy Garu to kindly please address the class.
So, very good morning to all the doctors sitting here. And I'm very thankful to Dr. Shanta Kumari Garu for coming over and emphasizing on taking care of our own health, before taking care of our patients' health. I think that is fundamentally very important. And in fact, we also made mandatory for HR to submit all the medical reports of doctors, every year. But unfortunately, it is not happening because of the doctors themselves. So, so it is at the end of the day, we have to involve ourselves into it. Then only we can make it more successful, and we can also make our lives. We have to show empathy on ourselves first before showing it on our patients. So, I'm very delighted to have all our oncology department here and conducting a program to resonate with the ethos of our organization, wherein we are encouraging all such programs, to collectively grow ourselves and our wisdom to deliver right care to our patients. That's a right contemporary care to our patients. As an avid reader, as an interventional cardiologist who trekked into the most complex field of cardiac interventions, that is C2I interventions, I understand the only constant in our lives is change. So there is nothing else. Whether it is a clinical practice, or whether it is hospital, or whether it is business, or our own personal lives or family lives, the only thing which is constant is change. There are many clear spots in front of us. There are many blind spots as well as in our lives and in our professional journeys and in our scientific understanding. So through my journey, what I understood, there are many knowns in our practice, many unknowns as well. And unknowns becomes known in future. And such as knowns becomes unknowns or become borderline knowns in future again. So we have to navigate through these knowns, unknowns, known unknowns, unknown unknowns to evaluate ourselves as a contemporary clinicians or relevant clinicians for the kind of challenges we are facing in terms of disease burden in our society or disease burden in our patients. So, as an interventional cardiologist, I keep changing, bar of our interventions in our hospital every day, month on month, and year on year. So all our interventional cardiologists are almost always on toes, to catch up with me in terms of interventions. And that is what is needed in every department and every organization. And these are the ethos which we want to carry along with organization, tethering to all the physicians around. Need not be the physicians in organization. There can be physicians even out of organization. And I'm very grateful to all the team sitting here, Dr. Ravichandra, Dr. Anvesh, Pawan, and Dr. Sarita for carrying, these ethos and conducting these programs so that continuously we can evolve and we can change our patient care in organization as well as in entire, place where we are living. And we have just started. Yesterday we inaugurated one more hospital in Warangal, inaugurated by Honorable Chief Minister of Telangana, K. Revanth Reddy Garu. And as already Madam mentioned, so we are, in 6 months' time, we are also starting one hospital in Secunderabad and another hospital in Gachibowli. So that's what, change is the only constant which I believe both in profession as well as in business. So I congratulate all of you and I thank all the gynecologists and oncologists who came for this program. Please, take this ethos and collectively come out of this program as new use and clear up certain blind spots and make certain blind spots as the clear spots, and also realize that still there are a lot of blind spots in this ever-changing medicine. Thank you one and all again.
Thank you so much, sir, for sharing valuable details and insights with all of us here. That was truly informative. I request our dignitaries to kindly please proceed for the lamp lighting ceremony. Yes, ladies and gentlemen, we are Indians and we believe that before we begin any auspicious program, we remember God through the lamp lighting ceremony, seeking the blessings of the divine, and we should be doing that now. Since our dignitaries, our chief guests of honor, are present here, I request all our beside the lamp and also we can take one on the stage. I just want doctors
Yeah, okay.
Yes, we also request our chairpersons to please step forward. We can take a picture with you also. Yes, please. Yes. Yes. There is all women power on stage along with you, sir.
బ్రో బ్యాగ్ వచ్చి బ్యాగ్ జూమ్ చేసుకో.
Thank you so much to our chief guest. Yes, Dr. Kumari there and also Dr. Sharat Garu. Thank you so much for doing the honors. Thank you for the wonderful addressing remarks that you have presented here. Ladies and gentlemen, we should now move into a short tea break, and then we have some presentations, and then we have the interesting panel discussions coming up. So we can take 10 minutes tea break, freshen ourselves, and please come back soon. We can wait by
అజ్జానా
Dr. K.G. Jyoti Swaroop, Consultant Uro-Oncology, Medicover Cancer Institute from Medicover, to please give presentation on managing missions, tackling inadvertent urological injuries in gynecology, oncology, surgery. Over to you, sir.
Hello. Hope we are really halfway now. Well, I'll start. Pretty well. I am Dr. Swaroop, consultant urologist, urologist and robotic surgeon with Medicover. Well, my topic is a bit more clinical. When it happens, is actually a positive who will actually detect it in raw. If for the rest of the people, it is a nightmare. Right. See, operative injuries of the urinary tract are common in gynecological surgery due to proximity to the urogenital organ systems, and urinary tract injuries are approximately about 0.2 to 0.4% in gynecological procedures and pelvic surgeries. And the rate of clinical injuries is about 0.2 to 0.5 for routine or benign conditions, and it goes to the level of 10 to 13% for and it's about 10 to 30% in procedures for malignant conditions. There are gamut of surgeries which all the gynecological oncologists and surgical oncologists proceeding with, the ureter in the back and the bladder below. And grossly, we can differentiate into bladder injuries and ureteric injuries. Bladder injuries are generally encountered intra-op and primarily corrected. And when there is a small injury in the retroperitoneal or extraperitoneal place, the bladder catheter will take care. So mostly we'll be concentrating on the ureteric injuries part of this session. Well, how do you tell it's a ureteric injury? A significant ureteric injury is defined as any recognized or unrecognized iatrogenic trauma to the ureter that prevents it from functioning properly or ineffectively. And way back in 1800s, when very much was known about the ureteric anatomy, ureteric injuries were recorded by Berat and Simon. And later in 1900s, when a young urologist, Sampson, started his studies on the ureter. And the first reported ureteric injury in laparoscopic procedures were in 1971, where the patient presented with clamping and it was managed with ureteroneocystostomy and bovine clamp. To classify for broad age is into 5 by Moore et al. Initial one is a hematoma, grade 1, and the laceration of less than 50% and more than 50% as grade 2 and 3, and the defect of less than 2 centimeters and more than 2 centimeters to 4 and 5. So what actually predisposes the ureter to be damaged? First, the patient goes. Well, there can be a large size of a uterus, ovaries of radiuses of more than 4 centimeters or larger, any prior abdominal, intra-abdominal or pelvic surgeries, prior radiation therapy, or an advanced malignancy, or if there is an anomaly of the urinary tract, like in the case of pelvic kidneys or dual ureters, like that. Most commonly, the mode of injury is like crushing with a clamp. What happens is when you just put a clamp and inadvertently the tip might even actually ureter the clinch on the ureter sometimes. Or you can actually ligate right with the suture also sometimes. Whenever there is a ligation put and when you cut it, if it slips, it's a human tendency that you go and try to clamp again, and you generally try it, ligate it, and you'll find that the ureter is partially or completely in that. And sometimes even annulation of ureter. This happens when you take a bigger bites and the ureter is actually pulled towards the suture. You may have a secondary obstruction due to a kink in the ureter. And transections are quite possible when you are not actually seeing the tip of your scissor and it goes into the bloody segment, or at the level of pelvic lymph node dissections. This can happen. The resection of a segment of ureter may be done when the ureter is not identified and you are trying to go on the obligated umbilical ligament below to find it, and you actually may end up in resection of the ureter in that part, or if there is a involvement of that part of the ureter by the lymph nodes. infiltration basically. And ischemia, this is one of the most important things we actually don't come across. Having an active link of harmonic or any monopolar coronary devices beside the ureter will cause a subtle amount of ischemic injury onto the ureter, or if you bear the ureter, removing the bordage sheet from it, there is a chance that post-operatively he can come with the patient, she will come with ischemic injury to the ureter, stripping and stricture. Well, what this injuries can cause? It can cause, if you are ligating it or a thing is that it can present with ureteric obstruction, or there may be a discontinuity in the ureter, or there can be, in case of partial ligation of stricture formation, there will be a chronic ureteric obstruction, even in cases of revascularization. And most of the times, this is higher in malignant, when you operate on a malignant gynecological procedure. And approximately 70% of these hypertonic injuries are detected post-operative. That is the biggest thing. In fact, what happens if you have done some injury from a minor one to a large, or even if you ligate, the possibility is that a thermal injury can spontaneously heal, or if there is a small link with the suture or it runs through it, it will spontaneously resolve you and heal. But later on, what will happen is there are some consequences which can happen. It can end up with hydronephrosis in case of complete ligation or in the loss of kidney function. And a partial trauma or ischemic injury can result in a leak, urinary extravasation. You will have a lot of drain fluids, non-serous, all this can happen. Long-term stricturization is a complication of such a healing process, and patient can end up with uremia in case of bilateral issues. So when should you think about evaluation of a ureteric injury following the gynecological oncology procedure? So whenever you find a patient in the post-operative ward with post-vertebral angle tenderness, or patient is having an unexplained fevers, abdominal distension, ideas due to urine in the peritoneal cavity, unexplained hematuria, or if you have a fluid in the vagina like fistulating regions, and appearance of a mass by seromas and all, and the elevation of the cerebellum, this warrants evaluation of a ureter. And how do you do that? You actually can be done by imaging with the CT urogram with delayed images, or if you suspect an extravasation from the ureter or something, you can do a cystoscopy followed by plus or minus retrograde pyelogram, wherein you can see the level of obstruction or level of leak, which will help us determine where something had went wrong. In fact, you can, if you have recording of the surgery, you can actually go back and look into it to find the level of lesion. And to manage this immediately in the post-op, there are a few contraindications, like whenever the patient is in sepsis, you don't have to, you just have to bail out by putting a percutaneous nephrostomy. And very rarely we come across where ureters have injuries identified in a histological specimen. And what are the common signs of ureteric injuries? As already Ravi Chandra sir has already shown you the anatomy of it and where all we have to be careful. It is at the level of the infundibulopelvic ligament, which runs very parallel to the ovary, which sir has already shown. It will be right posterior in the ovarian fossa. And in other conditions, ureter, there might be adhesions, specific adhesions, wherein you try to open it, or densely adhered ureters can be in the posteriorly below the peritoneum. And whenever the surgery is performing an appendectomy, maintaining a traction will avoid this kind of injuries. And also at the level of ischial spine, where it turns in the ureteric tunnel. But in that, there actually sir has shown you that the ureter goes obliquely in the ureteric tunnel. Yes, exactly that. So this is the presentation we got, and they actually can present with even peritoneal and signs of abdominal distension. So how do you manage? Management in fact depends upon when you are diagnosing the thing. Also the cause for it, etiology, the length and location of the injury of the ureter, and overall status of the patient, and associated other injuries which might have occurred. Grossly general principles are you have to make ureteric continuity with the bladder or with the ureter with minimum tension and preserving the blood supply of the ureter, adequate debridement of the surrounding tissues, and the water spatulated watertight drainage. And the most important here, while doing the operation or while approaching the ureter, is not to strip off the ureter of the superficial tissue. That's the Walden's fascia, which actually, if you see the picture, the ureteric vascularity comes from two layers: Walden's, inner Walden's, and outer Walden's, where the vessels are there. Even if you strip the superficial part of it, you are at a risk of having a compromised ureter. Even in the next setting, whenever you're going to operate, you may have unhealthy ureters. So what are the options we have? So if detected intraoperatively or in an open surgery, like you have seen it, you can actually remove just the ligature and look for it. You can get an assessment with the urologist to see for any damage and leave it. Sometimes you might have crushed it or something, then if you look that's fine, there is not much of a hematoma condition, you can just go away with putting a PCN or ureteral stenting in that state. The advanced procedures which might be required in case of defects of more than two, which I'll be explaining soon, are ureteroneocystostomy with or without a psoriasis. You can have a ureteric resection and ureterostomy or transureterostomy, and a boric flap or water transplant. So, which to choose where? If you have a ureter which is very close to the bladder and you don't have a juxtavesical pad more than less than 2 centimeters, what you do is you go up and you will have to take a ureterostomy where you spatulate the ureters anterior and posterior, like 6 and 12 o'clock, and close it over a stent. And if you have, see, in cases of some ovarian cancer or endometrial, where you're going up and dissecting the parotid lymph nodes, there is a high chance that you inadvertently injure the left ureter, which most happens now. But here we can actually do a transureterostomy to the opposite ureter and put it over a stent. But this one is least likely required these days because we have advanced procedures for that. And when you are below the pelvic rim and the ureter needs to be mobilized a little cranially up onto the PUJ, and then you can bring the ureter down to the bladder. You can mobilize the bladder anteriorly so that I can pull it up and put up a Lichtenberger, which is a tunneled anastomosis, or you can do Lichtenberger, which is a direct refluxing anastomosis, or you can do a Lichtenberger, which is a non-reflexing under the subretrosacrum. So these can happen when you can mobilize and bring it to the bladder now. And if you think that there is a larger ureteric damage and you have resected more than 3 to 5 centimeters, from there on you will generally require a psoas hitch. This is a psoas hitch wherein you will do a cystostomy, mobilize the bladder on the opposite side, remove the supports and push it onto the lateral side and put a hitch, implant the ureter in the submucosal tunnel. This is another depiction of boric flap. This is there in another picture. This is a boric flap wherein we take a L or a spiral bladder flap, refashion it through tunnel to make it into a ureter in the lower distal half, and native ureters are implanted in the submucosal tunnel like this. So later on, for more than 8, boric can be done to a level of 10 to 12 centimeters. Even more than that, if you have an option of having a ileal transposition, which can be done. So finally, what is the care we have to take and to avoid or prevent such things? So whenever we have to look at the anatomy first via CT scans and imaging to look for the ureteric involvement or any abnormal anatomies, and then you need to have a high degree of suspicion when you are close to it or when it is bleeding to see that you have not touched the ureter or you have not stripped it. And you need to have adequate exposure, put a pad or something, and make sure the pelvic area is clean and there are no bowel which is hanging around. And intraoperatively, you should be using cotton which is monopolar lines to be less used, minimally used around the ureteric area in the region of the pelvic lymph nodes. And following the principles of Dr. Arjuna, where he was showing the hysterectomy there. Of late, there have been emphasis on the lighted stents, which are being used for identification of ureters in complex surgeries, but it comes with a price. This can help when you decrease the lighting on the lab monitor. And otherwise also, if you have any doubt, try to put your camera into the other port and look at the ureteric injury or the part in a different angle. In any case of doubt, do call the urologist, cut open and see. have to, when you are managing the oncology procedures, make sure you should anticipate some difficulties during the lymph node dissections or the abnormal anatomy which comes with it. You may be encountering a large uterus which is difficult to be manipulated, and you may end up in having a ureteric injury or bleeding which will inadvertently cause an injury. And preoperatively, make sure that you are looking at the risk factors, all the things which are kept in mind. And during surgery, meticulously looking at infantile element and infantile of pelvic ligament, caudal ligaments, and at the level of the ureteric crossing. And whenever detected, just intraoperatively, you can call one of the urologists in-house. It will be helpful. Any amount of ureteric damage can be managed and will be managed. I'm open for any questions at all.
Presentation as to what, but majority of the times it so happens that it is not identified at the time of surgery.
Yes.
So they usually present after probably 10 days or 2 weeks or something. So what is the first step to be done in the diagnosis, and when should we plan a evaluation test in these kind of things?
So whenever a person presents immediate post-op, that is there is having a leak and patient is not in sepsis, we can right away go for RGP study, cystoscopy, RGP study, look at the bladder, look at the ureter, and straight away go for primary corrective procedure, either by ureterocystoscopy or requiring a flap or implant. If it is presenting delay and it is controlled, or like a partial injury, what we can do is we can stent and give it some time. Later on, go for a corrective procedure, the later date after 6 weeks. Because sometimes even we can go with only stenting itself. Yeah.
Yes, ma'am, I'll just give you the mic. Just 1 minute, ma'am.
So what happens is they don't come early. True. So probably they present after 2 weeks or something with a something like a BBS, ureterovaginal procedure. So, and you try to stent, you will not be able to stent that. What to do in that?
So ureterovaginal fistulas generally present late, and when they present with that, we actually try to put a PCN or an anti-grade stenting into the bladder, and at a later date when all the granulation tissue is all off, we dissect the planes between both primary closure and excisional closure, momentum there, and wrap the distal end of ureters also with momentum.
When do you do that?
That after 6 weeks, sir. 6 weeks, yes. 4 to 6 weeks, depends on. Yes. No, ma'am. Yeah, after the procedure, even if that might not, ma'am, because if there is a partial transition, you still have little amount of urine coming into the bladder. Not completely the path of resistance, it will go that way. The bladder. But the proper reflex which we see in a normal cystoscopy might not be there.
So in one of your slides you had mentioned that previous treatment with radiotherapy also is one of the risk factors. So how challenging is your surgery in a post-radiation setting for managing ureteric disease?
In a post-radiation setting, actually everything is plastered down there, and someone who is already operated, ureteric injury is there, it's going to be really challenging. What we do is we just go from native place. We go up, mobilize the kidney, run the ureter vague area, and go down, we go posterior to the ureter and then channelize the whole thing. So if at all required, we actually try to maintain that which is already structuring types in our post-radiotherapy. We remove, we assess, and then if required, we excise the whole segment and put either in a position or a flap. Okay. There is only one case which we did a total ideal interposition because the ureters are totally failed after radiation. So there was nothing we could have done for that patient. Transfer is an option, but we can get a.
Any more questions from the chair?
When there is a real stenting. When there is a real stenting. What real stenting? In case you are finding a lot of 7 cm, 8 cm lymph nodes, and it's a debulking surgery where you're going to do for prior to any chemotherapy. That time you anticipate, you sure you know that there is going to be ureter which is within the lymph nodes. That time you can go for this lichen stage. It comes with a cost around 7,000 to 8,000, but it helps you a lot.
Yes, thank you so much, Dr. Swarinder. I request you to please remain on stage. I request, Dr. Mirza Adar Ali to please present a memento to Dr. Swaru. Thank you so much, sir. I request the chair to please be seated. Yes, ladies and gentlemen, we move into our second session, session 2, which is cervical cancer. This is the general session. I'd like to invite Dr. Prithvi Peram, consultant gynecology, Medicover Women and Child Hospital, to please come on to the stage and give a presentation on From Prevention to Protection, the impact of screen and HPV vaccination. Over to you. A very good afternoon to all the dignitaries and the delegates. I bring a warm welcome from Medicover Women and Child, and after a huge talk regarding the surgeries, I am just moving on to the preventive gynecology here, and we are going to see a few slides regarding what dear Dr. Shantakumari Madam was emphasizing on our being as a gynecologist, why we are supposed to emphasize on pap smears, screenings, and even the HPV vaccination law. So moving on to the top, it is from prevention to protection, the impact of screening and HPV vaccination. Here you can see the teal and the white color ribbon, which indicates the cervical cancer awareness. And as we know that the current estimates are being showing that it is 1,32,000 new cases every year it is being diagnosed. And moreover, like around 74,000 deaths still occur annually in India. Though we are 75 years above, since we got our freedom since, still we are in developing state, and it's really sad to see this number. But we are accounting for almost 1/3 of the global cervical cancer deaths, and also it is at 2.5% times its cumulative risk for any woman in India to get this lifetime risk of a cervical cancer. And also death risk, it accounts up to 1.4%. The Globocon 2020 was showing that it is the second most cancer, and as the fourth most cancer in the worldwide after the breast, colorectal and the lung cancers. And if you see here the epidemiology, it is showing that it is mostly HPV related cancer, and majorly it is contributing to the cervical cancer in the females, and in the men it is oral cavity cancers. And also if you looking to the burden of the HPV infection, it is almost 83% in the cervical cancer. And moving on to the anatomy, as you all know, this is the female reproductive system, and here we are mainly concentrating on the cervical part of uterus, and the cervix we are mainly focusing again on the transformation zone, which is the zone where we are supposed to collect the sample from. If we go towards the risk factors, we see that early marriages, which is little bit on a low rise right now,
but still there are areas where still the age of marriage is still low, and partners are like multiple partners are there, and if they have become sexually active at a younger age, and also if they are maintaining poor hygiene. Still, many parts of India, they are not having any sanitary napkins availability. Still, they are using the cloths and all those unhygienic practices are being done. So, these contribute to the risk factors, and also even women or women is smoking or tobacco use is there, their immunity level gets suppressed, and also even OCPs also contribute to the low immunity level, and here everything, it contributes to the HPV infection. Come to what is this HPV infection? Human papillomavirus, if you see that it is having two types of strains, that is one is extensively high risk and low risk one. And there is also intermediate, probably high risk ones. There are many strains if at all we see, but the main things we concentrate on 16, 18, which are very high risk, and 31, 33, 35, etc. But coming to the low risk, it is again the 6 and 11, which we are more focusing on, because they contribute to a lot of anal warts and all warts and all those things. Coming to the HPV infection, if you see that the HPV persistence and the infection, it is the main determinant in diagnosis, like if we see for the progression of a cervical cancer. And most of it is contributed by the 16 and 18 types, and they contribute almost to the 70% of cervical cancer, with the 50% contributing to the cancer precursors, which we are trying to pick up in most of the women. And the HPV positivity is almost 98% in in situ and almost 90% in all the invasive cancers. If we see the pathogenesis, here the HPV virus, once it enters into the body, in most of the women it gets cleared up by maximum of 2 years. In couple of weeks, once it infects the basal cell, it starts proliferating, but with the immunity system what the woman has, this infection gets cleared out. But sometimes it proliferates, and in 10 to 20% of the women, they transform into where the HPV DNA gets integrated into the tumor cell DNA, and they present with the invasive cancers over a period of 10 to 30 years. Here we are blessed to have this 10 to 30 years of incubation. That's the reason the role of screening comes over here. And screening is mainly to pick up all the pre-invasive lesions of cervix. If we do a screening for an already invasive lesion, we have crossed the train, we miss the train. But here, if we are able to catch them up in a proper way before they develop into the invasive cancer, when the cancer is giving us like a huge period of almost 10 to 30 years, then we are going to make the difference. Now coming to the screening methods, the older method which we have is a visual inspection, the eyes, and this cuspospectrum, the simple one. This is the low resource setting. Everybody, anybody can, all the gynecologists can do, even at the remote places also. And here with the simple application of acetic acid, and we can see the acido-white areas. If possible, we have the leukocyte, we can again clearly demarcate the areas over there. And from then, if we take the colposcopy or the punch biopsy, then we are going to make a difference. Or treat them, see and treat, or like once you confirm the diagnosis and treat. That will be the next modality. Next, moving on to the newer method of the screening, it is a high resource setting, where this high resource setting is the basic pap test also. It is a conventional type and it's a liquid based type. In the conventional type, there is a slide where we have the spatula, cytobrush and the swab, which from where we will be taking the sample, we will be smearing it onto the slide, and we will be air drying it and fixating it, and then doing the microscopic study. While in the liquid-based cytology, we have the liquid prep solution. In this, the cytobrush is broken after taking the sample and it is centered. But here earlier, it was being said that the conventional pap is not giving adequate samples, and most of the sample gets discarded with the cytobrush and all those things. But it is recently noted in the systematic reviews of the randomized controlled trials that the sample collection will be more or less it is the same. It is not any different. but the way, how it is collected. Because most of our women, they will be having some inflammatory condition or some amount of bleeding will be there. When we collect the sample with a cytobrush or anything, the sample here, you can see the conventional smear has a clogged appearance and most of the cells, they can't read it as it is air dry. But when it comes to the liquid-based cytology, the clarity is more. That's where the liquid-based cytology is on the upper hand when compared to the conventional cytology. But whatever these are said and done, this belongs to the high resource setting. If possible, we are having, if you are working in the remote areas, and definitely VIA, VIL, and VIA will be playing a role. And if it is a high resource setting, definitely the conventional and the liquid-based cytology will be playing a role. Here you see, for whom are we going to do? In the limited resource setting, we go, when it is in the rural areas, it is 30 to 65 years age. We are at first stand at 30 years, and every 5 years they have to be motivated to come and do the visual inspection of the cervix. But when it goes to the target age group of a good resource setting, it should be 25 to 65. And here, as we know that the HPV infection prevails very much in 20 to 30 years of age, what we have to do is like a cytology is mandatory at 25 to 30, but LBC will be applicable only after 30, as most of them LBC with co-testing of HPV, sorry. Co-testing of HPV should be entertained only after 30, as it is more or less positive in less than 30 years age group. And the frequency, how frequently we do is like when it is a co-testing, you can upgrade it to 5 years, and if it is a simple conventional pap smear, it needs to be taken for every 3 years. Moving on to when to stop. For any resource type, it is like one and the same, 65 years should be the cutoff. But if they haven't, our Indian women are so reluctant, as very well said, even many of the doctors, they don't get screened themselves. If never it has been done for a lady in her life, and please do it at least at the age of 65. If it comes negative, then you can exit them from the screening protocol. But if it's a HPV, if you have treated them, there is a lesion, SIN 1 or SIN 2, and we have treated them. And what if, how long do you need to do the pap smear? It is definitely every 12 months we need to do the HPV or the cytology or a VIA. Then coming to, if at all they are like SIN positive and they have received the treatment, how long will be they under the screening procedure? There will be up to 20 years. If at all, most of the women in India, they undergo hysterectomy for some or the other benign conditions. And when they undergo for benign condition, they can no need of a screening for them if at all the SIN is not established in them. If you are not sure whether SIN is there or not, then please go ahead, do a pap smear for the wall, and then if it becomes negative, then you can exit them from the screening protocol. I mean, if you all need to do the examination, it's the discretion of the gynecologist again to check whether it's a complete hysterectomy or not. By examination, you have to do that. Then coming on to the follow-up of these women in SIN who had undergone the hysterectomy, it is definitely at the 6th month post-hysterectomy they need to undergo a HPV cytology, and also 18 months they have to undergo the HPV cytology. Then coming to the immunocompromised patients, it is always according to the age criteria itself, within the if at all the woman is starting her sexual activity even at the age of 20, we start the screening for them within 1 year after their sexual activity starts. And it always needs to be, again, depending upon the resource setting, HPV, cytology, co-testing, or via baby or anything. And they need to be like followed every 2 to 3 years. And this is the Bethesda system, which has reported NILM and ASCUS high probability, and the L-cell, H-cell, and FCC, and the glandular abnormalities. And now this slide, I just want to emphasize whichever kind of resource setting you have. Please make sure you are looking into the cervix, you are checking it with acetic acid, you are checking it with uvalcine, and make sure if you have only those things, let it be. With that things also, though there is a subjective pitfall, still you can go for the cervical biopsy and send them, and we can catch hold of the pre-invasive lesions. If not, then follow switch to when you have a very high resource setting, then please go ahead with the actual protocol of a pap smear with the conventional or the HPV cytology. Moving on to, after speaking a lot about the HPV screen, the pap smears and screening and all those things, I would like to emphasize, now these are the things which we are talking about, all those women who are already exposed and who are deprived of vaccination, and the HPV vaccination which is new in the market is doing a tremendous job. But I can say that there is a lot of impact on its HPV infections, where in teens it is coming down almost to 88%, and in the genital warts or the young adults when they are presenting, it has come down to almost 81%. And in the cervical pre-cancers, they have been dropped to 40%. Yet more studies have to be coming, as this is like almost 10 to 12 years old vaccine present in the market. If we see that human papilloma virus, we have noted that there is E1, E2, E7, all those things are the early genes, and the late genes L1 and L2 component. We take the L1 component in this, the coding region is manipulated in the form of recombinant DNA typing technology. It is incorporated in the L1 capsid of the HPV into the host cell. This is the viral life particle. It is similar in size and shape, but it is not immunogenic. It is not at all infective. And sometimes it might also give a cross-reactivity and give some kind of protection even to those non-vaccine strains also. Then coming on to the HPV vaccine, what are the types available here? This information data I have taken from the FOXI DCTR guidelines. So here the other variant which is readily available now in the market is not added upon. There's a bivalent Cervarix ESK, and quadrivalent, it's a Gardasil available mostly. But the latest ones I would like to say is the nanovalent, and also we have the Cervarix. That's a newer vaccine available right now. It is for licensed, for what age group? Many of us will be having this doubt, what age should be given this vaccine? It is definitely 9 to 48. But there is no recommendation for this. If at all you have to say, the grade A recommendation only goes to the 9 to 15 years age group. Whereas more than 26 is again, it depends upon various consensus, and we will be seeing in the next slides I have put up that. And how many number of doses? For any girl less than 15 years who is not immunocompromised and who is not immunosuppressed positive or anything, they can be receiving 2 doses. That is 0 and 6 months. If at all they miss to take within 5 months of the second dose, it can be extended up to 15 months. That is the guideline saying. And coming to more than 15 years or the immunocompromised ladies, they need to, or girls or the ladies, they need to take minimum of 3 doses. And the dosage interval will be 0 and 6 months. Now, that is what I told from the second dose extending from 5 to 15. And 3 doses, that is 0, 1, 6 for the bivalent, 0, 2, 6 for the quadrivalent. Then coming to the catch-up vaccination. Who is this in catch-up? That is beyond 15 years age up to 26 years, they can be given 3 doses, but we have to emphasize them. This is going to have a reduced efficacy in them, though we are giving it as a part of protection against not only the cervical cancer but also other genital cancers, oral cancers, laryngeal cancers. So here we have to be mentioning about the reduced efficacy and also the importance of screening. Most of them think that they have taken the vaccination, so they are free from screening. No, they are not. So we have to tell them, if not for the vaccination strain, we should also look into other strains causing or some amount of discrepancy will be there. So they need to be regularly under the screening protocol, irrespective of they have taken all 3 doses or 2 doses. And if at all it is for more than 26 years also, it applies the similar way. The FOXI doesn't say anything about it. But IME clearly says up to 45 years in Indian scenario, you can be the vaccination. It can be a Gardasil, nanovalent or a quadrivalent, and the latest Cervarix also. HPV, Cervarix is the quadrivalent, which has come from the varicellum, and it's very cost effective. Government has recently incorporated into the national immunization program to vaccinate all the girls for less than 15 years, so that we reach the elimination point. Now, all those HIV girls and all those people, it is 3 doses, irrespective of they have to follow the age recommendation. And anybody is missing the doses, there is no need to revaccinate them, they can just take the missed dose. And coming to the pregnancy, it is not recommended in the pregnancy. Anybody is become pregnant after the 2nd dose and they are due for the 3rd dose, they can skip the pregnancy part, and in the lactation they can be allowed to take the vaccination. And in victims of sexual abuse, they can just take the vaccination according to the age recommendation. At the time of first examination itself, the first 0 dose has to be given. And women coming with any abnormal screening reports are also to be explained about the decreased immune protection, but with regular follow-up, they can also be offered. And this is the slide where I was talking about the Indian consensus recommendation showing for the age more than 46 years for immunocompromised, HIV infection, ischemia, complement deficiency, CKD, and heart-lung diseases, chronic fever diseases, alcohol, diabetes, and many hepatic cholangiopathys and all. These people are supposed to be given the vaccine. These are the recommended group. While it's a traveler, mass gatherings, or just a pregnant lady or anybody more than 46, it is not recommended. The key points before I conclude here, still so much is being done in the Western countries, and they are trying to reach the elevation point almost, but still India is lagging behind because we are still put under the low and middle income countries, and we have the inequities to the access, lack of national HPV vaccine, and the cervical screening and also treatment, which are determinants for the social and economic. And now coming to the HIV infected ladies, they are almost 6 times more exposed to the cervical cancer risk. So please vaccinate all the HIV women. And also prophylactic vaccination against HPV, screening, treating or pre-cancer lesions will definitely let us to make an effective strategy to prevent the cervical cancer, and it's very cost effective also, as we spoke about.
We are running out of time.
WHO global strategy is saying that they have come to a conclusion by 2030 it should be less than 4 per 1 lakh women. That is a set target for us, and the 3 things they want us to do is 90% of the girls to be vaccinated by the age of 15, 70% of women need to be screened with a high quality test by age 35 and 45, and 90% of women with the cervical disease receiving the treatment. But the data is still the women's screen in India is very poor, less than 3%, and the total girls here vaccinated are less than 1%. So let's pledge all today to eliminate the cervical cancer with an effective screening and a universal vaccination of all our little young girls. Less than 15, 9 to 15 years is the age. Thank you.
Thank you so much, Dr. Priti. Please remain on stage. We have to also felicitate you. And any questions from the chair?
Let me congratulate the Minister first of all. So actually I am part of this cervical cancer screening which we have done in 2005. So in that we found that the community participation was less actually. So we could screen only 40% of the population, and then we moved to self-collected vaginal swabs, and then actually the participation rate has improved, and then there was a nice agreement with the self-collected vaginal sample as well as the health sample. So the agreement was almost reached to 50%. So I think we need to move on to the point of care testing and self-collected.
Yes,
so any experience with the point of care testing?
Even the self-care testing starts to be encouraged, but with this also many of the women, they are not able to collect the samples properly. Inadequacy of the samples are being noted. That is what seen with the self-collected sample. But the patient's participation is improving a lot with them. But what we actually want for the elimination is not happening in that particular point. When the comparative study was done, that is what is noted with them. but definitely it will at least to promote them to come forward and take active participation in the screening programs in rural India.
So actually we were fortunate to get a grant actually this point of the testing.
It is not mandatory, we can just right away go for vaccination and they can be put in the normal screening protocol as per the age information. As in the previous slides as I was saying, sir, even as a HPV positive or C positive also, they can be given HPV vaccination, telling them that the protection is not up to the mark, but they will be definitely giving protection from other cancers and other cancer. It's not just the cervical cancer which is giving protection.
Any questions from the audience? Please raise your hand.
It is not required. Any one vaccine should be enough because there is some amount of cross-reactivity which is again protecting against those. It is again a cost-effective process where the nanovalent is still very costly procedure, like cost expensive thing. So there is no data given regarding repeat vaccination. There is no recommendation for the repeat vaccine even if they miss the second, they take the first dose, second dose, and somebody don't take the third dose. They can just take the third catch-up dose, but rather than repeating all 3 doses.
So what about the other strains? Both strains are covered in
Yes.
So what about the other strains?
This is like still the nanovalent is very new in the market. Yet it has to be like a delta. There is not much data about what you were asking, like already quadrivalent vaccinated and they need the nanovalent or not. But definitely as per the consensus right now, it is not mandatory to take it. Because the other strains, which main strains where we are focusing is 16, 18, 6 and 11. The 16, 18 are more concerned, that will be covered. Whereas the other high-risk strains whichever are there, that is not of much significance, though they have a little bit. I need to check on this actually. They can mix up the thing, but it is not. Madam is asking like completely they have taken the quadrivalent and now again they want to take a nanovalent of again 3 doses. Though this is a recombinant viral-like particle, still it is not recommended in the consensus. As per now, it is not recommended. You can tell them like they can wait for a time being because even we are not sure how it is going to act upon. Yeah.
Alright, any more questions? Thank you so much, Dr. Priti. I request you to please remain on stage. I request, yes, Dr. Kalpana ma'am, can you please felicitate Dr. Priti. Thank you. We move on to our next presentation. I'd like to invite on stage Dr. R. Meenakshi, Consultant Gynecology, Medicover Women and Child Hospital. Yes, ladies and gentlemen, as you can read on the screens about Dr. R. Meenakshi, she has completed her MBBS from Rajiv Gandhi University of Health Science, 2005, and her expertise being cervical cancer screening and management, gynecological and obstetric procedures, instrumental vaginal deliveries, and we can also see her past experience. Thank you so much.
A very good afternoon to one and all present here. I would like to thank the organizing committee for giving me an opportunity to talk here regarding abnormal pap smear, the diagnosis and management, and the recommendation all the guys too. So as Dr. Prithvi has already told us about the impact of HPV vaccine, we now go into the realm of what we can do when we detect an abnormal pap smear. So today's agenda would be more on introduction, context setting, the classification, treatment algorithms, and closing remarks. It is a very vast topic, and I will try and run through it. What I am going to do is basically run the flow charts from the GCPR guidelines of the policy, which have been tailor-made to our Indian scenario, which gives you what we can do in every setting, whether it's a low resource or whether it's a high resource. So cervical cancer, as she's already said, is a major public health problem, and the prevalence of abnormal pap smears is around 3.4%, and the primary cause of an abnormal pap smear is association with the HPV virus. When we talk about the pap smear, we have to understand what is the transformation zone. So it's also known as the transitional zone. So if you look at the cervix, we have an ectocervix and an endocervix. The ectocervix is composed of non-keratinized stratified squamous epithelium, and the endocervix is just a simple columnar epithelium which also have glandular cells that secrete mucus. So the squamo-columnar junction actually connects the squamous with the columnar epithelium, hence it's known as the squamo-columnar junction or the SCJ. So this position of the cervix varies. It develops due to a constant remodeling process caused by uterine expansion, cervical enlargement, and hormonal state. So the transformation or the transitional zone is a region of the cervix where the columnar cells are continuously being converted into a squamous cell. So basically an area of tussle, because there is an inner columnar, outer cervical, there is a constant tussle happening there. It's a dynamic zone and it is a metaplastic zone. What do we mean by metaplasia? Where one adult cell type is replaced by another adult cell type. So this is where the tussle is going on. And during this process, the original squamo-columnar junction, which is inside the inner columnar, begins to come out, and there is a replacement of that columnar by the squamous. So the most typical location on the cervix for development of aberrant cells is the transformation zone, because that's the area of greatest mitotic activity. So the cervical cancer screening requires acquiring cells from the transformation zone of the cervix. The progression of epithelial alterations, as already mentioned, from precancerous to invasive, takes several years, giving us lots of opportunity to treat the disease in the pre-invasive stage and preventing it to progress into invasive or frank cancer. So when we are looking at a frank carcinoma, we know we have failed. That is what the disease is actually telling us. So as a result, there is enough precancerous phase screening, identification, and management. Now, as I told you, the transformation zone on colposcopic examination is used to assess and identify any abnormality and requires additional care or follow-up. More than 90% of precancerous lesions originate in the transformation zone, and these are critical dynamic markers in the transformation process. We need to understand it's a zone of great dynamism, and examining that zone, getting sample from that zone is key. So when we talk about the transformation zone, we have three types when we do a colposcopy. A type 1 and type 2, the entire transformation zone is visible. In type 1, it is entirely on the ectocervix. In type 2, it is visible, but there is a far extension into the endocervix. In type 3, it is not entirely visible because it extends into the endocervical canal and is not fully visible. When we talk about anatomic pathology of a pap smear, we know there are two cell types. So your abnormalities are likely to arise from these two cell types, a squamous or a glandular. So this is just a picture to tell you one is an original squamocolumnar junction and the new squamocolumnar junction. And the area between the original and the new squamocolumnar junction is your transformation zone. This needs to be seen in a colposcopy when it is known as satisfactory, and this is from where the cells need to be collected. So a similar thing is how we look at it when we look at it through a colposcope. So when we talk about the pap smear result, we also need to understand one thing, that the results of the cervical cytology cannot be used to make a definitive diagnosis or start treatment except when it's already an HSIL. Rather, the results are used to guide further evaluation with colposcopy and/or biopsy, and treatment decisions are based upon diagnostic results from such an examination. So when you talk about the normal pap smear, it can either be normal and will be negative for intraepithelial malignancy, or it can be an ASCUS, an LSIL, ASCH, an HSIL, and a carcinoma. So when we talk about squamous cell abnormalities, we're talking about cervical squamous intraepithelial lesions, because these abnormalities tend to remain in the epithelial, stratified squamous epithelium, which is multi-layered. So you have an ASCUS where it is atypical squamous cells of undetermined significance. We have an ASCH, that is, it cannot rule out or exclude a high-grade squamous intraepithelial lesion. Approximately 5 to 10% of ASCUS or atypical squamous cells can be designated as an ASCH. So when we talk about an LSIL, it is a low-grade squamous intraepithelial lesion, and this is probably associated with a histological diagnosis of CIL. So here we're dealing with two types of abnormalities. A cytological abnormality will give you a result as an ASCUS, an ASCH, an LSIL, and HSIL. Whereas when you take a biopsy is when you will get it as either a CIL1, a mild dysplasia, CIL2, a moderate dysplasia, or CIL3, a severe dysplasia. So one is a biopsy specimen, the other is a cytological specimen. So we need to have that clarity. So when we look at atypical squamous cells, these are the most common abnormal pap smear diagnosis. This diagnosis usually correlates with the HPV infection. This can reflect precancerous changes in the cells, but may also be caused by inflammation or as a response to trauma. So ASCUS doesn't actually give us a very big red flag. When we look at atypical squamous cells cannot exclude a high grade, what we mean is, this is rare, it requires colposcopy to tell you that there is no high grade lesion. So you definitely need to evaluate an ASCH. When we talk about a low-grade squamous intraepithelial lesion, this covers the spectrum of changes that can potentially progress to a squamous cell carcinoma. But this finding is highly suggestive of an HPV infection, and this includes CIL1 or myelodysplasia on a biopsy. While this finding is present in 2%, the good sign is over 2 years, 85% of LSIL will regress, and less than 25% will actually progress to HSIL. So even an LSIL is something that's not very worrisome for us. What do we mean by a high-grade squamous intraepithelial lesion? So this definition is for abnormalities in squamous cells with a serious concern for progressing to cervical cancer. This finding is suggestive of an HPV infection, CIL2 or CIL3 or moderate dysplasia, severe dysplasia, or even occasionally a carcinoma in situ may exist. The last would be squamous cell carcinoma. This is rarely diagnosed on a pap smear. It's more of a histological or a biopsy diagnosis. When we now talk about the glandular abnormalities, because as spoken before, we have squamous abnormalities and now we're into the glandular. So when you're talking about glandular abnormalities, you have atypical glandular cells. They may be endocervical, endometrial, or not otherwise specified. Why is AGC so important? Because when you evaluate an atypical glandular cell, in 10 to 39% you may find glandular abnormalities of high-grade squamous or other glandular. Interpretation of an adenosine. So whenever a favored neoplasia comes, you still have to really think about what you're dealing with. The other terminology here in atypical glandular abnormalities would be endocervical adenocarcinoma in situ and adenocarcinoma. Now, what year report, we know that the progression through an invasive is less than 1%. You're not worried. When you're looking at an LSIL and only on cytology, it's 16, 5.2, 6.1. When it is associated with the HPV, that is HPV positive, it increases to 19 and 6.1%. But an LSIL with HPV negative, the chances are less than 5%. A similar thing with ascus, we know you have an ascus patch here only on cytology. The chances of progressing to a CIN2, 3 or an invasive are between 6 to 0.18%. Whereas if it is a HPV positive, that increases to 18% and 6.8%. With an HPV negative on an ascus, your chance of progressing to a CIN2 is less than 1.1%. ASCH, definitely cytology alone, there's a 35, 18 and 2.6%. HSIL has got a high chance of progressing, 69, 47, 7.3. Atypical glandular cells, 13, 8.5, 2.7. And definitely squamous cell cancer itself is associated with CIL2 in 84, 84 and 68%. So when you look at what is the risk of progression, the FOGSI, luckily, the GCPR guidelines, which are the latest, have come up with recommendations based on you have a risk of progression of more than 5%, then a colposcopy is recommended. If the risk is between 2 to 5%, you can repeat testing in 6 and 12 months. 0.1 to 2% repeat testing in only 3 years. Less than 0.1% repeat testing in 5 years. This is just the background. As we go through what are the abnormalities, you will understand what we need to be doing. So treatment algorithms, we are lucky that FOGSI has come up for our Indian setup with the latest good clinical practice recommendations, and all my slides are from that because it's so applicable to our Indian scenario. So there are 3 types of levels of evidence. So one is the level A, which is recommendation based on good and consistent scientific evidence. Level B, based on limited or inconsistent scientific evidence. And level C is based primarily on consensus and expert opinion. So if you would want to follow, we would like to preferably follow a level A evidence. Now coming to the moving flow charts. So we first look at an ascus. We look at an ascus in the lady between 30 to 64. When you find an ascus in women between age 30 to 64, the priority is to do a HPV test. Why? Because we know when ascus is associated with a HPV negative, the chance of it progressing to a malignancy is less than 1.1%. So a triage is definitely preferred in women with an ascus. The level A recommendation is women aged 30 to 64 with an ascus should be triaged preferably with an HPV. Your HPV test comes negative, you can return to an annual screen, 5-year screening or co-testing, because you know that HPV persistence is what is going to lead to your further progression into either CIN1, 2 or 3. If they come HPV positive, we would prefer to go ahead and do a colposcopy and a biopsy. If the colposcopy is normal, you can repeat the co-testing at 1 year because it came as a HPV positive and you are worried about persistence of HPV infection being the main cause of progression. So repeating a HPV at 1 year becomes important. If it is abnormal, when you do a colposcopy and a biopsy, we follow as per the GCPR guidelines. The less preferred triage, that is if HPV facilities are not available, you can repeat the cytology at 1 year. So you're not ready, you do not have HPV. You can go ahead for cytology. The cytology comes negative, you go back to a repeat testing after 3 years. If the cytology at 1 year comes as a repeat ascus or higher and is an NSIL, a colposcopy and biopsy is recommended because now you have got a persistent ascus and you are not sure about your HPV, so progression chances are high. So then you look at a colposcopy and a biopsy. The colposcopy biopsy are normal. You will repeat the cytology at 1 year because you want to know that she is not progressing from an ascus to an NSIL. If it comes abnormal, you follow as per the GCPR guidelines. If it comes as an ASCH or an HSIL, you follow as per the guidelines. At any point of time, we find that the patient is not compliant or not willing to come for follow-up, there is no facility for follow-up, and over-treatment would probably be justified in terms of getting a VIA and a biopsy or a pap smear or colposcopy and a biopsy. So the 0.8 is the only thing I'd like to specify here. This is the same ascus. So women aged 30 to 64 with an ascus cytology can also be triaged with repeat cytology at 1 year if facilities for HPV are not available. So we have a role for HPV in ascus. I think that would be the take-home message for ascus. When we look at ascus or LSI in women between 25 to 29 years, we do not want to do HPV in this group of patients because the chances of HPV being positive are very high. We would rather only repeat the cytology at 1 and 2 years. If it comes as negative for intra-epithelial malignancy, we repeat cytology at 3 years, and then if that comes negative, we can put them back into the 5-year protocol of after repeat cytology. If your repeat cytology at 1 year or at 2 years comes as an ascus, then definitely go ahead with the colposcopy and a biopsy. If that comes negative, then you can repeat a cytology at 1 year. If that comes abnormal, we follow the guidelines. Again, if the patient is non-compliant, then pushing it for a colposcopy and biopsy will be important. LSIL, again, in women, we're looking at LSIL in 3 categories of women. We're looking at LSIL for 25 to 29, which is similar to the ascus, no HPV testing, follow-up with cytology as mentioned before. When we're looking at LSIL in women between 30 to 64, here the recommendation is to do a colposcopy and not a HPV. But in case you are doing the HPV, it comes positive, that should go ahead for a colposcopy and biopsy, manage as per the guidelines. If a HPV comes negative, we would still co-test at 1 year because the cytology is normal, we would go at HPV negative. You can again repeat co-testing at 3 years. That is also normal, go back into the routine screening. In case it comes as a cytology at 1 year comes again as an ascus or an HPV positive, then a colposcopy and a biopsy. If you do a colposcopy and a biopsy, then you manage as per the GCPR guidelines. At any point of time, the patient is non-compliant, go ahead for a colposcopy biopsy or a VIN biopsy. LSI in the postmenopausal age group, we have women with LSI should be triaged with either an HPV or a repeat cytology at 6 and 12 months or a colposcopy. So any of these are acceptable. If the HPV comes positive, we would go ahead with the colposcopy because you know it's a persistent HPV and then managing would be important. But if it is HPV negative, repeat cytology should be done at 12 months. If 2 positive test reports are negative, then the patient will resume routine screening. If the triage with the repeat cytology at 6 and 12 months, if the repeat test shows an ascus or higher, colposcopy should be performed. Coming to ASH, so ASH and HSIL in women more than 30 years, it is a direct colposcopy and a cervical biopsy. There is no role for HPV testing because you know that it is likely to be associated. You don't want to waste the money or the patient's money. So here we need to do a colposcopy. Here is the colposcopy adequate or not? That is when the question comes. If it is an adequate colposcopy, entire transformation zone seen, you take a biopsy, it comes as a CIN1, you have 2 options. You can do co-testing at 1 year and follow, or you can go in for a direct excision procedure base. In case it is inadequate transformation zone, or the transformation zone not completely seen, then a diagnostic excision procedure and follow as per the recommendations. So the probability of finding an ASH or an LSIL are only 0.17 and 0.21%. All women with an ASH cytology should be evaluated with a colposcopy. There is no role for HPV testing. These women are at substantial risk of developing a high-grade CIN or invasive disease and therefore requires further evaluation. The strategy for managing these women is to either do a colposcopy or an immediate leave. You do not have a facility to go ahead and send them for a colposcopy. You can go in for a diagnostic excision procedure. In a high-grade CIN, if the transformation zone is entirely seen, you may opt for an ablative, but the preference is always to do an excision procedure because you get a sample for histopathology and you know what you're dealing with.
Thank you, Dr. Meenakshi. We are running out of time. We have other speakers also with 15 minutes time.
I will just end this last with just on CIN 2 and 3 on histology. So whenever we get a CIN 2 or 3 on histology, We would like to see whether the colposcopy was actually adequate or not. That is going to be the determining factor. If it was adequate, then we would like to repeat the HPV and testing at 6 months and 12 months. And then based on that HPV negative, it is improving, we can put them back into the regular screening. Whereas in case it was an inadequate colposcopy, then going in for an ECC and going in for a leave would be important.
Right, thank you so much, ma'am. Yes, any questions from the chair? Yes, Dr. Mirza, Dr. Kalpana, Dr. Sulekha, any questions?
The study that I was mentioning, we detected around 12% PAP positive and 10% HBA positive and 10.2% was HPV positive. So I think, and then HPV was very sensitive and specific to the detection of pre-invasive and invasive cancers. So I think it's something that we need to promote HPV testing, but then even in the low resource settings, I think one of the methods we will have. So I think testing, and then hope the government of India will come with a very cost-effective HPV screening test.
So I think just 2 to 3 taking points. One would be in access and HPV trials will be extremely important because once you get an HPV negative, you don't have to worry. If you get an HPV positive, you know you have to keep her in your radar. Even LSIL also maybe repeat co-testing at maybe 6 months and 1 year with the HPV would also be applicable. As soon as you get an ASCH or an HSIL, there is no role for HPV testing. In follow-up, co-testing with the cytology and the HPV would be useful. When you know they are HPV positive, following up them at 6 months or 12 months would also be useful. These flowcharts are readily available on the net. My suggestion would be knowing them by heart is very difficult because we don't deal with this day in and day out. But having these put up in your clinic or in your center would help because at any time you have a doubt, you can always refer them back. Rather, I would say in a place like India, over-treating, taking an extra biopsy would be more acceptable by the patient rather than saying you come back after 6 months and I do a biopsy because we know loss to follow-up is significant. Just the last thing is we have a huge impact in terms of pre-invasive cancer screening because we're able to catch them. You do not need to treat early lesions. Even CIN2 in the reproductive age group can be observed. You do not need to treat. CIN3 also can be observed in case the lesion remains same at 6 months and 12 months. So over-treating is one thing we need to look at, but not losing the patient. So that's the balance we will need to be looking at when we're looking at pre-invasive cervical cancer screening and management. Thank you very much. I couldn't do justice due to the shortage of time, but I hope that makes some message for us. Thank you.
Any questions from the audience? Any questions from the audience? All right. So I request Dr. Sulekha to please present the momentum to Dr. R. Meenakshi. Thank you so much. I request all our speakers to please maintain the timing of 15 minutes as we have 3 more speakers coming up and we are also running in late for lunch. So I request all our speakers who are coming forward for the next presentations to please adhere to the timing of 15 minutes. I request the chair to be seated, please. We have 3 more speakers. Yes, we move forward to the session 2 cervical cancer oncology session. I would now like to invite Dr. Karthik Chandravalan, Chief Consultant, Surgical Oncology and Robotics, Medicover Hospitals, Vizag, to please step forward for the presentation on surgical roadmap, key considerations for treating early cervical cancer. And sir, thank you so much for being here. You've come all the way from Vizag and we are delighted to have you here amongst us.
Thank you, Team Medicover for inviting me here. As the only outstation speaker, it's my privilege to be presenting my overview of decision making in early carcinoma cervix. The key considerations for treatment: how do you go about deciding on how to treat the patients? Greetings from Visakhapatnam, first of all. So I will not go delve again into the basics. So this is how a patient presents to you in your clinic with cervical cancer. So what next? The patient is present with some amount of postpartum bleeding, intermenstrual bleeding, menopause spotting, weather and discharge, dyspareunia. What do you do next? You put a speculum, examine the patient, you do cervical power general examination, you do a rectal examination. You see a finding of cervical exophytic or endophytic ulcer or polypoid growth. And then you look for the weather and formations, examine the parametrium on the pervaginal examination and the rectal examination. Fairly, this is quite common, and even a postgraduate, newly passed out postgraduate will easily identify a cervix cancer once it becomes symptomatic. So what next? So people do a biopsy. It's either a direct punch biopsy, or if you see the lesion is quite small, you can do a colposcopic guided biopsy. If the lesion is very small, it may be an half a centimeter to 1 centimeter. You can attempt a cold knife cone biopsy. Sometimes if you have the facility slightly larger, you can do a laser incision. So then you get a biopsy with the report of squamous cell cervical cancer or adenocarcinoma. What next? So the gynecologists who have done their post-graduation before 2018 or so would have heard of this term of clinical staging. Clinical staging, suggests this clinical staging. You just do a provisional examination, rectal examination, speculum examination, if required a hysteroscopy or cystoscopy, cystoscopy or proctoscopy, and that's it. You give a stage to this. So that concept of only clinical staging for cervical cancer has moved away in the latest figure staging to a clinico-radiological staging. So it's not just enough to do a clinical examination, you also have to do a radiological examination to exactly stage the disease. Why do you need to stage the disease? Because once you stage the disease only, you go ahead with treatment. So what are the clinical parameters that we look into? We look at the size, expected size of the tumor. We get a idea whether the parametrium is involved. So in early cancer, in early cervical cancers, parametrium staging is very important. And then you look at whether the vagina is involved and whether the rectal mucosa is involved. All this you can put in clinical examination. But what are the radiological parameters that determines what the stage of disease is? You may think that the parametrium is not involved clinically, but if you do an MRI, you might have parametrium stranding and evidence of which upstages the disease. You might have nodal spread either to the pelvic nodes or the parietic nodes. What you think is a stage 1 cancer immediately gets upstaged to a stage 3 cancer because pelvic and parietic nodes are stage 3. Bladder involvement, again stage 4A. And then distant organ involvement. So all these data need to be there, especially in a resource-rich city like Hyderabad. So we are no longer, we talk of India as a developing nation, but I don't think we sitting here in Hyderabad are talking about Hyderabad as a developing city. It's a developed city. So we have to think of this as a high resource setting and we have to get things done. So what imaging? So the options in front of us are CT scan, MRI and PET CT. So when you're looking at CT scan, it's mainly advantages in knowing about whether lymph node spreads are not pelvic nodes or parietic node and of course the distant nodes. When it comes to MRI, it's very good for soft tissue delineation, especially when we have a doubtful parametrium, whether it is involved or not, whether it is indurated or not. You do a rectal examination, you feel the cervical growth, but it's an obese woman, we are not able to assess the parametrium properly. Again, MRI is the choice of investigation in these cases. And also, lymph node status, you can get either in a CT or an MRI. So the preferred choice for investigation in a clinically early stage cervical cancer would be an MRI of the pelvis and the abdomen, because it tells us more about both the parametric and the lymph nodes. So for anything more than stage 1, I would recommend either a CT abdomen and pelvis, or I would, if the patient is affordable, I would advise a PET CT scan, because it's already stage 2. We are more bothered about whether it is stressful. We are not going to talk about surgery. We are talking about radiation, whether it's gone to the pelvic lymph nodes or paralytic nodes. It changes the treatment a bit. So we have to take a call on that. So the revised FIGO staging, I mean, these are busy slides, but just the summary. What is stage 1? What is stage 1 CS cervix? The disease is confined only to the cervix. Stage 1, so in that you have stage 1A and 1B. What is stage 1A? Disease confined. This is microscopic. So only when you are taking a biopsy, you are getting a disease, then it is microscopic disease, stage 1A disease. And stage 1B is macroscopic disease. What you can see on a perspectival examination, or what you can see on a perspectival examination. So microscopic disease again has been classified into less than 3 mm and more than 3 mm. So largely academical discussion. So this and again in 1B you have the size differentiation. What is less than 1B1 is less than 2 cm, 1B2 is 2 to 4, and 1B3 is more than 4. So what exactly is early cervical cancer? 1A to 1B2, that is any cervical cancer lesion is less than 4 cm. More than 4 cm, gold is 1B3. It's still, the management has changed. So again, when it comes to stage 2, what is stage 2A, 2B? 2A is upper vaginal involvement, or upper toothed vaginal involvement, or 2B is parametric involvement. Stage 3, you have various discussions like whether it is going to the lower third of the vagina, or it is creating a hepatonephrosis, or the disease is extended up to the pelvic side wall. The entire parametrium up to the pelvic side wall is involved. And stage 3 is where you have pelvic involvement or parametric involvement. So what do you need on radiology? Whether it is gone to involved the parametrium or not, whether it is involved the lymph nodes or not. This is what you need on radiology to decide the next kind of treatment. So I'm talking about treatment of early stage, that is stage 1A, 1B, cervical cancer. How do you decide on treatment? So we can have large debates, huge debates on whether surgery is the ideal mode of treatment or radiotherapy. It's a special 1 hour debate on this topic itself for a stage 1 cancer. But let me tell you the pros and cons. So surgery preserves ovarian function due to, especially when cervical cancer occurs in an early age, you can preserve the ovarian function. And after doing the surgery, you get the exact pathological staging, because whether it is really spread to the lymph nodes or not, whether there is subtle involvement of the distant parametrium or not, whether there is lymphovascular space involvement, whether there is deep stromal invasion, all this tells us whether sometimes we have to give additional treatment, not just surgery, we have to give additional treatment to these patients. The cons are the short-term complications. The short-term complications, of course, it's a surgery, there is blood loss, it's a major surgery. There's a lot of difference between type 1 extrafacial hysterectomy and a type 3 radical hysterectomy. We have seen a lot of impressive videos so far. You will understand that we have to dissect later the nerves coursing in the parametrium, which can affect the neurological function, lead to urinary retention leading on to urinary tract infections. The risk of bleeding is higher, the duration of surgery is higher, whenever comorbidities are there, the risk of surgery is higher. And generally, if after surgery radiation is required, the complications are higher than you would use chemotherapy. However, so what about radiation? You don't need to put a knife on the patient. Most patients are relieved with that. It avoids surgical morbidity. But what are the cons? When you give radiation to a early stage cervical cancer patient, you cannot avoid irradiating the ovaries. You are predisposing all these patients with attain premature menopause. So that is especially when you are operating on 25, 30, 35-year-old or even 40-year-old patients. They have 10, 15, 20 years more of ovarian function. We are compromising the quality of life of these patients. Sexual dysfunction. Sexual dysfunction after surgery is only transient, maybe 3 to 6 months. But after radiation, there is vaginal shortening, fibrosis, loss of vaginal lubrication, and sexual dissatisfaction. So younger patients, this is a key consideration in deciding the treatment. The long-term risk of cystitis, proctitis, I accept that with the latest IMRT techniques, these complications are becoming lesser and lesser, but still these exist. And then of course, risk of bladder or bowel fistula or rectal stricture is a long-term, definitely exists. However, the general consensus worldwide is still favoring surgery because we are preventing ovarian failure, we are better sexual dysfunction in the longer run, and avoiding the long-term risk of cystitis and proctitis, and 20 to 20 years later there is a risk of second malignancies also. There are other complications like osteoporosis because of radiation to the early menopause associated with this. So what's the evidence? We are talking about the pros and cons. What's the evidence? There's probably only one good trial in such a common cancer, and this is published in 1997. Let me be brief. So cervical and recurrence rates are similar whether you do only surgery or only RT. However, the complications are higher if you do both surgery and radiation. So there was a 20-year follow-up published of this trial published in 2017. So again, the survival, the overall survival, the recurrence rates, the disease-free survival were all similar. So they concluded you have to take additional treatment based on these 4 factors. The menopausal status or age of the lady, the comorbidities, the histological type, and the tumor type. Menopausal state, a post-menopausal 60-65-year-old lady with multiple comorbidities, they doing the surgery might be more risky, is where you favor whatever in favor of radiation. Histological type squamous cell and adenoma can be, there are some high-risk histologies where you might decide on radiation. The tumor diameter more than 4 centimeters definitely, or 1B3 becomes definitely should be treated by radiation. So the ultimate aim is an early cervical cancer, we should aim to give only one modality of treatment, either surgery or over radiation. So we need to balance and select the patient's care. So need for pelvic lymph node dissection along with surgery only in stage 1A1, where the chance of lymph node spread is less than 1%, maybe you can avoid pelvic lymph node dissection. But in all other stages of pelvic lymph node, standard pelvic lymph node dissection has to be done. A brief summary. So when you clinically stage, clinico-radiologically stage the patient, you see a 1A1 disease. If there is a 1A1 disease in the initial biopsy and the margins are negative, maybe you can avoid further treatment. But if the margins are positive, either do a repeat colonization or in most cases what happens, a malignancy diagnosis, whether 1 year or whatever, we do a extrafacial hysterectomy, that's a type 1 radical hysterectomy. Already there have been a few presentations and videos on that, I will not tell you. So 1A2, so it's still microscopic, but 3 to 5 mm depth, we would suggest a type 2 radical hysterectomy or modified radical hysterectomy. And for a 1B cancer, 1B1 or 1B2, that is less than 4 centimeter microscopic tumor, a radical hysterectomy, that is a type 3 radical hysterectomy. So there is this subset of stage 2A1 which we didn't discuss actually. 2A1 is upper vaginal involvement, and A1 is less than 2 centimeters size. This again is treated more or less like early stage cervical cancer, and then we go ahead with surgery. So I'll not go again into the fiber classification or the problem of modification of radical hysterectomy. The other controversy that is there these days is about minimally invasive surgery in early cervical cancer. So a lot of propaganda against minimally invasive surgery in cervical cancer. We beg to differ, though there was an LACC trial which showed that the recurrences are slightly higher in the minimally invasive group, that is a laparoscopic group. Here is predominantly we are talking about all the studies, the 90% of the patients in this LACC trial were operated laparoscopically, not robotic surgery. So there is still, the jury is still out. There are a lot of other studies which say still minimally invasive surgery can be done. There are lots of proponents worldwide in large oncology teams with the high volume of cervical cancer work. They are still doing minimally invasive surgery for radical hysterectomy. So the takeaway sort of would be, and the data is not good for tumors which are less than 2 centimeters. So this 1 billion tumors. So if the tumor is less than 2 centimeters, you can still do MIS. Prefer a robotic radical hysterectomy because doing a robotic over laparoscopic is much more advantageous. I can do a robotic surgery with 25% more comfort than doing a laparoscopic surgery. This is the case with most people like this. A 2 to 4 centimeter lesion, maybe the jury is still out whether to do an open surgery or minimally invasive hysterectomy. In well experienced hands, the recurrence rates are quite low. You need not worry about recurrences. I'll skip this. What next if surgery after we get histopathology? There are some indications where if there are positive modes or parameter involvement, we have to add radiation to surgery. What to do? Just one slide on what to do with invasive cancer. You do a simple hysterectomy. You are not suspected serious cervix, but instantly you find a cancer in the liver. So again, if it is a 1A1 tumor with no lymphovascular space invasion, you just have to observe. And then it's a 1A2 or 1B1. We tend to give adjuvant or RT. We don't go into rule the parametric dissection. So mostly we go in for adjuvant Eastern green radiotherapy and brachytherapy. So this slide, Ravi, Ramesh, should I present the video? So this is a video, it's a 12-minute video. I'll try to finish it in 3 to 4 minutes. This is a video of a robotic radical hysterectomy and see the comfort with which we can do a robotic surgery. So, robotic surgery enables the surgeon to do the work of 3 people. Here I am operating the camera. I am operating the 2 instruments with which I am doing the dissection, and I am operating using the 3rd instrument for retraction. So 3-in-1 function. And look at the way we are able to articulate, move the instruments. You have the endurance function where you can move the instrument in 360 degrees. Is excellent for suturing and in complicated surgeries like the radical hysterectomy, like the type 3 radical hysterectomy, where you have to do a lot of dissection around the ureter and the major vessels. Here I am doing the pelvic lymph node dissection. See the comfort with which one surgeon is able to do all this. I hardly require the assistance of the a junior surgical oncologist or junior surgeon beside me. A nurse is enough to help me do this entire surgery. And the traction that needs to be maintained by dissecting these critical structures is very well given by the by the robot itself. So this is a pelvic lymph node dissection. Again, the entire details were shown in the excellent video for Dr. See that the ureter is coming into picture here, and then the uterine artery. You have to do a meticulous lymph node dissection, more so in cervical cancer rather than in endometrial cancer is important, but in cervical cancer, it's a squamous cell cancer. Lymph nodal spread is more common in squamous cell cancers, and you have to get all this potential lymph node bearing area out. So here, so the boundaries of the resection will be the area where the ureter crosses the common iliac artery, that is cranial extent. The caudal extent would be the passing of the circumflex iliac vein, and then immediately go to the operatory umbilical artery. Basically the lateral wall of the external artery in the genitourinary nerve. So we're getting all the lymph nodes here. There's a uterine artery coming into view. You take the uterine artery at the origin from the iliac artery, anterior region of the iliac artery.
So we have 2 more presentations and people are already waiting for the lunch time. So I request you to please, we can conclude the session.
Fine, I will conclude it there. I think I made my point. We can go to it.
Thank you so much, Dr. Karthik Chandra. I request Dr. Mirza Atharali to please present Memento. Thank you so much, Dimitris. We move forward to our next presentation, and I would request Dr. Pavan Kumar Janora to please step forward, the consultant surgical oncology Medicover Cancer Institute, Hyderabad, for the presentation on precision surgery, the transformative impact of TMMR on cervical cancer outcomes. Yes, ladies and gentlemen, as you can see on the slide, you have the expertise and the publications mentioned about Dr. Pavan Kumar. He has completed his MBBS, MS, General Surgery, MCH Surgical Oncology, FEDS, European Board of Surgical Oncology, FALS, and FMNS. And you can read the expertise and the publications. Post which we have another speaker, ladies and gentlemen, and then we may proceed for lunch. So I request you to kindly please bear with us.
Thank you very much. I am Dr. Pavan. I know most of you will be reading very hungry. I will try to complete my thing in limited time. And Dr. Karthik has spoken very good about this management of early cervical cancers and the role of surgery versus radiotherapy. And for most of the early cervical cancers and most of the tumors which are up to 4 centimeters, surgery predominate, and surgery, cancer surgery principle the guided procedures, and these tumors are unidirected and perifocal. So we try to remove that tumor with wider margins, and this is essential to have a good local control. So the current surgical treatment demands organ dissection with lymph node dissections to achieve microscopic clear margins. However, with these lot of type 1 or type 2, type 3 radical hysterectomies, even though we do that for most of the patients, we also find local recurrences, and these local recurrences vary anywhere between 5 to 50%. And to prevent or to decrease that local regional recurrence, we try to give adjuvant radiation, but it increases the morbidity. As I said, like when we combine with surgery and radiation, it increases morbidity to a greater extent. technique which is called as total mesometrial resection for cervical cancer. And this was proposed by this Hawken, and who explained or who proposed ontogenic anatomy of this surgery, and he described giving clear planes for the surgery. I just show that video in its right. It's all places about how we resect the tumor, and he has divided this thing into two compartments which are arising from Wolffian ducts or the Mullerian systems. So the genital tract which develops at the 6th week, it develops from this Mullerian component, and the understanding of this anatomy is very important for the performance of this operation. And this genital takes from mesodermal and mesonephroid systems will give rise to this component. So from the Mullerian duct, we get proximal unit and the distal unit. The proximal unit will give rise to bilateral fallopian tubes and the mesosalpinx and corpus and mesometrium, whereas the distal is the most complex one, and which develops into this parametrium, which is the most important, and the clearance of the parametrium is essential for any surgery of any type of radical hysterectomy. And we do this TMMR procedure. I'll just show. By open method, and here we perform first ovarian preservation of ovaries and do an extended pelvic lymph node dissection, which involves dissection of external iliac, internal iliac, obturator nodes, as well as we continue our dissection to the presacral and common iliac lymph node dissection. And this video is showing the extended pelvic lymphodectomy component. We are trying to remove the nodes all along the external iliac vein as well as the external iliac artery. As we move proximally towards the common iliac clearance, and once we enter this obturator fossa, we can identify the obturator nerve, and we try to remove the nodes extensively in this technique, taking due care to preserve this obturator nerve, avoid injury to the nerve. And this is the internal iliac. And the internal iliac vein is seen. Once this is all the fibrofatty tissue along this vessels are clear, we can even visualize the deeper planes, and we can even visualize the sciatic nerve. We can see the sciatic nerve, that is the sciatic nerve. This dissection is done. The most important component to create the planes in this surgery is mesoureteric dissection to identify the autonomic nerves, the nerves which are to be preserved in radical hysterectomy and all the complications arise because of the injury to the nerves. And the nerves are identified in this plane, and this is the mesoureteric dissection where you can see the pelvic flanking nerves visible there. And this is the ligation of the uterine artery position. And we go along the length of this ureter, safeguarding it and trying to avoid And once that is done, we try to clear the vascular mesometrium which contains the uterine artery, uterine vein, and the autonomic nerves. The autonomic nerves will be visible a bit later, and now we are going up to the entry of the ureter into the bladder, and that constitutes the vascular mesometrium, and we want to clear that vascular mesometrium. What we are holding now is the vascular mesometrium there. Because to avoid injury to the nerves, we try to be very careful. We try to be medial to the ureter, and that is the vascular mesometrium. And we can see the nerves below. Same thing on the right side. You can see the nerves and ureter being lateralized. And this is the ligament of mesometrium where the attachment to the rectum has to be separated, and this is what we are talking about, the common site for the local recurrence following the surgeries. And after completing the hysterectomy part, we continue to clear the presacral lymph node dissection. This is the presacral area. And the one which is looped with umbilical tape is the hypogastric nerve plexus, and this is the dominant lymph node dissection. This is how it looks after completion of the dissection, common area. External iliac and internal iliac, along with the veins, crossing of the ureter, stump of the uterine artery, obturator fossa clearance and obturator nerve. And this is the region place which shows the double ureter for the same patient for a patient, two ureters on one side with a single ureter. And this is the hypogastric nerve which goes along the sacral promontory, and it will receive pelvic flanking nerves which are visible now, and they form the autonomic plexus which go along the lateral side of the pelvic wall. And this is the specimen with paramecium, and these veins are the ligamentus mesometrium and the vascular mesometrium. Thank you.
Thank you so much, sir, for concluding it well on time. Any questions, the audience, and also the chair?
In the conventional surgery, we don't go along the planes of the embryological development. If we see in rectal cancer, because it has total means of rectal excision, which is along the embryological planes. In the same way, this TMMR will go in the embryological planes, where there are separate genitourinary system and the genital system. we go exactly in between, preserving the nerves.
Alright, I now request Dr. Kalpana Garu to please step forward and present the memento.
Just one last question. And does this reduce the surgical mobility, this PMMR, compared to any other laparoscopy?
Yes, basically no.
What is the benefit to the patient?
No, sir.
Yes.
Thank you so much. Yes, Dr. Pawan Kumar. Thank you so much for the informative presentation. Ladies and gentlemen, before we proceed for lunch, we have one last speaker in the house and then we can proceed for lunch. So I would like to call upon, Dr. Prabhakar M. Consultant, Radiation Oncology, Medicover Cancer Institute, Hyderabad, to please come forward and give your presentation on exploring radiation therapy, cutting-edge modalities in radiation therapy and their impact on management of gynecological malignancies. As you can also see, ladies and gentlemen, on the screen, we have the expertise mentioned for Dr. Prabhakar and also the designation qualification of the experience has been mentioned on the screen for you, for your information.
If there is no positive nose, it's 45 to 50 grain, 1.8 to 2 grain reduction with concurrent BT cisplatin. And cisplatin here is used as a radiosensitizer and is a standard of drug since my childhood. And the SID plan like 55 grain 25 fractions and primary and electrode will receive 50 grain, whereas parietic and ignorant node will receive 45 grain, everything in 25 fractions. So coming to the most important brachytherapy techniques, so we have three types of techniques. One is intracavitary that uses tandem and ovoid, tandem ring and tandem cylinder. And second is intercavitary plus interstitial, that is vena applicator. And third is interstitial applicator. So intracavitary applicator can be done as an OPD procedure with analgesia and stop IV sedation, whereas intercavitary and interstitial as well as interstitial can be done in theatre setting. So after extending radiation, we have to assess for the residual disease. So if the residual disease is within the median orbit of parametrium, so the dose coverage will be better with intracavitary techniques. But if it is extend beyond the median orbit of parametrium, the dose coverage will be adequate. So that we have to choose either intracavitary or interstitial technique. And these are the intracavitary applicators most commonly used. We use tandem and ovoids. And tandem ring. The tandem is inserted into the uterine cavity, whereas ovoids and the rings are kept at the vaginal orifices. And this is a dose distribution showing a pear-shaped distribution. So this image shows the yellow line is a the pink is the residual GTD at the time of brachytherapy. So this patient had a very good response after PDRK and chemotherapy. So we have done intracavitary technique with tandem and ring applicator. So but science always is not like a math, it shows some miracles and stars. So what if patients is having extensive disease after extensive radiation? So then comes the interstitial applicators. So this is a Vienna applicator. So it consists of tandem and a ring with the provision for the interstitial needles. So yes, sometimes we play the role of surgeon also. After this, the patient is subjected to the imaging, either MRI or CT. After that, we have to control based upon the astro guidelines and the 16-week plan, and the radiation dose is delivered. So this, you can see the difference between the intracavitary as well as interstitial applicators. You can shift the ISO dose curve to completely cover the GTP with the help of the needles. So perineal tablets are used whenever there is a very extensive disease after the extensive radiation. So multiple needles are placed, almost like 18 to 20 needles are placed to cover the intake parametrium as well as the cervix. So coming to the dose prescription, most commonly we use 7 gray 4 times and 9 gray 2 times. Both these dose fractionations have better local control with less side effects. And in general, if the disease is confined upon the response. So when to consider for post-op chemo-RT, so we call it as 3 P's. One is positive parametrium, positive node and positive margin. And in the RT, when to consider only external radiation, 3 things we have to look. One is lymphocyte space invasion, second is stromal invasion and tumor size more than 4 cm. And when to boost vagina, if there is a positive vagina, boost it with the brachytherapy. So complications are acute radiation, cystitis, proctitis, bone marrow suppression and gene toxicity. And late we can encounter urethral stricture, rectovaginal fistula and lymphedema surveillance and endonephrosis. But all these side effects can be managed conservatively. And endometrium, we use vaginal cylinders for brachytherapy, and as you all know that early stages we have to consider for brachytherapy. If the age is more than 60 years and tumor is more than 4 cm or lithosphere space involvement, and if it is high grade and more positive, we have to consider for EPRT as well as chemo also. And recently the molecular phenotypic categories are shown, and there is a P53 mutant present with mitochondrial inhibition, we have to consider for external RT plus concurrent chemo as well as or EPRT followed by chemotherapy. So and this is radiation oncology team, and I thank Dr. Babaya and Dr. Ali for being the mentor, and teamwork is really good. Thank you.
Thank you so much, Dr. Babaya. And any questions from the chair? During the lunch, yes. And please feel free to, post your questions to all our panelists here during lunch. And in the meantime, I request Dr. Sureka Garu to please present a memento to Dr. Prabhakar N. I request Dr. Pamela Banu to please step forward to present mementos to all our chairpersons present here on stage. Yes, can we have the saplings? Yes, for our chairperson, thank you so much. Dr. Mirzani. Dr. Kalpana Garu. And Dr. Sureka Garu. Thank you so much, Dr. Pamela Banu, ladies and gentlemen, for participating on our chair people. And yes, my dear friends, you can please proceed to lunch and please reconvene by 3 o'clock so that we can continue with our sessions. Request you to please reassemble by 3 p.m. Okay, by 2:45 please. I request everybody to please make sure that you are seated well in time for the next sessions. Thank you.
अभी अभी
उसका एक काम करोगे పర్లేదనుకుంటా వాడు ఉందా
When asymmetry, it is seen in one projection, it is asymmetry. It is seen in two projections of focal, global and developing asymmetry. Focal asymmetry is visible on two projections. It has to be differentiated from a mass. Global asymmetry consists of an asymmetry over at least one quarter of the breast, and developing asymmetry is a new, larger and more conspicuous than a previous examination. So we can see asymmetry in medial lateral oblique and CC view. This was just a parenchyma, it was not a mass. The focal asymmetry. You can see architectural distortion. When normal architecture is distorted, here there was no definite mass and biopsy was only scar tissue. So coming to calcification, what are benign calcification and what are suspicious malignant or suspicious morphology. So left hand side are benign and right hand side are malignant calcification. These we'll see in detail with images. So these are all typical. Vascular calcification, usually along these vessel branches, round and punctate calcification. These are all benign calcification. Coming to suspicious calcification, these are usually fine, pleomorphic, varying in sizes, can be linear, branching, can be coarse and heterogeneous, can be amorphous. So usually fine linear branching, fine pleomorphic and coarse heterogeneous, these are suspicious calcification. So to study all these findings, we will give a final assessment categories. Usually we don't give R at 0. We usually do ultrasound if it is extremely dense breast, we will perform ultrasound and we'll give the category ranging from 1 to 6. 1 is negative, 2 is benign. This patient returns to annual mammogram screening. SP is probably benign. There is one feature of malignancy is present. 4, there are some features of malignancy suspicious. 5 is highly suspicious of malignancy. And 6 is known biopsy fluid. If anything is found suspicious, we usually go ahead with efficacy of biopsy in our practice. So what are the associated features we see? Skin retraction, nipple retraction, skin thickening more than 2 mm, clavicular thickening, axillary adenopathy, architectural distortion, calcification. These are the associated features in nodal mammogram. So we'll see some interesting cases. So how do I read mammogram? So this is the mediolateral oblique view. This is the upper quadrant. This is the nipple. We draw a line from the nipple, and this is the upper quadrant. The below one is the lower quadrant, and both the pectoris major muscles should be visible in the MLO view. And here you can see there are multiple round density with popcorn calcification. So what is the diagnosis? Fibroadenoma. This is CC view of the same patient. The CC view, the convention is the lower half is the inner quadrant, the upper half is the outer quadrant, and both the breast CC view are joined together. So this is the CC view of same patient, and you can see this popcorn calcification, similar small round capacities are present in both breasts. This was a biopsy too. Another patient CC view, MLO view, where we see a large, well-defined opacity and dystrophic calcification. Similar lesions present, similar smaller lesions are present in both the breast. This is the CC view of the same patient. Diagnosis. These are also fibroadenoma, so they are larger in size. This patient presented with breast lump. You can see in the CC view, same point of view, large lucid lesion is present. The left breast, which is displacing the glandular parenchyma to the opposite side. This is the CC view, showing a large lucid lesion. So low density well-defined lesion, as you see in the description. Low density is usually fat. If you see the fat, it is almost matching the same density. So the low density lesion are usually fatty. This was the lipoma on ultrasound. This is another patient CC view, outer quadrant of right breast, very well defined margins. The CC view, very well defined margins. Density is almost equal to the parenchymal density. This was another patient. She complained of bilateral breast masses. You can see the equivalent parenchymal opacities, parenchymal densities in both breasts. Both are involved in the analogy. So she was a diabetic, not something suspicious, so the level is Barrett's 4, but this came as a diabetic mastopathy. So usually this is a very rare diagnosis. Typically it's a bilateral, and this is a parenchymal, usually parenchymal fibrosis due to diabetes. So another patient presented with left breast mass. You can see two masses here in the left breast inner quadrant. There is architectural distortion, highly cellular or high density mass with ill-defined margins, seen in the upper central region with multiple axillary lymph nodes. So this was a suspicious morphology. Label is the Barrett 5. Biopsy was done. It was a invasive carcinoma, ER positive, PR positive, HER2 negative. So this fits in the luminal A molecular subtype of breast cancer, which is ER positive, PR positive, HER2 negative. This has a better prognosis compared to the triple negative, which is ER, PR and HER2 negative. In another case, you can see in the upper quadrant left breast indefined mass, the margins are lobulated. Axillary lymph nodes also seen. This was the MLO view. And note that in the CC view that mass was not covered. This patient also underwent biopsy, and biopsy was invasive carcinoma, again ER positive, HER2 negative. This is another patient. She presented with right breast mass. We don't see any well-defined mass here, but what we can see is, what is this? It's microcalcification. So this is all scattered microcalcification involving both inner as well as outer quadrant. So MLO view, multiple scattered microcalcification seen in the upper quadrant. The entire upper quadrant was involved. So this patient underwent biopsy as well as surgery. So it revealed invasive carcinoma with extensive DCIs. ISC suggested PR positive, PR negative, HER2 positive. So another female presented with left breast mass. So where is the abnormality? Right or left? Left side. Yeah. So you can see a large mass in the left breast. And what is this? Can you notice the screen? The right screen, can you compare right and left? Yes, so there is a screen thickening, so pleural appearance. This is the MLO view. You can see a large mass and also axillary lymph nodes. See the density is high density. Usually high density lesions are malignant. We have seen a lucent lesion, it was a lipoma. So this is the opposite of that. It's a high density lesion. This was also suspicious. We performed biopsy on it, and this was an invasive carcinoma. It was a triple negative. PR negative, PR negative, HER2 negative. So usually triple negative are more aggressive, and luminal A type they are less aggressive and have good prognosis. Why is it important to diagnose them early? Because they are very aggressive and they can metastasize to lungs and other body parts. So this is another use of mammogram. This we can see the mass here. And what is this? I think surgically taken. Yes, metallic clip. Usually metallic clip assessment usually telling patients which are they undergoing neoadjuvant chemotherapy for proper localization of residual tumor. Because sometimes with chemotherapy these tumors sometimes they completely regresses. We cannot see in the follow-up study. So this clip, sometimes only we can see this clip only. This is done for usually patients who are undergoing neoadjuvant chemotherapy. So this was mammography. This is specimen. This wide local excision was done in this patient, and this is the wide local specimen showing a residual tumor in the center with the hyperdense metallic plate. This patient history is she underwent breast conservative surgery on the right side.
You can see something here. CC view. Something here. Any guess? Post BCS? So this was actually normal appearance of post BCS breast. So more and more BCS surgeries are done. This was the post BCS scar. You can see also the skin deepening on the right side. This was the post starting changes. So post BCS scar in the right breast. Just notice the parenchymal volume. Compare the right and left breast. You can see the volume loss in the right breast compared to the opposite side. Notice the parenchymal volume left breast and right breast. So this is the post BCS normal appearance. So to conclude, for average risk women, start annual mammogram at the age of 40. For high risk group women, start screening early, depending on the age of the cancer in the relative or in the family history. And then X-ray mammogram and ultrasound are the basic modalities for diagnosis and characterization of breast mass. Consider MRI as the problem-solving tool, especially in dense breast. And clinical breast examination in remote areas where screening testing is not available can be useful too. Thank you.
Yes, thank you so much, Dr. Vikas Yadav. Any questions from the chair?
Like you said, screening, we've been advocating screening for Indian population at a younger age, because on an average what we see is the Indian patients are all at least a decade younger than the Western population. So right now I think even the Western population, they have moved their screening guidelines to 40 years. So that is one thing which needs to be stressed. Mammogram screening should start at 40 years of age. And the second thing is when we give a BALADS 3 or BALADS 2 and the tumor, fibroadenoma is the commonest thing which we see, but if there is any lobularity or any suspicion and the patient doesn't want to go for a surgery, or because we are seeing breast cancers even in 20-25 years of age, and I have patients whom we thought on mammo or whatever it looked like a fibroadenoma, they didn't want an excision. So all that we told them is if you are going to wait, better do a biopsy and wait. So they have done a biopsy. There are a few patients which I have seen even BALADS 2. But turned out to be malignant. So if the fibroadenoma is smaller than 1 to 1.5 centimeters or something, I think probably there is a role for conservative thing. But anything more than 2 to 3 centimeters, if the patient is willing for a surgery, that's to excise. Or if the patient is not willing, at least get a biopsy done.
So any patient with family history presenting with breast lump in early age, you should undergo biopsy, definitive biopsy. I think that should be done.
Biopsy always. Definitely sometimes might show some.
Definitely for smaller lesions. Biopsy definitely with a larger lesion, biopsy should be done.
Yes, any questions from the audience?
Yeah, definitely AI and machine learning, they have improved smaller lesions. Yeah, they are available internationally, they are available in US and other countries, but still we don't have those platform here. But definitely smaller lesions they pick up better, especially 3D mammogram. Ours is usually 2D mammogram, so they perform 3D mammogram.
One area we are seeing common nowadays, getting a lot in news and technology spaces, is about thermographic imaging using AI now. What's your viewpoint as a radiologist on that?
Thermographic point is not very specific actually. It's just to detect eye spot, like a spot which is showing more thermal activity. So I don't think so it can replace or it may be just a screening modality, like a population-based screening.
Mass screening.
Mass screening.
This is microscoping like India. Mass screening may help you filter cases.
From then we can select the cases and do mammo and ultrasound and then decide.
You do a biopsy on a mammogram case.
Definitely we do first mammogram and we have to localize. Obviously we have to localize. Without localization I cannot do biopsy. No, but what they are using then? They are stopping mammography as screening model and what they are using. But older patient definitely mammogram is very useful. We can do ultrasound for younger patients. For older patients more than 40 years, especially when the density of breast goes down, like becomes more fatty. So mammogram is better than ultrasound.
But how sensitive is ultrasound for detecting microcalcification?
Yes, mammogram is more sensitive. Mammogram is more sensitive than ultrasound.
So you're likely to miss on it, but particularly with such a high prevalence of breast cancer in India, I think it's better we still stick on to mammogram. Yeah, that's not, that would be my opinion. Really mammogram. Annual mammogram.
Before that, ultrasound.
Are there any specific use cases where you will recommend, even though low thyroid score, you still recommend mammogram, MRI-based mammography?
Usually, ultrasound and X-ray mammogram is enough for our setting. But if there is any doubt, we will go with MRI first and we'll see the dynamic contrast, enhancement pattern. So, based on enhancement pattern, we can distinguish whether the benign or malignant in the MRI. High risk cases. That depends on the age. Like if a patient is like elderly patient, usually do it with mammogram only. And usually we do ultrasound screening. It's not like that only we do mammogram. So after performing X-ray mammogram, we do ultrasound screening. We should go for ultrasound.
Then if you get any doubt, also can you go for
Like if you doubt, we directly go with biopsy.
షూట్లో ఉన్నాం మళ్ళీ మళ్ళీ చేస్తాం మళ్ళీ చేస్తాం
Mammogram may not pick up, mammogram may not pick up the abnormality in the younger patient. So usually perform ultrasound in younger patients.
Alright, with that we conclude this session. I request Dr. Amit Durwani Garu to kindly please present the memento to Dr. Vikas Nagar. Thank you. Our next speaker, ladies and gentlemen, is Dr. Praveen Adusumati, Senior Consultant, Medical Oncology, Medicover Cancer Institute. I request you to please step forward to give your presentation on from discovery to decision, evaluating breast, lungs, and planning treatment sequencing. Over to you, sir.
Very good afternoon. Thank you for this, Dr. Rajan, sir, and organizing team, marketing team, and all the delegates for making this event very successful. I think covering breast, lungs in 15 minutes is not possible. I think Dr. Andres and my team might arrange some more one day meeting here, so it is possible. So I'll try to briefly tell about how to make the diagnosis and what are the various options of treatment that are available for breast cancer management. This is the article that came in the week magazine in April 2024. Yearly, almost 12 lakh new cancer cases are being diagnosed in India, out of which almost 4.5 lakh to 5 lakh people are being shut. Of these cases, almost 2 lakh new breast cancer cases are being diagnosed in India. In women, breast cancer is the most common cancer, and combining both sexes, male and female, breast cancer is the most common cancer in India. That is why we all, whether we treat them or we don't treat them, we will encounter a breast cancer patient. Not only our patients, they may be our friends, relatives, or neighbors. As told by Dr. Ravi previously, a lot of breast cancer patients are also being seen nowadays. So we should know definitely how to evaluate these patients. So this is an article that was published in 2021 from various, after analyzing the data from various population-based cancer registries. The conclusion of this is because of various changes in our lifestyle, urbanization, and everything, there is an increase down, and because of the better screening techniques and because of the urbanization and variation of lifestyle also breast cancer is being diagnosed more nowadays. The alarming point is it is being more diagnosed between ages of 25 to 59. That is the conclusion stage. It is being diagnosed more in the ages of 25 to 59, not above 60, not above 60. So we all should know about the effective screening strategies which is told Dr. Vikas previously and how to diagnose it. So these are the various risk factors we all know from our MBBS days: early menarche, late menopause, late age at childbirth, and the use of OC pills and various things. This picture shows what is the risk percentage with all these risk factors. When a woman comes to us with a breast lump, these are all the diseases that we will be having roughly in our mind, and we need to sort it out. So basically it is based on the age, but nowadays we are seeing a lot of cancers in females also, so it doesn't work out. So these are some of the most common benign diseases that we see. Most common is the fibroid tumor. It can be a breast cyst, it can be a breast abscess, it can be a fat necrosis, if there is a history of trauma. It is a lactation tumor, it can be a also. Well, coming to the managing disease, these are all the options we see. So invasive ductal carcinoma, invasive lobular carcinoma. One of the most common diagnoses we see as an oncologist is non-invasive like ductal carcinoma in situ, DCIS, and less than 5%. It is not uncommon. We see sarcomas of breast, we see breast lymphomas and thyroiditis, and metastasis to the breast from another primary also. Yes, the chance is less, but 1 to 2% of cases we see these clumps in breast also. So a woman came to us with a breast lump. What is our diagnosis approach? So first of all, everything comes out of this only first physical examination, which we have been taught from our MBBS days. Look at the physical examination, look at the symmetry of the breast, size, shape, always compare with the opposite breast. Look at the changes in the skin, beauty of the skin, any retraction, any ulceration is there. Look at the nipples, whether there is any symmetry, whether there is any inversion, whether there is any retraction, or whether there is any discharge. Proper palpation, correct position against the chest wall in vertical surface, ideal approach with finger pads is advised as we all know. And always examine the other breast. And always examine the axilla. Same side and opposite side also. Examination of the axilla is a must. It only completes the breast examination. So after physical examination, we will be having some idea or theory. The next investigation of choice is radiological investigation. As told by Dr. Vikas, if the patient is less than 30 years of age, over 30, it gives a very valuable information, whether it is a 35 months or whether it is 85 months, whether it is 4 years or 8 years. These basic information sometimes you will write in there in 60. Is there any fluid? So all this basic information we can get from an ultrasound. Small medical lesions can be made out very easily. If at all we have any suspicion that the woman's age is less than 30, do a pregnancy and get a mammography done. As someone is also previously asking whether it is stone or nano, it always goes hand in hand. We call it as a stone mammography, and we always correlate findings to each other investigation. So less than 30, mammography, if doubtful, do a pregnancy and do a mammogram, and get some idea of what stage of thyroid disease and what are the diseases we are going to based on the data. For some patients, like patients having very less stress, or some suspicious lumps are there in the mammo also, and we don't want to go for invasive procedure directly, and we want to confirm. And some patients with very high risk and BRCA mutation carriers, we can get more information with contrast MRI. There are separate screening guidelines for high risk patients also, as well as Dr. Vikas. In those patients also, we may be alternating doing mammo and contrast MRI also. These are the key radiological investigations we have in our hand after seeing a lump in the breast. Yes, this lump, we did a mammo, and it is looking like 5 lakhs for the lesion. We know we need to involve in an investigation and confirm the diagnosis. what is the next step in diagnosis, what kind of things. So this is the algorithm for a woman with less than 30 years of age and based on her findings. We proceed with this. As per the Dr. Spears right on the annual screening program, biopsy, repeat number in 16 of time. Biopsy, confirm what is the lesion with the particular biopsy. So, dust lumps are heterogeneous. That is the thing we all want to regulate. So there will be fat inside, there are ducts and everything, everything is there. It is a heterogeneous. Always do biopsy. No appendices. You might use the diagnosis. There is no doubt about it. And better to cut or go-dated biopsy must be done in trust. Why we need to do it, I'll tell you in the next step. If possible, just we do blind biopsies. Agree with it. But if possible, always do a guided biopsy. It is a guided approach. Because in the previous mammals also you have seen, there is a huge area of breast. But there is only one area, there is a often microcalcium fields and everything. You might miss it. So no chance is there. Always do a guided biopsy if possible. No appendices. Because if at all it is malignant, it can't differentiate between an incident cancer and invasive cancer. In appendices, it is very tough to do. So biopsies is a must. And if at all it is malignant, we cannot perform immunohistochemistry, which is the basis for managing a breast cancer patient on appendices. So always try to do that or bone needle biopsies. So we have done biopsy and since we are talking about oncology, yes, I am an oncologist, that's a patient with regarding only invasive breast cancer. So we got done biopsy, look at biopsy, it came as invasive ductal carcinoma. Next we will do immunohistochemistry, that is marker, estrogen receptor, progesterone receptor, AS67 is the vitamin index, and immunodermal growth factor receptor, that is up. These four markers we will do on the biopsy specimen. So coming to the staging, like any other cancer, we do AJCC or TNM staging. Based on the size of the lesion, it can come under T1, that is less than or equal to 2 cm, T2 less than or equal to 5 cm, T3 and T4 based upon the extent of the lesion till the chest wall or involvement of the skin. It completes the staging system. And you might be seeing a lot of prescriptions or reports, CT2 and 2, PT2 and 2. So there is always a clinical stage and there is always a pathology stage. So clinical stage comes after our examination, radiological and pathological diagnosis. So CT3 and 1 and 0, it is a clinical stage that is given to that lesion. So T2 and 0 is a stage that comes after the surgery. It is a pathological stage. For example, if the same pathological stage was given after giving neoadjuvant chemotherapy, for example, the specimen is in the most of H3 specimens after giving neoadjuvant chemotherapy, it is written as white T1 and 0. So there is always a clinical stage. Based on the clinical stage, we try to plan the treatment. Always note the menopausal status of the woman because that factor helps us in planning the treatment. And always note in the family or hospital history of previous cancers or there are. So complete the staging workup. For example, for the lesion size is very small, less than 5 cm, and there are no axillary inputs on the patient diagnosis. Generally, what they say is you can get away with just extra ultrasound and bone scan. You don't need to perform other scans. From stage 2B to higher up, yes, we need to evaluate thoroughly for the metastatic workup because the chance of metastasis is very high in higher stage. So we can do either the CBCT, chest and abdomen. Always imaging should include the ovaries also. This is the thing we want to remember. Or we can get a PET scan. So this is the staging workup. So before putting a knife or before giving chemotherapy, before planning treatment, one thing we all should remember is have complete plan of treatment in your hand. Have a complete proper diagnosis in your hand before planning treatment. So these are the essentials before planning. Complete biopsy report to the receptor status. Complete stage workup based on the stage and have the final clinical stage in your hand and know the organ result of the patient, any comorbidities are there in the patient. So this is the final diagnosis of a woman coming with a breast lump and is having cancer. So she is being diagnosed with invasive ductal cell carcinoma of the right breast, clinical stage B3 and 1 and 0 with above adverse status, and she is postmenopausal female with no comorbidities and no family history. So, well, before primary treatment, you should have this complete diagnosis in your hand. Then you can decide on how to treat them. So, I'll just take 3 minutes. Options of treatment. I think the management of breast cancer have evolved like anything in the last 2 decades. Nowadays, it's not only just MRM, normal RT and chemotherapy patient. So the survival is the same, whether you do only MRM or PCS. There is no difference in survival. So nowadays, they are doing minimal surgery, minimal amount of surgery with better cosmetic outcome, prolonging the life and with minimal side effects. So this is the motto today. So these are the 2 options we can have. That is either apparent surgery for the medical treatment or near-term chemo with or without anti-cancer therapy, or the surgery followed by adjuvant treatment. Like adjuvant treatment means it includes both chemo and treatment. So these are the why we need to give near-term chemotherapy. Near-term chemotherapy, the treatment of choice for breast cancer surgery. Any treatment that is given before the adjuvant treatment is called near-term treatment. Before surgery, we are giving chemotherapy mainly by 2 reasons. To make an inoperable cancer to the operable or to convert an malignant disease. And there is a concept called seeded soil hypothesis or in higher up stage, 2B and 3 and higher, there is chance of micrometastasis. The small tumors may be sitting somewhere in the soil. So, to target them and prolong the life of the individual, we will give near-term chemotherapy. So, these are the main indications of chemotherapy. I think there are 3 subsets of breast cancer. One is triple negative, as told by Dr. Vikas. 20% of the breast cancer patients are only 20% of the breast cancer patients are triple negative, and it is highly aggressive cancer. And to target these kind of aggressive cancers, NICT with immunotherapy is being approved nowadays and is the standard of care. And HER2 positive, almost 15 to 20% of the breast cancer patients are HER2 positive. Even though it is aggressive like triple negative, but we have a target here. We don't have only single target, we can use dual anti-HER2 agents. By using anti-HER2 treatment, the PCR is increased and survival is also increased. And hormone positive, the management of hormone positive is completely different. In the initial stage, early stage, yes, we can avoid chemotherapy in very low risk population. In metastatic stage 2, we can avoid chemotherapy. Many women are living with ER positive, hormone receptor positive, stage 4 breast cancer for years without chemotherapy. They are living happily for years with minimal side effects. So, take home, breast cancer is not a single disease entity. Tumor microenvironment is highly heterogeneous. Guided biopsy is essential for after diagnosis and diagnosis management before planning the treatment. Post-section, PCR, sentinel immunotherapy are all 3 movements in extent of the surgery and better hospital outcomes. Advanced radiation techniques have minimized the toxicity and improved the confidence. Near-term chemotherapy is standard for HER2 positive tumors which are greater than 2 cm, triple negative greater than 0.5 cm breast cancers. Early stage low risk ER positive and HER2 negative breast cancers are treated with hormone therapy alone. CD4/6 inhibitors and anti-HER2 targeted therapy significantly prolong survival in stage 4 breast cancer patients. There are many breast cancer survivors around us. Of course, we know few of the celebrities they are there. If we plan proper treatment, if we diagnose early, the success rate in breast cancer treatment is more than 95%. There are only less than 5% of the breast cancers are very aggressive, and unfortunately they don't respond much to the whatever treatment we do. Other than that, survival rate in stage 1 is 99 to 100%, stage 2 is 95%, stage 3 is 60 to 80%. Stage 4, we are able to save those patients from 2 to 4 to 6 years also. So we need to plan the treatment, we need to diagnose properly, we need to plan the treatment appropriately. Thank you.
Thank you so much, Dr. Praveen here. Any questions from the chair?
Thank you, Dr. Praveen. Very comprehensive, very clear picture given for early process or any approach towards breast cancer diagnosis and initial plans for treatment. Breast cancer, as you said, we are getting very long. So cancer in general is becoming a chronic condition. You continue medication, people live with it for longer years, even in advanced stages of disease. One question I had was around neoadjuvant treatment. As we know, radiation oncology, a lot of times patients with neoadjuvant treatment achieve complete responses. And once they undergo breast conserving surgery, we have to give almost all cases of breast conserving surgery need radiation. We may skip chemotherapy, but still radiation is needed for all the patients of breast cancer, be it early or advanced. So, how many cases do you, or how many times do you recommend implanting clips? We saw in mammogram.
For every patient, we give neoadjuvant chemotherapy. Ideally, clip must be placed. We see tremendous responses, especially with this anti-HER2 agents. And people like you nowadays, we are giving pembro also. So, ideal stand-up care is we should place the clip and then you neoadjuvant therapy, and don't trouble our surgeons, because if it completely disappears, they should know finally what to do. We just can't go blind based upon this previous radiological, because many times the patient comes to us after 2 cycles of chemotherapy, no clip was placed. After 4 cycles or 8 cycles, the mass is completely gone. Whether to do PCS, we don't know previous area, what we are targeting, ultimately we end up being in a lab. So obviously it's best to complete the recovery.
We also struggle as radiation oncology. We have to give boost to the tumor bed, and if we don't know where the tumor lies, sometimes we struggle with where do we give the boost.
What is that? Neoadjuvant chemotherapy has become more common. So a lot of times we don't feel a mass, but just because there is a clip, we can do a PCS. If there is no clip, then that's a problem. We don't know where we have to do. So sometimes what we do is what is called a quadrantectomy. That means we remove that entire quadrant. Probably that much of a resection is not required, but at least our thinking at that time is at least we are saving the breast. So we are removing more than what is needed, or sometimes it so happens that we have to do a mastectomy only, where we are not very sure where the tumor is. So we are doing more and more cases with just clip guided with a radiologist. So we'll be doing a preoperative marking and wire placement and do a surgery around that. So that is what has increased a lot right now. And like you said, post radiation, they don't know where to do. So for that also, normally what we do when we do a BCS, breast conservative surgery, of late we are doing what is called as an oncoplastic surgery. So we are doing reconstructions. So we are mobilizing the adjacent breast tissue to cover that entire defect. So the bed is something which is moved away. So that's what we do during a surgery, particularly when we go for an oncoplasty. After the breast conservation surgery, we place clips all around the bed. So mark at least the 4 quadrant, so that when the radiation oncologists have to give a boost to the tumor bed, we don't wait to do it.
Before we conclude the third session, ladies and gentlemen, we have one more presentation, and for which I request Dr. Anvesh Medicover to please step forward and give us a presentation on From Detection to Action, Managing Abnormalities on Pap smear.
afternoon. I'm Dr. Anvesh Darnikota. I'm the consultant surgical oncologist at Medicover Cancer Institute. And today I'll be talking about changing landscape of surgical management for breast cancer. As we had a review about workup, screening and treatment modalities for breast cancer, we now know that there has been a significant paradigm shift in the management of breast cancers over the years. As you can see, in 1844 is the time when the first mastectomy was documented by Pankos, which involved extensive resection of chest wall, including the pectoralis muscles and ribs if indicated. But it was only in the late 1890s that Halsted has popularized and standardized the surgical technique for the first time for breast cancers, which is known as a radical mastectomy. And the radical mastectomy involves removal of entire breast, axillary nodes, pectoralis minors, extensive skin, which is then covered using the skin grafts, because the notion at that time was the more the resection or the more radical the resection, there will be better survival. And in those lines, the 5-year survival in late 1890s was almost 40%, which is considered to be exceptionally good almost 130 years back. Slowly over the time, after a decade, almost a century, in late 1900s, the Patty has popularized modified radical mastectomy, which included only removal of an ellipse of skin around the tumor as well as nuclear complex. We routinely give a modified Stewart incision. As you can see, it is more acute on the medial side and is more curved on the lateral side. And once the incision is given, the flaps are raised in the subcutaneous plane. The most important step is to identify the plane between the native subcutaneous fat and the breast fat. As you can see, all the bigger fat lobules belong to the breast and the smaller fat lobules belong to the skin. And you can see nice thin plane. The flaps are thin and the breast tissue is being separated out from the subcutaneous fat. And we almost reach up to the clavicle. The infraclavicular area is the limit for upper dissection, and then we move on to the lower flap. So once both the flaps are dissected, the breast is now lifted off the pectoralis major, unlike in a radical surgery where they were removing the pectoralis muscles. We preserve the pectoralis muscle, but we take the pectoralis fascia along with the breast. And you can see we reach the lateral border of the pectoralis, and once you incise the fascia, what we call as clavipectoral fascia, will be entering the axilla. In axilla, the first structure we identify is the median pectoral nerve, which guides us as a landmark to identifying the axillary vein, which is seen at the top. Once we identify the axillary vein, you can see we are dissecting the torcodorsal pedicule, the vein, nerve and the artery to the latissimus dorsi, which has to be preserved during axillary dissection. Once that is safeguarded, we ligate all the venous tributaries and arteries supplying the axillary gland. Once the step is done, laterally we routinely remove lateral quadrant of axillary tissue lateral to the torcodorsal pedicule to completely clear the axillary nodes. Medially you can see the nerve serratus anterior of the long thoracic nerve, which has to be preserved. The cold cuts are given and nerve is medialized, and all the axillary tissue lateral to that is excised. With this we complete the axillary dissection. You can see the long thoracic nerve and medially and the torcodorsal pedicule laterally. This completes the axillary dissection. So this is a conventional or the traditional MRM which we do for breast cancers, and it has been the standard of care for both early as well as advanced breast cancers till almost a decade back or so. You can see the envelope specimen of axillary lymph nodes along with the mastocytosis. So what happened in the last 2 to 3 decades was a paradigm shift, which was because of the great Bernard Fisher, who has hypothesized that breast cancer was a systemic disease and not a localized disease to be treated only with an aggressive surgery. So breast cancer was a systemic disease in that tumor cells were likely to have been disseminated throughout the body by the time of diagnosis, and that more extensive local regional therapies like surgeries was unlikely to improve survival, and this has helped us in identifying that the multimodality treatment is the key to go forward in breast cancers, and surgery alone cannot cure breast cancer or improve the survival in breast cancer, which has helped us in moving towards more and more neoadjuvant therapies, adjuvant radiations, which have definitely taken or a toll on surgery, resulting in a de-escalation of surgery, but with a better outcomes. If you see, we have gone through de-escalation in terms of both axillary dissection as well as the primary surgery, that is mastectomy. If you look at the de-escalation in axilla, traditionally we were doing axillary lymph node dissection, which involves removal of level 1 and level 2 lymph nodes, and the aim is to remove at least 10 axillary lymph nodes for proper pathological staging to guide adjuvant radiation. Whereas we have already seen the limits, but complications associated with axillary lymph node dissection are significant upper limb lymphedema rates. As we cut the intercostal nerves, there will be permanent numbness over the medial aspect of the arm, and some patients land up in shoulder abduction deficits also. So to combat that, we have moved on to sentinel lymph node biopsy in breast cancers, and it has become good alternative to axillary lymph node dissection in clinically node-negative breast cancers. There are multiple methods with which we can identify sentinel lymph nodes. I'll be going through a video. So we have predominantly a blue dye method, a radioactive colloid method, and an indocyanine dyes. Traditionally, the recommendation is to use at least a dual dye technique for better pickup and to decrease the false negative rates. This is a case which has already undergone breast surgery for a benign lump, so we expect altered lymphatics in this patient. So we went ahead with the triple dye technique. As you can see, we are injecting a methylene blue in the retroareolar space. We generally inject 3 to 5 ml of methylene blue, and we massage the breast for 5 to 10 minutes so that the methylene blue dye enters the lymphatics and reaches the axilla. Post that, we will be injecting ICG. ICG 1 ml is injected intradermally at least 2 locations in the periareolar region, and this patient had already had an injection of radiocolloid day before. So all the 3 dyes are injected in the retroareolar and periareolar region. So once the injection is done, you can now see the lymphatic channels. The beautiful advantage with ICG is it is real time, and you can see the passage of dye from over the skin, which helps us in lymphatic mapping during breast surgery, so that we can precisely know where the lymphatic channels are draining and which lymph nodes are getting the dye. So the sentinel node is the first node which is being drained from the periareolar region. So we excise the sentinel lymph node, send it for frozen, and depending upon that, we take the decision regarding whether to go ahead with the complete axillary dissection or whether we can avoid it. As you can see, it has also taken up methylene blue, which can be seen with naked eye, and this is the gamma probe, which helps us in picking up the radio activity, as we have already given the radiocolloid also. can see the increased radioactive count in the mesh. So all three modalities of sentinel dyes have been used, and all of them have successfully detected a sentinel lymph node. So with the advent of this sentinel lymph node biopsy, there has been a statistically significant decrease in the lymphedema rates, impaired shoulder mobility rates, and also the numbness. Whereas coming to the de-escalation of surgery in management of breast cancer, we have moved from a traditional mastectomy to what we call as a breast conservation surgery, where we are conserving the breast rather than knocking it out altogether. So it can be either a wide excision, that is or a lumpectomy, or sometimes a quadrantectomy. But the only concern was its safety initially. So this was a landmark trial which has evaluated modified radical mastectomy versus breast conservation surgery with or without radiation. As you can see, disease-free survival, distinct disease-free survival, and overall survival, all three are similar irrespective of what surgery your patient is undergoing, but the difference is in terms of local recurrence rates. The mastectomy had a local recurrence rate of 10%, whereas the BCS alone had a local recurrence rate of 40%, which is not acceptable. So with the addition of radiation, the recurrence rates have come down to 14%, which were almost equivalent to a mastectomy. So whenever we are planning a breast conservation surgery, it is mandatory to counsel the patient that they should be undergoing adjuvant radiation at any cost. So the breast conservation surgery involves wide excision, and we usually plan a separate incision for axillary lymph node dissection or sentinel node biopsy. And the more recent advance, where in the last 5 to 10 years, we have moved on from breast conservation surgery to breast oncoplasty, which essentially means rather than just removing the part of the breast, we are doing a plastic surgery to supplement the lost volume or to cover the defect so that the patient will have a better cosmetic outcome. So there are two types of oncoplasties, level 1 and level 2. Level 1 is simple, suitable, can be done by most breast surgeons, whereas level 2 requires complex training. We usually plan the incisions based on the Langer's lines, and we usually do either a uniplanar or biplanar mobilization of the breast tissue once the tumor is taken out. And once that is approximated, we make sure there is no nipple contraction or deviation. A short video I'll run through because I'm running out of time. So these are few examples where we have done an oncoplasty. This is a level 1 oncoplasty where we have done a wide excision, and post that we will be mobilizing the local breast tissue from both the sides, which results in a better cosmetic outcome. Just a minute. So, whereas for the type of level 2 oncoplasties depends on the area of involvement, that is depending upon which quadrant is involved. We will be going ahead with Atkins mastopexy for upper quadrant tumors. This is how we plan an oncoplasty. We do the markings, the expected volume of volume loss, and then we mobilize both the pillars of the breast to give a good cosmetic outcome. And this is one more inferior quadrant tumor where we have done inverted T mammoplasty. You can see the defect is quite huge, but once you mobilize and do an oncoplasty without any nipple deviation, you will be able to get a good cosmetic outcome. And in few cases, if there is a size discrepancy, we can also go ahead and do a reduction mammoplasty in the opposite breast to match the size as well. And this is one more complex level 2 oncoplasty where the central quadrant tumors were previously considered as a contraindication for breast conservation. And we go ahead and do a resortive flap where you can see the native island of skin is mobilized up to match, And once the surgery is over, we can even tattoo the patient on the right side to match the color of the opposite nipple, and we can even incorporate an artificial nipple mount in such cases. And this is the final video. This is one of the more complex oncoplastic surgery done for a 29-year-old female, unmarried, with a recurrent breast cancer in the upper inner quadrant. You can see it's a very small breast, A-cup breast, and she was not willing for a mastectomy. So we had to go ahead and do a surgery called as matrix repositioning of the breast, where we took out the primary by giving an inverted triangular incision, and at the center angle was given in the axilla for axillary dissection. Once that is done, we were able to mobilize the entire breast tissue and rotate it along the axis to be there. Cosmetic outcome. You can see the final image. So, where we were able to preserve that A-cup breast and also give a good cosmetic outcome to her in the end. So to conclude, we have come a long way in this 15-minute talk from radical hysterectomy to cosmetic surgery, although it took surgeons 150 years to move from radical to oncoplasty. The breast cancer surgery previously was considered to be a more disfiguring surgery, has become an aesthetic and pleasing surgery where we are able to give a good cosmetic outcome as well as an oncoplastic clearance to the patient. Thank you.
Thank you so much, Dr. Amit. Thank you for the informative session. And I request Dr. Amit Jodwani to kindly please present sampling to Dr. Amit. Since we already presented a memento in the morning, we are presenting a sampling now. With that, ladies and gentlemen, we conclude the third session. We would like to thank the chairperson once again. Thank you so much. Request you to please collect your samplings on your way to the seats in the audience. And my dear friends, we will now be moving into session 4, but in the meantime, we are keeping the tea open. So anybody who would want to go have tea, you can please feel free to have your tea. You can get them inside your tea cups, coffee cups, and you can settle down here. We are not going to be breaking in for the tea. So I request you to kindly please, it will be a free flow. So you can go collect your tea, come back, be seated, and the sessions will continue here. So I request you to please make yourselves comfortable. If you would want to go get your tea cups, coffee cups, you can sit here and we can continue with the session. So moving further with the fourth session, ladies and gentlemen. Yes, it is divided into two sessions, the general session and this will be followed by the oncology session. So I request the chairperson of the fourth session to please step forward. I'd like to invite Dr. Bharat Patodia, consultant medical oncologist, to please step forward onto the stage. And I would also request our next chairperson, Dr. Lakshmi, senior consultant gynecologist, Medicover Women and Child Hospitals, please step forward. Yes, we can clap for both our chair people. I invite Dr. Sarita Srivastava to please present sampling memento to both our chairpersons here. Yes, we believe in keeping the environment green and hence the samplings to all. Thank you so much, dignitaries. You may kindly please be seated. would request. Yes, our first segment will begin now, general session. So I would request Dr. K.S. Varalakshmi, consultant, obstetrician and gynecologist, Medicover Women and Child Hospital, to please step forward and give the presentation on from discovery to diagnosis, evaluation of complex ovarian cyst mass. Over to you, ma'am.
A very good afternoon to all of you who've been here for a very long time. This post-lunch session, I hope this topic would bring some interest. I'm Dr. Varalakshmi and the consultant obstetrician and gynecologist in Medicover hospitals. I would like to thank the team Medicover for giving me an opportunity to start with the topic. We are starting with the evaluation of complex ovarian mass or cyst, discovery to diagnosis. Often encountered in clinical practice, the ovarian mass encompasses a diverse group of benign and malignant growths that develop within the ovaries. Early detection of ovarian masses is vital in women's healthcare as it offers the potential for more effective treatment and better overall patient outcomes. Unfortunately, the silent nature of many ovarian masses, especially in the initial stages, often leads to a delayed diagnosis. We know that up to 10% of women will have some form of surgery during their lifetime for the presence of an ovarian mass, and 2% of women have a lifetime risk of an ovarian carcinoma. The incidence increases from 1 in 1,000 in premenopausal women to 3 in 1,000 by the time she becomes 50. So let's know a bit of the embryology of the ovaries. So by the 5th week of intrauterine life, the developing embryo develops the genital ridge, which is seen as a yellow color thickening there, that is going to develop into the future ovary, and there the black dotted primitive or the primordial germ cells migrate from the yolk sac and they go to form the primordial germ cells or the primitive germ cells developing into the eggs later. So now there are some sex cord cells which will encircle these primordial germ cells and they form the supporting cells. To know this embryological development is important because the malignancies which arise from these cells are they have the spread along the same embryological origin. Like the serosa which covers this genital ridge, it differentiates to develop into certain types of tumors, namely serous tumors, mucinous tumors, and endometrial tumors, clear cell tumors. These are further again classified as benign, borderline, and malignant tumors. And the spread of these malignant tumors is along the coelomic epithelium. So the germ cells which get undifferentiated and the dysgerminomas, mature and immature teratomas, the yolk sac tumors, embryonal carcinomas, and choliocarcinomas arise from these cells. The sex cord and the mesenchymal tumors go to form the granulosa cell tumors, the serrated cell tumors, the fibromas, and the lymphomas. So we can broadly classify the ovarian tumors as functional tumors, inflammatory, neoplastic, and others. The functional tumors are most commonly self-limiting. They are the follicular cyst, the corpus luteus, or the theca luteus. The inflammatory swellings we know are basically the infections mainly PIDs in the reproductive age group, or it could be COX resulting in ovarian mass or an abscess. The neoplastic ones are the benign, borderline and the malignant tumors, and the others are the endometriomas, enlarged PCO and paraovarian cysts. Most of the time we identify these cysts which are asymptomatic by doing accidentally discover them in ultrasound. So the other way of presentation in the elderly women would be more in the form of gastric symptoms. They would present with irritable bowel disease-like symptoms like dyspepsia, bloating. There could be difficulty in digestion, belching, distension of the abdomen. They can present with chronic pain. It can be associated secondary symptoms like anorexia, nausea, vomiting, or urinary frequency could be increased. So some tumors can present with menstrual irregularities, virilization symptoms, or precocious puberty. Acute symptoms like pain abdomen are seen in masses which undergo torsion, rupture, or hemorrhage. So it's difficult to identify benign ovarian neoplasms from the malignant just by the clinical symptoms. Coming to the physical examination. A physical examination, a thorough physical examination done both abdomen and pervaginally will help us to know the exact origin of the mass. We can identify whether the mass is arising from the midline structure or para-midline structure, whether it's cystic, solid, the mobility of the mass, how the mass is, whether it's smooth or irregular, there is a presence of ascites, or there is any kind of nodules in the sac. To complement this, we have investigations, namely the transabdominal and transvaginal ultrasound. Transabdominal scan as well as the transvaginal ultrasound help us to identify and pick up these masses in up to 88 to 100% accuracy and specificity of 62 to 96%. Adding Doppler will increase the diagnostic precision, but it will not help us to make a clear diagnosis as to whether it is a benign or a malignant mass. We all know that the tissues which grow faster have a very high vascular supply. So the pulsatility index and the resistivity index is very high. So when you do a pulse Doppler on the papillary projection, solid areas or the field separations, by doing a 3D ultrasound, we can see that there is an increase in the vascular or there is an increase in the blood flow. Sometimes a chaotic vascular pattern is seen in malignancy. So, considering these ultrasound features, the IOTA group has classified the masses, the ovarian masses as B roots and N roots. B roots include unilateral cysts, presence of solid components, where the largest solid component is less than 7 mm, presence of acoustic shadowing, smooth multilocular tumor with the largest diameter of less than 10 cm, and minimal blood flow. When it comes to the malignant roots, M roots, most of the time it's like either the irregular solid tumor, they are present with ascites, they have at least 4 papillary projections, they have irregular multilocular solid tumor with larger diameter greater than 10 centimeters, and they have a very strong blood flow. The other imaging modalities that we use are the CT, MRI and PET scan, but all of them are not advised for every woman. The CT scan may help in certain situations where there is a dilemma in identifying whether it's a benign or a malignant mass, or whether we need to know whether there is any kind of a spread. Once it is known on the scan that it is a complex or a mass having the malignant roots. So it will help us to identify the lymph node involvement, omental mets, peritoneal deposits, hepatic mets, or if there is any kind of obstructive neuropathy. Coming to the markers, we have CA-125, which is universally done for all women with a complex ovarian mass in women more than 40 years of age. So this is a glycoprotein and it's a primary marker of epithelial ovarian carcinoma. It cannot be used as a screening test because it has a low sensitivity as it is false negative values, because the first stage of the cancer of the epithelial carcinomas, about 50% of the cases they do not have an increase or an elevated CA125 levels. And also the specificity is less because CA125 is elevated in some other normal benign conditions like endometriosis. It is increased in fibroids, PIDs, COX, etc. But serially monitoring CA125 levels will help us to identify this elevated levels are associated with epithelial carcinoma. So, do we advise CA125 in women who have ultrasound suggested for simple ovarian cyst? It's below the age of 40 years, we do not advise. There are other serum markers, namely the LDH, AFP, HCG, which should be measured for all women in women less than 40 years with a complex mass, because there is a possibility of germs and tumors. The other tumor marker is the HE4. This is a precursor to the epidermal secretory protein E4, and as normal ovarian tissue, there is a minimal gene expression and production of HE4. As a single tumor marker, HE4 has the highest sensitivity for detecting ovarian cancer, especially in the stage 1 disease. So combining CA125 and HE4 is more accurate predictor of malignancy than either alone, because even in stage 1 disease, when the CA125 levels are less, the HE4 levels are elevated and they will complement each other. So levels greater than 70 were found to be elevated in over half of the patients with ovarian cancers where the CA125 levels were normal. HE4, when studied in premenopausal age group women, they were able to discriminate benign tumors from the malignant ones. So the newer scores that have been employed are the DOMA score, where the two markers, the HE4, the CA125 and the postmenopausal stages is used. So in patients with stage 1 and stage 2 disease, DOMA achieved a sensitivity of 85% compared with 67% for RMI. Or the next new score is the OVA1. So the FDA has approved this. Here we test for 5 immunoassays, namely CA125, transthyretin, apolipoprotein A1, transferrin, and beta-2 hydroglobulin. The sensitivity is quite high, up to 93%, specificity up to 43%. So how do we deal with asymptomatic simple cysts in the reproductive age group? Less than 5 centimeters, we do not give any kind of oral contraceptive pills or any medications. We can just follow them up. Between 5 centimeters to 7 centimeters, we do a yearly ultrasound, and greater than 7 centimeters, which will require further investigations or other surgical interventions if there is any acute problem. Coming to the cyst aspiration. The cyst aspiration is not therapeutic and it should not be used routinely, because 25% of the cyst will recur within 1 year, and sometimes aspiration of the cyst may result in seeding of these cancer cells and may progress from stage 1 disease to stage 3 disease. So coming to the operative modalities, we have laparoscopy versus laboratory, but the decision to go ahead with the surgery has to be done only after the suspicion of malignancy is clear and technical expertise is available. So laparoscopic surgery for benign ovarian tumors is associated with less pain, so shorter hospital stay and fewer adverse effects than with the laboratory. So the standard of laparoscopy in benign tumors is to carefully examine the external surface of the tumor and sampling of the peritoneal cavity, avoidance of any tumor rupture, protection of the ovarian tumor with an endo bag before it is removed. There is a diagnostic accuracy of frozen section, which is very high for malignant and benign ovarian tumors, but accuracy is poor in the case of borderline ovarian tumors. So we'll talk a little bit about this RMI. So in order to complement the pitfalls of the CA125, associating CA125 levels with the menopausal status as well as the ultrasound findings, the RMI index has been identified. So we calculate the RMI by multiplying the CA125 values with the menopausal status, where if the patient is pre-menopause, we assign a value of 1. If the patient is in the postmenopausal age group, you assign a value of 3. And the ultrasound findings. The ultrasound findings should be, there are 5 characteristics where we assign 1 for every characteristic, namely the metastasis, multinodularity, bilaterality, ascites, and multicystic. So, if there is more than one feature present in the ultrasound, we assign 3, the value of 3. So, multiplying these 3, that is the ultrasound value, the menopausal status, as well as the CA125 levels, we can assign the RMI index. If the RMI index is more than 200, that indicates that the patient we are dealing most probably with a malignant ovarian mass. So always this helps us to categorize patients as whether they require a laparoscopy, whether we need to take the help of the oncologist, whether to refer such cases to the oncologist or do the surgery in the presence of an oncologist, and also to plan whether we're going for a laparoscopic surgery or we're going for a staging laparotomy. So if the RMI is less than 200 and in the postmenopausal status, if the woman has a cyst of 5 centimeters and it's a pure unilocular cyst, it can be dealt with by repeating the RMI index, by repeating the CA125 levels as well as the ultrasound after a period of 4 to 6 months. If it resolves within the 6 months, the patient can be discharged. If the patient continues to have the same cyst, or if there is an increase in the size of the cyst or the CA125 values are increasing, then you will have to consult, speak to the patient and also take the opinion of the oncologist if it is showing any malignant features, and plan for staging laparotomy. Otherwise, it can be done as a laparoscopic procedure, and as we discussed, we can remove the cyst in toto along with the ovary. So in postmenopausal women, there is no role of removing the cyst. It has to be removed as oophorectomy, especially in postmenopausal women. Bilateral oophorectomy is advocated, and we can discharge the patients from the follow-up. So the biomarkers which we have used, namely the single CA125, gives a sensitivity of only 30 to 35% in cancer ovary. And if we involve the CA125 along with the menopausal status and the ultrasound, the RMI index, the sensitivity will go as high as 71 to 88%, specificity of 74%. There are other panels that are the OVA1 panel, which will include the 5 markers, has very good sensitivity of 96% and 28% specificity in postmenopausal women, and 85% sensitive and 40% specificity in premenopausal women. The Roma index, which considers CA125, H4 and the menopausal status, gives a very good sensitivity of 92% and 75% specificity. So that is the reason we do not do the screening, universal screening in ovarian carcinoma, because it is not possible to identify with a single test. We cannot clear-cut and pinpointedly pick out a large number of population who do have the disease because of the false positives and high false negatives. So, in which group of population should we do the screening? It is advocated in genetic predispositions, in women who have a genetic predisposition and high-risk groups, where we have the BRCA genes positive, and in certain syndromes like hereditary non-polyposis colorectal cancer syndrome or the Lynch 2 syndromes, because the normal general population has a incidence of 2% for ovarian malignancy,
Whereas the people who have BRCA1 and BRCA2 genes positive have a 5 to 10% chance of developing malignancy. So the lifetime risk of women having the BRCA1 genes positive is about 42%, and for BRCA2 there is a 17% increased risk of having ovarian cancer. This is going to be the last one or two slides. So for whom do we do this screening? It is for women who have had a family history or a personal history of a breast carcinoma before the age of 50 years, ovarian cancer diagnosed at any age, first degree related with an unknown mutation, family history of 2 or more cases of breast cancers, 2 or more cases of ovarian cancers in the family, bilateral breast cancer or male breast cancer. So in all such women, we can go for screening. Screening is done by history, clinical examination, a transvaginal ultrasound, and by doing a CA-125. In women who have Lynch syndrome, screening for colorectal cancers has to be done by doing a colonoscopy starting from the age of 25, because these women have a high risk of developing colon cancers as well as endometrial cancers. And also, prophylactic bilateral salpingo-oophorectomy for women who have completed their family. For all these high-risk women with BRCA genes positive, you can offer them. And the oral contraceptive pills will reduce the chance of having malignancy by about 50%. So these are some of the recent future perspective. One is the liquid biopsy, where they take the blood sample and identify the free DNA, the mRNA, the microRNA, the circulating tumor DNA. The recent combination of microsomal RNA 200A, 200B, C have shown a very high sensitivity and specificity. Nowadays, use of artificial intelligence and machine learning have made some development, and they are instrumental in developing algorithms and models that can significantly contribute to the diagnosing and characterizing ovarian tumors. Thank you.
Thank you so much, Dr. K. as well as Lakshmi. Thank you for the informative presentation. Any remarks from the chair?
These are the future perspectives. These are the future perspectives. There are studies where they have identified these markers, but I am not aware of the labs where this is done.
As per my understanding, there are only 1 or 2 labs which are doing RNA sequencing, and the latest which is coming up is the proteomic-based therapeutics. So, as you all know that carrying a gene does not mean they will get expressed. So, even if some gene is there, somebody is having BRCA1 mutation, it's not specific to ovary or breast, but let's say a gene is there, it is a mutated gene for cancer, the family is there. So, they will create a silencing RNA and will administer to the patient. It is yet not in the limit, but there is one thing extra. I just remember the microRNA, so I can tell it here.
Yes, we have a question there. Can we offer the mic, please, to the management? Just a second.
We are not doing in the clinical practice, but we are following the RMI. Basically, we are doing the M and videos on ultrasound and complementing it with the CT scan and taking the opinion of the oncologist.
So what is your cutoff for saying it is malignant or benign? Any size criteria or solid and cystic variations between them?
We do consider the size as well as the solid and cystic areas. If there are solid areas with papillary excrescence is more than 4, or if the size of the mass is more than 10 centimeters, then there is a more probable chance that the mass is malignant. So we involve the oncologist, take the opinion, and then plan for the next surgical treatment.
Yes, there's a lady behind. Please, we can stand up. Yeah, We'll just give the mic to you now. If you can stand up.
Recently you are doing romance story and
We are not doing romance stories.
available.
But the next tumor markers is discussed by our next panelists, so they will be telling us the labs where it is available.
You don't have a question? Oh, any other questions to the audience? Yes. Ma'am, please take the mic.
Postmenopausal women, what is the cutoff for the size of the ovarian mass? Suppose there is a kind of ovarian mass is expected to be malignant.
Any ovarian cyst more than 1 centimeter in a postmenopausal woman we have to evaluate. And any simple cyst less than 5 centimeter in a postmenopausal woman we have to calculate the RMI index. If it is less than 200, we have to do a scan after 4 to 6 if the patient is asymptomatic, if she is incidentally detected on the ultrasound. If she is not having any other symptoms, follow her up after 4 to 6 months and then rescan to see for any increase in the size. We do the CA125 levels, see whether they are increasing, and you see for any change in the cyst contents, whether it is a simple cyst turning into a solid cystic lesion or a multilocular cyst. If any of such findings are there, you directly counsel them for a bilateral salpingo-oophorectomy in postmenopausal.
Sizes remaining the same, there is no change in CA125 levels. So we can just wait and
yes,
you can is less than 5 centimeters.
Yes, you can wait and watch if it is less than with no family history of any malignancy.
Thank you. What about post-hysterectomy ovarian cyst?
Post-hysterectomy ovarian cyst, again we have to categorize whether it is a simple cyst, whether it is a complex cyst, what was the reason for her to undergo the hysterectomy, whether there is any family history of malignancy of the breast, of the ovary, or if she has any Lynch syndromes. Then taking all this into consideration, we have to complement it again with the CT scan because postmenopausal status there could be a lot of fibrosis, bubble adhesions, and the scan may not be able to pick up the clear size of the cyst to see for any lymph node enlargement. MRI, yes, it can be done, but it does not give any additional value compared to the CT scan. It doesn't give any additional information. Only when you need to know whether the mass is arising from the uterus, whether it's a leiomyoma or it's a solid ovarian mass, whether it's a malignant tumor or a lateral tumor, then maybe MRI will help us. But otherwise, CT scan will give most of the details.
In relation to her question, where you place ovarian doctors in case of incidentally detected ovarian.
So always doctors will improve the accuracy of detection to a certain degree, but they will not give a full information as to whether the mass is a benign or a malignant one. So the place where we do the Doppler is at the solid areas, where the interseptal areas where the blood flow is there, and also the papillary exclusions.
Anybody who is a radiologist can, because my limited knowledge is in radiological doctor there is a cutoff beyond which it can be seen a higher chances of malignancy, just like diabetes. So the Doppler score is also there. I think the radiologist level.
Alright, I think we'll leave that open to discussion post the event. And I would now request Dr. Bharat Rao to please present a memento to Dr. K.S. Varadachna. Thank you, dignitaries. We are now moving forward to session 4, ovarian cancer, oncology session. And I would now request Dr. Ravi Chandra Vedigeti to please step forward for the presentation. Yes, he's the Senior Consultant Surgical Oncology in Medicover Cancer Institute. I request you to please step forward for the presentation on comprehensive surgical staging for ovarian neoplasms, techniques and clinical impact. Over to you, sir.
Because we are running short of time, and the majority of that tumor market talk was covered in the previous one. So decided to go ahead directly with the surgical management. Yes, we'll try to keep it short and simple. So, as you know, postmenopausal or premenopausal women, they have a 5 to 10% risk of requiring a surgery during their lifetime because of ovarian or ovarian pathology. And those who undergo a surgery, there is a 13 to 20% risk of having an ovarian cancer. So, whatever it is, the primary aim of diagnostic evaluation of any adnexal mass as such is to rule out a malignancy. Once you rule out a malignancy, then treatment will be different to the benign malignant condition. So, but the chance of having a malignancy is less than 1% if it is in the reproductive years, and if it is a postmenopausal woman, it increases to roughly 29 to 30%. That is 1/3 of all the ovarian masses, ovarian cells you see in postmenopausal or malignant. So, I think it has been discussed extensively. There might be multiple things like tumor markers or ultrasound, radiology findings and everything, and different algorithms which have come out to detect risk of malignancy. But in practice, what we see is simple thing. What ultrasound IFA group rules, there are B rules is benign rules and M rules are malignant rules. So any solid tumor, any patient which has an SIA, that is 4 papillary structures, irregular, multilocular, and a very strong blood flow on Doppler. So all these patients will require more likely to be malignant, and these patients need to be managed as a malignant tumor only. And the B rules or simple rule. Presence of solid components, where this wall might be irregular, but solid component is less than 7 millimeters. Presence of acoustic shadowing, smooth multilocular tumor, less than 10 centimeters, no blood flow, unilocular. These are absolutely benign tumors. So, apart from all the B rules, whatever is there is to be taken as a potentially malignant tumor. I am not telling it is malignant, as a potentially malignant tumor and to be treated accordingly. So, and that's why American College of Obstetrics and Gynecology (ACOG) has given some referral guidelines for premenopausal women that is younger than 15 years. They have taken a cutoff of CA125 of 200 units because CA125 can be limited in multiple benign conditions. So, the cutoff is 200. Anything more than 200, it has to be referred for an oncologist. There is a site that indicates that there is a spread or evidence of abdominal or distant metastasis which are seen, some nodularity, some nodules outside the ovary which are seen. All these things will have to be referred for an oncologist. Similarly, in postmenopausal women, the CA125 more than 35 is taken as a cutoff. Aside is nodular or fixed pelvic mass, abdominal distant metastasis, the same thing will continue. So based on that one, I think they have discussed about the risk of malignancy index. RMI 1 was there initially, and they have modified it and they made it an RMI 2 score. So what are the factors that we have seen? All these factors: multiloculosis, presence of solid areas, bilaterality, ascites, intraabdominal mass, and then the menopausal status, premenopausal, postmenopausal, and the CA125. So RMI is like ultrasound criteria. and then menopausal status into GA125. So what does it say? Based on the RMI index, the low, intermediate and high risk group, the RMI is less than 25, the risk of cancer is very minimal. Intermediate risk is when it is between 25 to 250, this is the RMI 2 score. And if it is high, more than 250, there is a high chance that it is a malignant tumor. So, multiple systematic reviews have been done, which showed RMI score of 200 or more will have a sensitivity of 78% and specificity of 87%. And if you have increased that RMI score to 250, the sensitivity might be lower, but specificity increases considerably. So, when you go conservative, when you go for the surgery, if the ultrasound features the digest of functional ovarian cysts, premenopausal cysts less than 7 centimeters, and postmenopausal cysts less than 5 centimeters with no other features of malignancy, asymptomatic, and when we say risk of surgery, outweigh the benefit of cyst removal and patient preference. Obviously, that takes precedence. So, when you have all these features, it is conservative. Anything more than that, when is surgery indicated for all complex ovarian cysts, unless thought to be hemorrhagic or carpophageal cysts. Postmenopausal cysts more than 5 centimeters, premenopausal more than 7 centimeters, even if they are simple cysts. Any symptomatic cysts or any other features are suspicious of malignancy. So all these will go for surgery. And surgery, extent of surgery will depend on the patient's age and patient's desire for ovarian function, fertility, because we are talking about premenopausal menopause. So if it is premenopausal and the chance of suspicion for malignancy is low, then cystectomy is the operation of choice, right? But you can go for an oophorectomy or oophorectomy where you cannot preserve the ovarian tissue. For all postmenopausal women, it is always a oophorectomy, which is bilateral. So, laparoscopic approach can be used when the risk of malignancy is considered to be low. And when you are going for a laparoscopy, try to avoid spillage of the content. But multiple studies have been done comparing open with laparoscopy, and they found out that both of them have similar cyst structure rate. So, laparoscopy or open really is not going to benefit much in terms of cyst structure. So, if cyst structures during the surgery, what needs to be done, we have to do an extensive peritoneal lavage. What we say is use roughly around 3 liters of normal saline, warm saline, and wash the entire abdominal cavity from the diaphragm to the pelvis. And where possible, if you have removed it without rupture, put it in a bag, bring it out through the umbilical cord, then within the bag you can just puncture it, aspirate the fluid and take it out. Put a simple ovarian cystectomy here, as you can see. No ovarian cyst, but luckily for us you can see the ovary there. And majority of the time what we tend to do is we tend to give an incision here at the periphery, trying to preserve more and more number of follicles. But if there is even an iota of suspicion of malignancy, please go close to the ovary so that you don't have to dissect so much amount of cyst capsule. So that way the chances of cyst structure are minimal. You might be losing a little more follicles than what would have done with the peripheral excision. But obviously the chance of rupture or spillage will be very minimal if you go close to the base. So once, like I explained to you, once it is done, put it in a bag, bring it out through the whatever port, umbilical port, usually the bigger one, bring it out, then puncture it, aspirate it, and you can take it out. So any suspicion of ovarian cancer is there, then surgery can be in different stages. We do different kinds of surgery. We do staging laparotomy for early ovarian cancers where there is no spread, looks like tumor is apparently confined to the ovary. We do a staging laparotomy to see whether there is any spread outside. Primary cytoreduction
is for locally advanced or advanced breast cancer, stage 2 to 4, so where we are trying to remove as much tumor as possible. And interval cycle reduction or interval debulking surgery after giving 3 or 4 cycles of neoadjuvant chemotherapy when it was initially inoperable. Then secondary cycle reduction, when you have done a complete, you have done initially the patient had a surgery, but there is a gross residual, you give chemotherapy, and at the end of the procedure there is still some residual disease, then that is the time when you do a secondary cycle reduction. And the second loop laparotomy, nowadays we are not doing the so-called second loop laparotomy because second loop laparotomy is when you have completed the treatment, the patient is absolutely symptom free and there is no disease which is seen on any of the scans. But they used to do a second loop laparoscopy or laparoscopy to see if there is any residual disease or something. And they found out that roughly there is a 11% instance of finding micrometastasis in these patients. But end of the day, what matters is how the patient is doing. So you are identifying micrometastasis earlier, but it will improve their overall survival. So unnecessarily doing a second loop laparoscopy or laparoscopy is not going to add much to the patient survival. So that is more or less abandoned right now. So that's what I was talking about when whether you do a laparoscopy or laparotomy. The chance of cyst structures are similar. If you do sorry, I think this is what we're talking about. In suspected ovarian cancer, can you do a laparoscopic surgery? Right. So normally the standard was an open laparotomy with a midline incision. Right. If you are planning an open surgery, what I suggest is never go with a panel stage incision because that panel stage cannot be extended and we will not be able to examine the upper abdomen in that one. And in case we see some disease, we cannot extend that incision. So it is always a midline incision. Keep it a lower midline incision and take the tumor out. And in case you are seeing some more disease, you can always extend it up. You can see that basically what happens is that spread is transcelomic. So the peritoneal fluid circulates from the pelvis, from the right paracoelical onto the subdiaphragmatic area, from the left subdiaphragmatic and comes down. This is the loop of circulation of the peritoneal fluid. So majority of the time you see disease under surface of diaphragm. From the phalansteal incision you cannot put your hand there to feel whether there is disease anything there or not. So if we are doing an open surgery, it's always a midline laparoscopy. So when we do it, even the guidelines now accept laparoscopy as a safe approach. It is the NCCN guidelines say you can use minimally invasive approaches when you have an experienced surgeon who can manage an early stage disease, for interval debulking surgery, and it's also useful in locally advanced disease to see whether you can do an optimal cycle reduction or not. If you feel that you cannot do an optimal cycle reduction, you just do a diagnostic lab, come out, and then give neoadjuvant chemotherapy and plan for the surgery at a later date. So when we compare laparoscopy or laparoscopy for the staging of ovarian cancer, the chances of cyst structure with open or lap are similar. The lymph node retrieval is similar. The recurrence rates were not different, and the DFS and OS, that is overall survival, did not change. So laparoscopy as such on this present day is an accepted modality to treat ovarian cancers. So what is the staging laparotomy would mean? Right? All stages with early ovarian cancers will go undergo what is called as a staging laparotomy. So when you do a staging, why do a staging laparotomy? That is when the disease is confined to the ovary. You can just see an ovarian cell, nothing other than an ovarian cell. So there are multiple biopsies taken from the peritoneum, omentectomy and the lymph node dissection. So the instance of lymph node involvement is roughly around 11% for stage 1 and 28% for stage 2. So, and instance of omental metastasis is 10%. So roughly around 28 to 30% of the patients will be upstage, and those who are upstage will always be stage 3 because lymph node positivity or omental positivity is usually upstage to stage 3, and these patients will require treatment, adjuvant treatments accordingly.
So this is what we do. I think why we say this, I have just showed an intracolicomectomy because sometimes it so happens that the patient is in the periphery and asks the gynecologist to do whatever they can do. So when they have a minimum suspicion about an ovarian cancer, apart from your pH and DSO, omectomy is a very simple procedure, can be done by anybody. So that is what we are trying to demonstrate here. So what we are doing is the laparoscopic so that you can have a better visualization. So just below the colon, transverse colon, whatever omentomy is there, slowly we can start dissecting it out and taking it. It's a very safe procedure, does not cause any morbidity, does not cause any other problem. So always when you have operated some case like that in a periphery, try to take any suspicion is there, try to do an intracolicomectomy at least to add up onto the staging. Because otherwise we'll have to go do a staging laparotomy as a second procedure that will add unnecessary morbidity to the patient. So that is what we do. Ascites, if there is ascites aspirated, if not, then do a peritoneal lavage. How do we do it? 50 to 100 ml of saline in the pelvis, in the paracoelic gutters, in the subdiaphragmatic area. From 3 areas, you have to test it 50 to 100 ml, take aspirate it and take it. All peritoneal surfaces should be visualized. If there are suspicious areas, you take biopsies. If there is nothing, you can take random peritoneal biopsies. And what we say is bilateral paracoelic gutters, subdiaphragmatic area and pelvic peritoneum. Subdiaphragmatic is difficult to take, so even scraping like pap smears are accepted for diaphragmatic staging. What differs in primary cytoreduction? The same thing, similar to staging, because you aspirate ascites, omentectomy is a standard. Majority of the times what happens is in these patients we will not be doing intracolicomectomy, you may have to remove the entire omentum. So we might be doing a total omentectomy. So this is what it is. A full methyl incision, pH, DSO, and if there is any deposits on the pelvis, pelvic peritoneum, because peritoneum on the bladder is usually where the deposits are there, and this peritoneum will easily strip off the bladder. So you do a pelvic peritonectomy, omentectomy, you can see extensive disease here. So we did a total omentectomy. So this is the stomach, this is the transverse colon, and diaphragmatic stripping, whatever is needed. And if needed, you can do any of these procedures. Appendectomy. So appendectomy is advised to do appendectomy in useless tumors, but we don't know what is a useless tumor until you remove it and send it for a transplant. So appendectomy, if any suspicion is there, usually useless tumors are large without extensive spread within the abdomen. So if something like that is there, you can always add appendectomy. And like stripping of background, if needed, we can do a stenectomy, cystectomy, or partial hepatectomy, or partial gastrectomy. All these are accepted procedures by doing a primary cytoreduction. And what about the lymphadenectomy? Lymphadenectomy is a systematic lymphadenectomy, pelvic and paravoidal lymphadenectomy. It shows that the lymph node metastatic yield has increased, but it did not show any improvement in overall survival or disease-free survival. So it might change your adjuvant chemotherapy regimens, but it did not show much of an improvement. So for advanced ovarian cancer, it is indicated only to remove involved nodes when they are seen at primary cytoreduction or secondary cytoreduction. And interval cytoreduction, where you go for neoadjuvant chemotherapy. Neoadjuvant chemotherapy, when we feel that the patient is not fit to undergo chemotherapy, or the disease is so extensive that you feel that you will not be able to do a proper cytoreduction. What is an optimal cytoreduction? Normally the NCCN guidelines say less than 1 centimeter, but ideally speaking, no visible disease is what is your target to do a cytoreduction. So the patient factors like advanced stage, fragility, poor performance status, and the disease factors like
infiltration of the small bowel mesentery, deep pastomatosis, deep infiltration of stomach, duodenum, iliac lung, all these things. So, what is the difference between a primary cycle reduction and an interval cycle reduction? Both are similar. Right? Does not change the prognosis much, and primary cycle reduction, proper primary cycle reduction is a main determinant of prognosis of these kind of patients. So, initial primary cycle reduction, where possible, is the standard of care. Interval only when we cannot do initial primary cycle reduction. So, if you are doing an interval cycle reduction, so now the guidelines recommend doing a high pipe during the interval cycle reduction with cisplatin. Two slides on two important topics about fertility sparing surgery, urinary cervix oophorectomy, complete surgical staging. So we are trying to preserve, because we are seeing more and more younger patients with ovarian cancer. So fertility sparing surgery is indicated in patients with conventional low-grade stage 1A tumors like serous endometrioid or Houston expansion subtype. It is also acceptable stage 1C1. So stage 1C is again divided into 1C1, C2 and C3. C1 is when the washings come positive. C2 is when there is an intraoperative cyst structure with spillage of the fluid, and C3 is there is tumor on the surface of the ovary. So 1C1 it is acceptable, and when we are talking about 1C2 and C3, what happens is they say the chance of recurrence are high, but recurrences are not because of, it is not in the opposite ovary, it is not because you are sparing the ovary, recurrence are in the peritoneum. So effectively speaking, your doing a fertility sparing surgery is not going to impact the recurrence rate, so you can still go ahead for a fertility sparing surgery in a low risk group. And grade 3 disease is a contraindication for a fertility preserving surgery. And there are certain subtypes like clear cell and astrocytomas like mixed mullerian tumors. So these are contraindications for doing a fertility sparing surgery because they are aggressive tumors and the prognosis is bad with fertility conservation. So it is contraindicated for stage 2 or 3 disease, but it should not be done. It can also be done in advanced disease in patients with borderline tumors, malignant germ cell tumors, and exposome tumors. Even in stage 3 disease, you can do a conservative surgery, you can do a fertility sparing surgery in all these patients. And one more technique, difficult thing for all the gynecologists is borderline ovarian tumors. The borderline tumors, because the patients tend to be younger, they are usually in stage 1. Surgery is the primary treatment, and there could be implants, but we give chemotherapy only if there are invasive implants or there are non-invasive implants. The treatment is after surgery only observation. So fertility preservation is indicated for all borderline ovarian tumors if the opposite ovary is normal. So unilateral vaginal oophorectomy. So in non-menopausal it is bilateral vaginal oophorectomy. Postmenopausal it is bilateral vaginal oophorectomy, and in younger patients it is unilateral vaginal oophorectomy. Serious borderline ovarian tumors. If you have done a cystectomy and it came as borderline ovarian tumor and it is serious, cystectomy is an acceptable alternative. This is one area where you can get away with just a cystectomy, but you have to do a complete surgical staging. You have to do a laparoscopy, see there is no spread anywhere else, and then you can just leave the patient after cystectomy. You need not remove the ovary. And there is no role of any lymph node resection in these patients because these things do not spread the lymph nodes, they will be only implants in the peritoneum. To conclude it, initial evaluation with ultrasound, the tumor markers, once you have seen it, until analysis clears this, any indefinite or malignant cases, better managed by an oncologist. So primary cycle reduction is the treatment of choice where it is good. And fertility sparing surgeries can be considered in all borderline tumors, early ovarian cancers, and you can consider if it is locally advanced initially where cycle reduction is not possible, that is where you give near-term chemotherapy followed by surgery.
Yes, thank you so much. Dr. Ravi Garu, any questions from the audience and from the chair? Any remarks, please let us know.
robotic surgeries are very popular nowadays, especially about the main scanning any value or any extra benefit doing robotic rather than doing open laboratory.
So right now for the staging laparoscopy, minimally there is an accepted approach right now. So definitely, if patient's recovery is better, and as I have shown, the structures, cartilage are the same with open laparoscopy or robotic surgery. So you can always go for a laparoscopic or robotic for all early openings.
How long would you like to enter the competitive competence to wait for the nanopopters for late stage after the
Normally, when we talk about malignancies, the chance of recurrence is whatever recurrences happen. 90% of the recurrences usually happen in the first year. And by second year, 99% of the recurrences already might have happened. So 2 years is the ideal time to wait before they can start infertility treatment also.
Some centers also offer pipette approach, not in this category, but as a reductive setting, where you take pipette.
So pipette right now is ideally done, is right now given for palliative cases more or less, because pipette is some procedure which is not as costly or as extensive business as pipette, but we can repeat the procedure. So pipette is indicated any of the stage 4 we can consider that one to relieve the patients of intractable ascites.
And now, with that, I guess we conclude the session. I request Dr. Lakshmi Garu to please present the memento. Yes, I request Dr. Ravi to please receive the memento. Thank you so much, dignitaries. Thank you. We move further to our next presentation. I'd like to invite on stage Dr. Pawan Kumar Janala, Consultant Surgical Oncology, Medicover Cancer Institute, to please come forward for the presentation on Turning Up the Heat, HIPEC's game-changing role in ovarian cancer treatment. And yes, my dear friends, you can see about Dr. Pawan Kumar on the slides. The qualification, designation, the experience, and also his expertise and the publications are mentioned on the slide.
Good afternoon. My name is Dr. Pawan. I'm consultant in surgical oncology. Now we will be discussing about the role of HIPEC for ovarian cancer. Just a brief introduction. It is one of the biggest cancers in the female genital tract, often diagnosed at advanced stages and has high mortality because of late detections. And the risk factors include aging, family history, and we all know that BRCA1 and BRCA2 mutations, hormonal factors, obesity and lifestyle factors, and history of breast or colon cancer. And it often presents with vague symptoms like bloating and pelvic pain, and it is instantly detected either by screening methods previously explained or through CT scans or ultrasound, and we confirm the diagnosis with biopsy or surgery. And after confirmation, we stage the disease like stage 1, 2, 3, 4. And for the key disease, whatever research has said that primary debugging and most of the procedures are applied. And for stage 3, generally we do either primary or multiple debugging therapies along with additional intraperitoneal chemotherapy. So we can use this different treatment modalities like surgery, chemotherapy, and in combination, either upfront or delayed based on the disease status. But whatever we are doing, the goal of site reduction is complete removal of the disease. Ideally, like cross disease should be less than 0.2 centimeter or 1 centimeter. And in cases where the detection or the surgery is going to be extensive, we give about 3 or 4 cycles of chemotherapy and do the surgery. That is interval. But after giving complete site reduction, there are some patients who become or who at least 20 to 30% have chemo-resistant tumors from the beginning itself. And out of them, like 60% will relapse within 3 years. That's what they are highlighting, the first 2 years of this is important, follow-up is important. So what are the causes or what are the observations which can cause this recurrence or the disease recurrence pattern? And the pattern of cancer dissemination is basically as the peritoneal fluid circulation happens, it is exposed to full of the peritoneum, and the cancer cells that are contained within the vascular system and the bone marrow, they do not progress. But which are cancer cells in the peritoneum or the coelomic cavity, they have high capacity to implant in the peritoneal cavity and they progress. And this peritoneal space plasma barrier is one of the most common sites where we can target to heighten or to improve our local-regional treatment and without increasing the systemic toxicity. So, the peritoneum is a common site of tumor recurrence because the factors could be like poor blood supply to the peritoneum, and because of the poor blood supply, there will be low penetration to the tumor nodules, the chemo or the agent, and the inability to eradicate the complete tumor growth. And there post-operative radiation formation, this is the ideal place for tumor cell enlargement. So, almost all the recurrences, majority of the recurrences are confined or they occur within the peritoneal cavity. So, the other factor which is most important is the complete site reduction. So, the complete site reduction has a direct impact on the survival. And the meta-analysis which has included about 7,000 patients showed that this maximum site reduction is crucial for the powerful survival, powerful determinant of the survival. So when we combine the site reduction, complete site reduction with the additional therapy, we could get some better results. But how to achieve that complete site reduction? Generally, we calculate what is called as peritoneal carcinomatosis index. That is the calculation of the disease which is present in various quadrants or various regions of the abdomen, and we give a numbering to it. And depending upon that, we calculate the PGI index and we try to remove the achieve complete site reduction, which we can categorize as CC0 or CC1, CC2 or CC3. And our target is we have to remove all the residual gross disease, ideally CC0, and the residual impact ideally less than 1 centimeter or even less than 2 centimeters. This is why, because of why the patient with no residual tumors has a chance of survival advantage of about 46 months compared to the people who did not undergo any complete site reduction. And complete site reduction patients also have a survival benefit in advanced ovarian cancers. And to achieve complete site reduction, we have various techniques like pelvic peritoneectomies and diaphragmatic peritoneectomies. And this is one example of showing how to clear the disease in the upper abdomen. And this is where we can see all the diseases in the near the porta hepatis, gallbladder, liver, and the complete diaphragm. That is the sheet of disease along the falciform ligament and all along the liver surface along the distal capsule. And we try to remove this tumor going along the reflectomy procedures, and we try to achieve the complete CC0 with the surgeries. We will remove the complete tumor, and this is how the post-op went after the cytoreduction is done. That is the common bilateral, that is the porta, that is IBC, and needle to that is porta and the liver. So once we target this, we achieve this complete cytoreduction, we enhance our treatment, lower issue control by adding some therapy. So why we need that therapy is like we target the microscopic residue which is in the abdomen, which was not visible to us. It reduces the risk of peritoneal recurrence. It has to improve local efficacy. It should have minimized systemic side effects, and it should enhance disease-free survival and also potential for improved overall survival. So there are different mechanisms where they gave intraperitoneal chemotherapy by heating it up, without heating it up, and what goes to fill it is like hybrid, it is like hyperthermic intraperitoneal chemotherapy, which possibly is that drug which addresses the microscopic disease in the abdomen, and it is administered during surgery directly into the abdomen, and it targets cancer cells in the peritoneal cavity, and it also improves local drug concentration efficacy. So hybrid is delivering the chemotherapy at 42 to 43 degrees centigrade. Why that temperature? Because that heat enhances the drug cytotoxicity from 39 degrees onwards, and synergy diminishes after 43 degrees. So generally we try to put between 42 to 43 degrees centigrade. And this hyperthermia was destruction of cancer cells, augmentation of cytotoxicity, and increased penetration. So the intraperitoneal chemotherapy allows for much higher concentration in the peritoneal tumor due to direct diffusion of the drug from the peritoneal cavity that improves the local cytotoxicity, and it has the additional advantage of reduced systemic side effects. Generally, most often we use cisplatin for ovarian cancer, and every evidence of using hybrid came from this study, who used intraperitoneal chemotherapy plus IV chemotherapy. Here they did not heat the chemotherapy, they just gave normal intraperitoneal chemotherapy. But even in this study, they have observed and improved overall survival, but also the recurrence rates are very, very high. And the toxicity and difficulty completing the post-op chemotherapy became difficult. So then it was heated and it turned into hyperthermic intraperitoneal chemotherapy. This direct chemotherapy is given to the affected area. As usual, it targets the microscopic residual disease, efficacy against peritoneal metastasis, and increased drug concentration. And if we give the chemotherapy, it promotes uniform distribution towards the abdomen and improving the local drug concentration. And this is the evidence that using hybrid, we have almost 3-fold or 4-fold improvement in the overall survival when compared to without hybrid. That is confirmed by the recent 2022 meta-analysis. And this is a diagram showing the hybrid. 4 trains are placed inside the abdomen, and 2 acts as an inflow and 2 acts as an outflow. After giving the chemotherapy up to the target, we infuse into the abdomen, and it will circulate for a certain amount of time. For an average, generally for 90 minutes, the drugs are placed, and the drug is taken out after that time, and it is released. And after that, the abdomen is closed, and any anastomosis are there, we perform that anastomosis. And 2 types are there. non-closed operations, anastomosing leaks and instant fistulas, up to tune of 5 to 10% when compared to size reduction alone, and the additional oncological complications. And the risk factors of complications are directly related to the extent of the surgery involved. The more number of visible infections and anastomosis, the high chance of complication. And to conclude, the evidence where hypertensive benefit is like interval developing after often CRS or a salvage CRS for recurrent ovarian cancers or advanced stage 3 requiring interval developing after neoadjuvant chemotherapy. Less evidence is for advanced stages of stage 3 and for the upfront lesions. And whatever we can do, the hyper only works only we could achieve only maximum site reduction. So maximum site reduction remains essential for overall survival rates, and adding hyper to it enhances the overall survival benefits. Thank you.
Yes, thank you so much, Dr. Bhavan. Yes, over to the chair.
What's the choice of chemotherapy agent for hyper?
Actually, it is like the dose modification that we are using for upgrade or interval development. The dose is modified to 70% depending upon seriously most of them is just 90. On the same dose, the dose is not intravenous. Generally, we use this around 5 liters of per second, 3 to 7 liters. We can start to do that.
Yes, any questions from the audience? All right. Yes, I request Dr. Bharat Garu, can you please present a memento to Dr. Bhavan. Ladies and gentlemen, all those who are seated here, please stay tuned as we are moving in towards our last speaker for the day. So I request you to please remain seated. Just a matter of a few minutes. Thank you so much, sir. Thank you. So I would now request our last speaker for the day, Dr. Sarita Srivastava, Consultant Medical Oncology, Medicover Cancer Institute, to please step forward, and I request you to please give your presentation on exploring chemotherapy in ovarian cancer from standard regimens to personalized therapy. Over to you.
अरे बैटरी का वैसे
Good evening, everybody. Realizing the time crunch and I just try to keep the topic very short and brief. So most of the surgical aspects have been covered by the previous colleagues. So a few slides regarding the chemotherapeutic management of ovarian cancer. So ovarian cancer is the second most lethal gynecologic malignancy worldwide, and first in the developing countries. A lifetime risk of which happens in the tumor, and most of them, basically ovarian cancer, most of the time we find in advanced stage. 75% of the patients present in stage 3 and stage 4. So pathology-wise, the discussion I focus on epithelial ovarian cancers, which comprise almost 90% of all ovarian cancers. Again, epithelial ovarian cancers are subdivided into serous, which are most common. Serous again divided into low grade and high grade. Then followed by endometrioid, clear cell, mucinous, malignant renal and other histologies. So this is the fever staging which is already covered. So following extensive and exhaustive surgical aspects in the gynecological malignancies, few slides on the pharmacological aspect as well. So the most common agent what we use in management of ovarian cancers are platinum and cisplatin and carboplatin. So how these work is that once they are within the nucleus, they form adducts with the DNA strands, both mono adducts as well as in between the strands, intrastrand as well as interstrand crosslinks. As a result, the cell division gets impaired and cell death happens. Then we have taxanes, the second most common agents used. So taxanes like paclitaxel and docetaxel. So once they are taken up inside the cell, they cause tubular stabilization. As a result, the cell shape, the intracellular transport system, as well as they enter into the nucleus and bind to the mitotic spindle and cause mitotic arrest. As a result, the cell fails to divide as the result it dies. Then we have a few enhanced drug delivery systems. So this is a prototype example, regulated liposomal doxorubicin. So here we have the basic molecule, the chemotherapeutic agent, that is doxorubicin, is within the core of the within the liposome, and then it is surrounded by a lipid phospholipid bilayer. So by this setup helps us enhance water solubility of the drug, escapes the immune mechanism of destruction of the drug, then little less uptake by the normal cells, as a result side effect decreases, enhance uptake in the tumor cell. So as a result, once these kind of drugs, once they are uptaken in the tumor cell, they are digested by lysosomal mediated degradation. The molecule is releases oxygen, free oxygen mediated radicals. As a result, it damages the protein, affects the DNA in the nucleus as well as the mitochondrial DNA. This causes cell killing. Then we have, so these are the chemotherapy agents. So medical oncologists nowadays is more about targeted therapies, precision medicine, etc. So we have bevacizumab. So now ovarian cancer cells express a lot of VEGF receptors, which enhances angiogenesis and promotes the survival of these cells in the body. So VEGF-A is a ligand which binds to these VEGF receptors and causes this mechanism of tumor cell survival. Bevacizumab is a targeted agent. It's a monoclonal antibody which targets the VEGF ligand and prevents it from binding to the VEGF receptor. As a result, the proliferation, survival, migration and vasodilation of the tumor and its microenvironment is affected. Then we have another group of targeted therapy in ovarian cancer, that is PARP inhibitors. So basically PARP are the enzymes which repair single-stranded breaks in the DNA. So once these single-stranded breaks are, if the repair is impaired, when we treat these cells with PARP inhibitors, the repair of single-stranded breaks is impaired. As a result, these single-stranded breaks during cell division are converted to double-stranded DNA breaks. So we have BRCA mutations common in BRCA mutations and HRD mutations common in tumor cells. As a result of which, these double-stranded breaks will not be repaired by the cell. As a result, the tumor cell dies. So treatment with PARP inhibitors, especially in patients who have deficiencies in repair of the double-stranded breaks, results in cell death. As a result, these group of patients especially benefit with PARP inhibitors. Then we have new kid on the block. So these are bevacizumab, as previously mentioned, where it was a monoclonal antibody. Now we have antibody drug conjugates, wherein the antibody targets a specific receptor exclusively expressed by the surface of the cancer cells. So this is mirvetuximab soravtansine. So this was approved almost 1.5 years back in relapsed ovarian cancers, platinum refractory relapsed ovarian cancers. So the molecule essentially consists of an antibody which targets the folate receptor present on the surface of the ovarian cancer cells. So once this antibody is again linked to a cytotoxic payload. So once these molecules are taken up by the cancer cells, again through lysosomal mediated degradation, the active drug is released, and as a result, it causes cell death or cell lysis. So again, enhance selectivity and decrease decrease in the effect of the normal cells. So the therapeutic ratio is increased, more cancer cells and less side effects. This is how the antibody drug conjugates work. So next, how is the natural history of an ovarian cancer patient? So once the patient presents herself and is diagnosed with ovarian cancer, depending on the stage and the disease burden, she may either undergo primary cytoreduction or she may be treated with neoadjuvant chemotherapy, and then when she achieves substantial amount of chemoreduction, surgery. Sometimes even 6 patients is taken up for surgery after 6 complete cycles of chemotherapy. After that, there is a period of disease-free interval following which the disease relapses in almost 60% of the cases, depending on the stage at which patient presents. And then again, depending on the disease burden and the natural course of the disease, patient may be taken up for secondary cytoreduction or may be taken up for further chemotherapy. So a simplified ovarian cancer staging. So stage 1 and 2 is early stage wherein the tumor is confined either to the ovary or it is extending up to the pelvic structure, and stage 3 and 4 are considered advanced, wherein the tumor has spread to the abdomen or involved in the lymph node or presents with distant metastasis. So the prognosis again depends on the stage at which the patient presents. We have 5 ranging between 70 to 90%, and stage 3 and stage 4 is between 20 to 40%. So how we deal with ovarian cancer management? So we first obtain a systemic imaging of the patient and try to stage the disease. So if the patient is in stage 1 or stage 2, patient directly undergoes for cytoreduction, following which patient receives 6 cycles of adjuvant chemotherapy with cisplatin or carboplatin and paclitaxel. In stage 3 or 4, a diagnostic laparoscopy is indicated and decided whether the disease is resectable or not. So if the disease is resectable, patient undergoes cytoreduction, following which patient completes 6 cycles of adjuvant chemotherapy. If the patient is deemed to be unresectable, then patient receives 3 to 4 cycles of neoadjuvant chemotherapy, and then again the scans are repeated to see regarding the operability. So if the patient becomes operable, then she is taken up for surgery, and following which she completes the remaining cycles of chemotherapy. If the patient is with the disease, then change the entire treatment and as a platinum refractory disease with single agent another line of chemotherapy. If there is a cytoreduction, however still surgeon says that no, we need to cytoreduce it further, then patient completes remaining 3 more cycles of chemotherapy and then is taken up for surgery finally. So this is individual management of fetal stage 1 to early epithelial ovarian cancer. The following surgical staging that which is done upfront. We decide the further treatment plan is decided based on the stage of the patient, the histology of the patient, and the grade of the tumor. So for low-grade serous carcinomas presenting with stage 1A, low-grade endometrial carcinomas stage 1A, and expansile mucinous carcinomas stage 1A and 1B, we suggest observation. So low-grade serous carcinoma stage 1B and 1C, clear cell stage 1A to 1C1, low-grade endometrial carcinomas 1B to 1C, expansile mucinous carcinomas 1C, infiltrated mucinous carcinoma stage 1A. Here we consider the option of adjuvant chemotherapy 3 to 6 cycles on an individual basis. Then if the patient has any high-grade tumor, irrespective of the stage, then clear cell carcinoma stage 1C2 and 1C3, infiltrated mucinous 1C3, and any other histotype stage 2. Patient receives definitely 6 cycles of adjuvant chemotherapy. Management of advanced epithelial ovarian cancers. So we deal the possibility of complete cytoreduction. So if the possibility is less, then we obtain adequate tissue, and here we send it for molecular testing. So what is tested? We test the patient for HRD, that is homologous recombination deficiency, and BRCA mutation status. Then after this, patient receives 3 cycles of adjuvant chemotherapy, and again patient is assessed for operability. If patient is deemed to have to be highly resectable upfront, then patient receives primary cytoreductive surgery, and then
the respective specimentation, we request for HRD status as well as germline, as well as a somatic and germline DRCA status, following which patient completes 6 cycles of adjuvant chemotherapy along with or without targeted therapy in the form of bevacizumab. Then, why HRD status and BRCA status is important is because we nowadays we are offering not only chemotherapy but also precision medicine in the form of targeted therapy, bevacizumab and PARP inhibitors to these group of patients. So if on these tests patient is found to be DRCA 1 or 2 mutated, then we don't stop with chemotherapy. Patient receives further maintenance therapy in the form of olaparib for 2 years, which is a PARP inhibitor, or niraparib for 3 years, which is also a PARP inhibitor, or olaparib plus bevacizumab if patient was offered bevacizumab along with chemotherapy. Then if the patient is found to be HRD positive but DRCA negative, then the options are niraparib for 3 years or olaparib and bevacizumab for 2 years. If the patient is found to be DRCA wild type or HRD negative, then the patient completes maintenance bevacizumab or is offered 3 years of niraparib maintenance. Then this was the upfront management, chemotherapeutic aspects of upfront management of ovarian cancers. As mentioned before, 60 to 70% of ovarian cancers do relapse. So based on the timing of the relapse, we divide the disease into platinum-resistant relapse, wherein the disease progression is within 6 months of completing platinum-based regimen. Platinum refractory, when the patient has progressed on chemotherapy, or within 4 to 6 weeks of completing the last platinum dose. And platinum-sensitive relapse, when the disease progression or the disease recurrence happens more than 6 months after completing the last platinum regimen. So once the patient presents with recurrence, the further treatment plan is depending. Advised by supportive care. When the platinum is not the best option, that is in case of platinum resistant or platinum refractory disease, complete site reduction in the during the initial surgery and good performance status of the patient. So this suffices AGO score. So if the AGO score is positive and it is a first relapse, then the patient is considered for secondary site reduction. However, if this score doesn't suffice, then we offer the patient doublet in the form of again platinum plus a complementary combination with or without bevacizumab. If the patient is found to be DRCA positive, following completion of this chemotherapy, patient receives maintenance or PARP inhibition as part of maintenance therapy. So this completes the systemic therapy or anti-neoplastic management of ovarian cancer. So how do we follow up these patients? So we suggest for the first 2 years, the patient visits every 2 to 4 months. For the next 3 years, every 3 to 6 months, and then annually after 5 years. So what we do physical examination, including a pelvic examination as indicated, the imaging as indicated, then CBCs and basic biochemistries, and CA-125 or any other tumor marker if it was elevated at the time of initial presentation. Thank you.
Thank you so much, Dr. Sarita Srivastava. Thank you, ma'am, for the informative session. I request the chair if you could please post any remarks on this.
Of course, audience has thinned out yet, but yes, a lot of things are coming up in medical oncology. But to the extent that we covered is still not clear, but sooner or later we can get it.
With that, we will be concluding this session. So I request Dr. Lakshmi Garu to kindly please present a moment to Dr. Sarita. Yes, let's also give a huge round of applause to our chairpersons here on stage. Thank you so much for patiently listening to all our speakers and posting your remarks as well. Thank you so much, ma'am. Thank you, sir. And yes, ladies and gentlemen, as we conclude this wonderful conclave and update on Women's Oncology 2024, I now would request Mr. Suhankar Mrida, Center Head for Medicover Oncology Institute, right here in Hyderabad, to kindly please propose the word of thanks.
Good evening, everyone. My name is Suhankar. I am the Center Head of Medicover Cancer Institute. I would like to conclude today's enlightening conference updates on Women Oncology 2024. I am honored to extend a heartfelt vote of thanks on behalf of the organizing committee. First of all, I would like to express our profound gratitude to Dr. Satish Garu, Medical Director of Medicover Hospitals Group. Without your conviction and motivation, this event would have not been possible. Your leadership has been instrumental in making this conference a success. I would like to extend my sincere thanks to Dr. Durgesh, Regional Director of Telangana State Medical Hospital, our Department of Surgical Oncology, Dr. Ravichandra Garu, Dr. Anvesh Garu, Dr. Pavan Garu, and the Department of Medical Oncology, Dr. Praveen Garu, Dr. Sarita Ma'am, Dr. Sriram Garu, and Dr. Kiran Garu. Department of Radiation Oncology, Dr. Babia Sir, Dr. Mirza Ali Garu, Dr. Jotwani, Dr. Prabhakar Garu, along with all the members of the organizing committee from Medicover Cancer Institute. Your dedication and hard work been vital in smooth execution of this event. We are deeply honored by the gracious presence of Dr. Shanta Kumari Garu, whose attendance has added great value to our conference. Additionally, a heartfelt thanks to Dr. Sharath Reddy Garu, who has been a constant source of encouragement and motivation for all of us. To our esteemed speakers, presenters, chairpersons, panelists, your participation and insights have greatly enriched our discussions and contributed to the success of this event. I would like to thank our marketing team and corporate support team, especially Arjun, who is the Regional Business Head of Telangana Medical Hospital. His team members including Ramakrishna, Dharmendra and Ishwar Naidu for his tireless efforts. A special mention goes to my administration team including Bishop and Dhanraj, Rajkumar, and everyone from Medicover Cancer Institute who has engaged and made this event possible. I would like to express my appreciation to Prabhalika and Aishwarya, especially, who has been working round the clock to ensure this event goes at the best of its stage. Your dedication is truly commendable. Lastly, I would like to thank our MC, Sharon here, for your wonderful effort to make this event a great success. It was engaging. To our participants, your active engagements and thoughtful questions have enriched our discussions and highlighted the collaborative spirit that drives progress in our field. Your enthusiasm and commitment to learning are the lifeblood of such conferences. Thank you all once again for making updates on Women Oncology 2024 possible and a memorable event. We look forward for such events. We look forward for the same event for 2025 again. Thank you all for your support and encouragement. Thank you.
Thank you so much. Proposing the word of thanks. And yes, ladies and gentlemen, we shall see you next year 2025 for another update on Women's Oncology. Then again, there will be many such conclaves coming up from Medicover. So can we give a huge round of applause for Medicover Hospitals for this wonderful initiative I'm sure so many of you have been enlightened today, and I request the entire team of Medicover to please step forward for a group photo opportunity. Yes, marking it as a grand success. I request the entire Medicover team to please step forward for a group photo opportunity.
I request Dr. Anvesh sir, Dr. Ravichandra sir, Sarita ma'am to please join the photograph. Complete team of Medicover, please join for photograph. Pravarika, Aishwarya. Please assemble at there. So it was a very nice event, and I would like to thank all our Medicover Oncology Institute consultants, Dr. Ravi sir, Dr. Sarita ma'am, Dr. Anvesh sir, for organizing and letting us and giving this opportunity to do Women's Oncology Update 2024. And especially I would like to thank all my teams, all the units of Medicover, starting with Madhapur, Center at Anusha, and marketing at Ishwar Naidu and Dharmender, Oncology Shubhankar, and marketing at Ramakrishna. You can join for the photograph. Meanwhile, I just read out. And KP from MWC, and Balaraju, the marketing head, then Chandanagar, Srikant and Srirangam for giving the good support and making this happen. From Begumpet, I would like to thank Senator Rajkumar and marketing at Vinod. And I would like to thank Kiran from Karimnagar Center Head and marketing at Karnataka. And special thanks to Nizamba Center Head Swami and marketing at Vinay. And from Nellore, we have Dr. Dheeraj and Bindu Bharani Center Heads and Satish Puliganja for extending the support. And my special thanks to Pravarika and Aishwarya for making this happen. Women's Oncology, without your support, it could not have happened. And all the team from Moi, Vishnu, Bharat, Dr. Harish, Dhanraj, Priyanka, Manasa, Rafi, Devi, Rahana, Deepak, thank you all for giving and supporting this event and making this grand success. Please join the photograph. Medicover team, complete team, all units of Medicover, MWC, Madhapur, Moi, please join the photograph. Sharon, please join the photograph. Pravarika, Aishwarya, please join.
Rajshekar. అరిపీద ఒకసారి అవుతాం నేను 5 సెకండ్ రికార్డ్ చేసుకుందా శేఖర్ బాబు ఒక 5 సెకండ్ రికార్డ్ చేసుకున్నాను అంతే తర్వాత నువ్వు ఐడి వెళ్ళిపో బ్రో ఫాస్ట్ రాట్లేదా అరే ఆపు తీసుకున్నాను కొన్ని ఇప్పుడు ఫోటో తీసినా కాప ఫోటో తీసి ఆపిన జరిగి అమ్మటే అరే ఆగురా. నువ్వు వస్తున్నావు నాకు.
I think in the camera you all should say 3 cheers. Hip hip! Hooray! Hip hip! Hip hip! To Medicover and for the grand success of the event.